from Lutz. She's a consultant radiation oncologist from Lutz. Dr. Otene is also a consultant radiation and clinical oncology from Calabar. So he's also not here, but he will join us soon and we'll do that. So, yes, so we will start once, and then the others can join us once they are around, so that we will complete. So, first, I just want to, can we have another mic so that, I want to have a second mic. Okay. Yes, so I'll just give each one of you 2 minutes to just tell us about yourself, where you are, and how did you get into oncology? Anyone, you can start.
Okay, good morning everyone. My name is Dr. Bashir Miriam. I'm a senior registrar at Lagos University Teaching Hospital, Department of Radiation and Clinical Oncology. Our department is situated in the NSIA Lutz Cancer Center. So for me, I got into oncology because I lost a relative to cancer, and that it made me to start reading about the disease quite early on. Before I even finished med school, I had logged on to a good number of research websites, more importantly Cancer Research UK. So I was excited about reading a way of people's mindset of thinking and trying to solve a problem, and I saw that theme basically within cancer research. So that was what really was the research really that drove me into, and I was fortunate to rotate through senior colleagues during my house job. I did my house job in Lutz also, so I was fortunate to rotate among very fantastic senior colleagues. One of them is here in the audience, Dr. Kokola. He was my registrar as a house officer, and they were awesome. My registrars were awesome. Dr. Kokola, Alegi, Okoro, they were fantastic people. Dr. Olukiron. So that also attracted me. So I was like, okay, these people have good vibes now. Let's go. Yeah.
All right. Dr. Njoku.
Good morning, everyone. My name is Dr. Njoku Amarachi. I'm a registrar in University of Benin Teaching Hospital, Benin City. Okay, I picked interest in oncology. Actually, I wanted to be a gynae oncologist, but due to I felt that gynae O&G, they were very malignant in the department. And oncology really looked simple or less malignant because I rotated 1 week in radiation clinical oncology during my house job, and my consultants, they were very nice people and they made the place homely for me. So during my youth service, I met one of the consultants that I wanted to do my service in radiation clinical oncology, and that's Dr. Ikile. And that was the beginning of my journey in radiation clinical oncology. So after my service, I was opportune to write my primaries in radiation clinical oncology, and the university gave me residency. And since then, it has been a very nice place, I can say. And for me, the gynae oncology, it's felt that in radiation clinical oncology, it entails everything. It includes both the gynae oncology aspect, it includes all cancers for me. So I felt like I was in a better place than just sticking to gynae oncology. Thank you.
Thank you very much. So from what I'm hearing, I think contact with practicing oncologists, whether they be in the teaching hospitals or in other fora, I think it's one of the key things that actually sparks interest, and then people also probably maybe having direct or indirect issues with cancer. Maybe like Dr. Bash said, she lost someone and then that actually drove her to that. I don't know how many centers that we have that house officers rotate through oncology. I remembered when we were training in Zaria, they don't send house officers to oncology. So they go through the traditional medicine, surgery, O&G, and pediatrics. So I think probably that's one of the things we can look at so that we'll be able to get more young oncologists on board. You have started training. Dr. Bash, you are a senior resident now. So looking back from when you started your training, what are some of the challenges that you've faced, during this period?
Thank you very much. I think one of the commonest challenges is, first of all, the workforce is not so much, and the fact that a lot of people don't want to come into oncology, but there's a high level of misconception, really, that, okay, oncology, what do you do? Even when you interact with your colleagues in other specialties, surgery, O&G, they're like, oncology, why did you come and do oncology? All your patients almost always die. Where is your fulfillment and all those things? So I think there's not enough awareness, like you hinted, about oncology and the opportunities that this space holds. Because one thing I tell other people is, other specialties, the questions have been answered. If I have a DM patient, I know what to give. I know. So basically, yes, the joy is in seeing your patient come out fine and okay. But I think for oncology, it's a series of questions we're trying ultimately to answer to better people's lives. And we cannot run away from the fact that cancer is becoming a major cause of morbidity and mortality. It's almost something nobody can run away from right now. Either you know somebody that knows somebody that knows somebody that has cancer. So I think workforce really is one challenge. Then the machines, really. I'm opportune to be in one of the most equipped centers in the country, and I can almost confidently say practically every senior resident in the NSI Youth Cancer Center, you can comfortably give your patients to contour. Your consultants can comfortably leave you to contour, run a clinic and contour the patients. Of course, they still go through the contours for purpose of learning and all, they are under training. But because you have that exposure with the machines, a good number of other senior residents might not, or residents don't have that exposure, and that's a minus, especially since we are moving towards 3D and external beam and brachytherapy. Another challenge really is for the teaching aspect. We know we need medical physicists to do that, and we don't have enough medical physicists. That's the truth. We have quite a number at our center, but what about other centers? Do they have enough? How many of them are interested in teaching, and how many? So those are some of the challenges I can hint on for now. Then the brain drain, that's affecting everybody, every specialty.
Yeah, so manpower, teaching, radiation physics, radiation biology. I think there was a series on radiation physics by Arcon, and I think it's because majorly of that. And I'm sure, I don't know how many centers really have people that can teach, particularly radiation biology. We have some centers, most centers will have at least 1 or 2 radiation physics, but radiation biology is also actually a challenge. So, Dr. Amarachi, what are your challenges?
Well, my challenges, or our challenges as residents.
So
in radiation clinical oncology, like she said, most importantly is the manpower. Like of recent, we realized that cancer, like the burden, it's increasing every day. And the loads of patients we have in clinic is also increasing. Like my center, we just have 4 resident doctors, and our patient load it's really high. So it's taking a lot from us. And on that thing too, we have to read, because we have, in as much as we are in training, we still have to read to pass our exams. So we need more manpower. Then in the machines too, we only have brachytherapy in UBTH. And most centers, I don't even know how many centers have the brachytherapy machine, but we don't have the EBRT. Like I'm here, apart from the pre-conference, that's the first time I'm doing contouring since I stepped practicing as a resident doctor. So we still need the machine, because the name of our department is radiation clinical oncology, and that radiation aspect is also important in our training. Then on that aspect that is underestimated in our field is the research aspect. We, the young doctors, want to be involved in this research aspect, and we need to know how to go about it. Like me, I'm really interested in the cancer immunotherapy, but how to go about it is the issue. So they need to put us on board in all these aspects. Thank you.
Yeah, so thank you very much. I think we are all hearing that. Some of our, maybe some things Arcon can do, some Arcon probably may not, like the issue of manpower. People are leaving the country and all that. Issue of getting residents, even the traditional departments, really, they are having a lot of issues getting that. But the research aspect and then the machines and all that, I'm sure Arcon is listening. That's part of why we have patients advocate, policy makers and all that, so that all those things can also be articulated, and then government will also look at that. So so some other people have just joined us. Come. I know, don't worry. I know now. You are part of the person that will. No, so you call Dr. Shimiri and Otene.
Thank you. Good morning, and hope we are having a wonderful time. So we are to answer the question on research, but I think in addition, I would like to get Dr. Sarimiye to come to the front so that if there's any question, she's going to answer on psycho-oncology, because that's another aspect we want to get to people exposed to. So Dr. Foluke Sarimiye, can you please come to the front seats? Okay, I don't know, is Dr. Otene in the house yet? Okay, he's also on his way. Okay, so apart from research, there have been a lot of exposure to that. So psycho-oncology is another aspect that we're looking at a form of holistic approach to management of cancer, and we don't want, our training is clinical and radiology, but then other aspects too are necessary. So we want a situation that you are also well exposed to that, you are grounded, you can, apart from your core training, there is another aspect you should also look into and develop yourself in that. So in due time, Doctor, if you have any question as regards psycho-oncology, feel free to ask her. Then there have been a lot of networking concerning research. We have some faculty in the house. Make use of that opportunity too. So you want
So, Dr. Gaddafi, you're welcome. We'll just give you 2 minutes. Just introduce yourself and then tell us how you got into oncology.
Well, good morning, everybody. All protocols duly observed. I'm Dr. Gaddafi Yusuf, a senior resident from Ahmadu Bello University Teaching Hospital, Zaria. Well, I think I would like to first of all say, if by any chance I can go back and be asked, will I choose oncology as a specialty? I'll say yes, and I will answer 100 times. In fact, I was in a surgical unit for close to 2 years after, as a medical officer, with learning a lot of skills in surgery. And I was in Abuja to write primaries in surgery when I got a call from my boss in Katsina that he proposed me as one of the candidates to be sent for training in radiation oncology. The first thing that came into my mind is, yes, this is where I should go. And God so kind, I was in oncology with no primaries, and I had to put much effort. I had to tell myself, okay, I've chosen oncology and I don't have primaries. So I started with all the support from the department. I was able to write and pass the 2 primaries in one sitting. And I up till to date, I still enjoy the specialty. It's a specialty that is so rare. You will put a lot of impact in the patient, the family as well, and also the community at large. So I have to say some challenges actually. Practicing in Africa, in Nigeria, in northern Nigeria, where we have a lot of challenges that people are unaware about cancer. People are unaware about even the specialty. People among even colleagues will be asking me, why oncology? Why oncology? Where your patients are dying. You know the outcome of the patients. But I do tell them that if we are not in oncology, we can't change the trend. We have to be there to at least see this patient, enlighten the community, and for those that are diagnosed, if we have lots of specialists, we'll be able to make it better. And well, for my center, I have to say it, we have 10 residents in the center, 4 senior residents, although it wasn't like that, but because of the Japa syndrome, things are declining. And we have like 3 consultants in the center. As per training, we get a lot of training from the consultant, the research mentorship. I wish Prof. Adewe is here. I think he supported, like last Arcon, our case report abstract was one of the best case report. Although I felt to some extent that this Arcon we should have presented a paper, but next Arcon will be there.
Yeah, thank you.
Do well. Thank you.
Yeah, so that's great. So finally, I just have one more questions for you, the residents. So I'll just give you like 1 minute each to tell us what do you expect from your mentors, the people that are training you as residents. What are your expectations from your mentors? What are your expectations from Arcon as an association? What is your expectation from government, even as you go through your trainings? And then, of course, you guys are going to be the future consultants. You're going to be the ones that will be training the next generation. So, but now, at this stage, what do you expect from your mentors, Arcon, and the government? So I'll start with you, Dr. Bash.
All right, thank you, sir. So our expectation first from the mentors is, I think, continual exposure to opportunities that sit within and outside the country, and possibly, getting full or partial funding for the residents to attend and present internationally. Because one thing is, when you sit and you read, what your colleagues out there in the abroad basically are doing, what I tell myself is they are no better than me. They might have the opportunity and all that, but they are not better than me. They are not smarter than me. They might be more opportunity than me, but they are not better than me. So if a 4th-year resident in so and so place can do this, I can also do that. So let me also be exposed. And also, but that might not be fully possible as a single person running that. So Arcon as an organization, one thing I'm happy that the best of ASCO came here for this conference. One thing we can also do is to see how we can collaborate to see, okay, per session, let's say aortic conferences that holds every 2 years, can we have 5 residents that go from Nigeria and present 1, 2, 3, 4 papers, and these residents are fully funded or partially funded for the conferences. So basically, I think that's something I want Arcon to also do. And also, if they can repeat the radiobiology lectures, I know the last ones that I held were really impactful. So if they can do maybe every year or so, maybe, or every dispensation, that will help.
5 minutes more.
Okay, in addition to what she has said, mine is, I need to plead with our mentors to have more patience with us. Because for me, coming to radio oncology, it's more like, it's like a different journey altogether. So in learning, they have to actually be more patient with us when it comes to this learning aspect. Then another thing is for the government. We have many patients that the whole cancer burden has been a huge toll on their financial capabilities. But the thing is, they run away from treatment. You could see that most of our patients, their treatments are being protracted because of financial constraint. And at the end of the day, when they don't have the money, they run away from treatment. So they should provide more avenue for our patients to have more free care, because in some other countries out there, that's what they are doing for their cancer patients. Because cancer, it's cost expensive.
All right, thank you. Dr. Gaddafi.
I think my colleague they have all said it all. I would just add that to some extent, I'm the only resident from Zaria that do come for this Arcon. And you can just imagine, I had to put a lot of personal effort for me to be here, because last year I was there. I know how it was. So there is need for, to some extent, our mentors, the Arcon executives to at least see to it that lot of residents, 1/10, I think, is grossly inadequate, because the more exposure we get, the more we learn, the more we make ourselves better. For the government, I think to some extent, the officials may not really be here, but Arcon can convey the message. We actually need more, as per the training, as per sponsorship, as per everything, because the training is in such a way that you cannot practice if you don't have the facilities. If there are no machines, you can't train. Sometimes we want to learn the contours, but my center doesn't do radiotherapy. So you can imagine, even if I learned, I'm not practicing, how will I perfect my skills? So we need more and more.
Excuse me, our time is up. So we'll have just 2-3 minutes for questions, please.
Okay, so I think in addition to what you've said, we are taking this back. The lectures, there's an arrangement both locally and internationally. And I think another thing I want to say is the issue of exchange program. So even if you are not doing internationally, there are centers that does this. Our center in Lagos and there. So I think as a body will support you to have access and the opportunity to visit other centers that have these things working. So I'll hand over the microphone to Dr. Sarimiye to put in 1 or 2 words for psycho-oncology as you round up. Thank you.
Okay, I'll just say that we all know that we are human beings with a soul and a spirit. So as doctors, generally our discipline deals with the physical illness, that is the body. But we all know that there are other aspects that are really important. Prescribing medications to people alone and not dealing with this emotional and the psychological well-being of that person, you wouldn't get the best clinical outcome that we want. So I don't want to belabor the points. We all know how huge the psychosocial burden of cancer patient is. So psycho-oncology is that subspecialty that takes care that handles the psychosocial aspect of oncology care. And it is so important that it's incorporated in the holistic care of cancer management. If you don't do that, one, that will not be the best clinical practice. Then two, we're not going to get the best clinical outcome that we want. And I also want to say that we have an association, Psycho-Oncology Society of Nigeria, which is also part of an international organization, IPOS. And then here in Nigeria, we have an MSc program in psycho-oncology in Ibadan. So I know some of the residents have approached me and talked about interest in it. So we could always talk more on that. Thank you.
Thank you. I think at this point we get questions from the audience. Just 5 minutes.
Yeah. So we'll take questions from the audience.
Okay, good morning. My name is Dr. Debbie Numbara from the River State University Teaching Hospital. Okay, I want to ask, is there any collaboration between Arcon and any of the cancer institutes outside the country? Because last year, my state, River State, commissioned 8 billion naira cancer center, and that has been well equipped. And since then, it has been on lock and key. And we asked, why is this place been on lock and key for a while now? And the main reason was there's no manpower. And that's one of the major reasons why I'm here. In my hospital, River State University Teaching Hospital, we don't have any clinical oncology or radiotherapy. And sometimes we have MDT meeting on cancer, and sometimes the discussion is, can anybody that have knowledge of medical oncology or clinical oncology give an input on the management of this cancer institute area? And the need for the government to train someone or to send someone or collaborate with an institute somewhere else, or to train one or two of our residents, the opportunity is there, but because there's no channel. So I want to ask, is there any collaboration like that? Thank you.
Okay. Thank you. We'll take all the questions first.
Thank you very much for this session. My name is Tolopo Ido from Lagos State University Teaching Hospital, Lagos. I must thank Dr. Sarame for the exposure yesterday. I was really, like, all through my time in medicine in Nigeria so far, yesterday I saw a different dimension to practice of medicine in Nigeria. I'm really impressed. Now, to the residents, okay, taking myself for example, I came from pediatrics. I was medical officer in pediatrics before going into oncology. And oncology entirely is like a different game. Like it's an uncharted water. And considering that the last time I did physics was secondary school, now I have to start learning radiobiology and physics. How did you cope? How were you able to handle that transition? I think I'll pose that at Dr. Bashir. And thank you very much.
Okay, so let me answer for the first question. Okay, there's still an, oh, okay.
My name is Dr. Osita Ezenwosu from UNTH. I'm a pediatrician, pediatric oncologist. Mine is a suggestion on the issue of exchange program or getting some radio oncologists to do some programs outside the shores of this nation. One suggestion I want to make is what we are doing in pediatrics. I know that Arcon may have some products they endorse for some pharmaceutical companies. What we do is that there is one pharmaceutical company that Pediatric Association of Nigeria endorsed their product. And as part of their bargain, they send 2 pediatricians outside to the US for training every year. So I think Arcon can think in that direction and get that kind of arrangement? Thank you.
Okay, I think that's the last question. Thank you so very much, pediatrics oncologist. That's a very good one, and we'll actually explore that option. So the other person that asked question from Rivers State University Teaching Hospital, I think that's not University of Port Harcourt Teaching, is different. So we have an oncologist in University of Port Harcourt Teaching Hospital. So that's in person of Dr. B. So that will be your number one contact, such that from that you can get exposed to most of our NDTs, and then there are the more way we can actually assist you even virtually from wherever we are. So we need I'll try and get your contact, and then we'll explore that option. Another one is the issue of staffing the hospital. So I think that is actually political. If the government that built that place, this is Nigeria, and we know a lot of things goes on. If they are really ready to start the center, there's a lot of PPP, there's a lot of way they can get it done. So it's just to get the political will. I hope they are not just using it to mark the tick check that, okay, they've done this. But the political will is there. There are lots of industries or agencies that can help them with the staffing and stuff like that. Such, even if it's not, they may not get all the staff full time. People have been doing 1 or 2 places and getting resident. That will not be an issue. But at least there's an oncologist in University of Port Harcourt Teaching Hospital. So that will be your plug. I think I'll need to see you, and we'll continue on that. Thank you. So Dr. Bashir, answer your question.
Okay, thank you, Dr. Edowu, for the question. So the truth is, yes, the physics and the radiobiology becomes like a sudden surge of breeze, like, okay, this is different, but you just sort of like have to find a way around it. For me, I think the trick is to start early. One thing was then, especially for the radiobiology, our senior colleagues made us do presentations for it. So then when we started, it was like, these guys are stressing me and all that. But when it was closer to the exam, I saw the worth of it, because once you do presentations early, you have the slides. You can go back and read the slides. The thing with radiobiology is everything doesn't come at once. So you have to go back and go back and go back and disturb your seniors, basically. Say, okay, Chief, I read this thing. I don't understand it. Then when it's before exam, another thing is, what you can do is you can join discussions. What I used to do was, let's say I know I'm going to write my exam in April 2024. So I joined the discussions of people that are writing exam in October 2023. So I know the tandem of how the discussions hold. That's the exam candidate. I'm in the background, I'm listening, I understand how they answer questions. So when it's time for the exam, at least I'm already used to it to an extent. Then for people who are familiar with physics, I had to meet with some of my senior colleagues within the center and even outside from the north. Dr. Umar is here.
Thank you so much.
He really helped out with that.
Thank you so much.
All right, so thank you very much. I think this is where we'll end. Thank you very much. Picture, okay.
Where's our official photographer? Okay. So good morning, everyone. I hope we are well rested. This is the day 3 of the scientific session, and well, it's the whole experience is gradually coming to an end. We'll miss everyone, and I'm sure all the sessions have been very, very impactful. So the next session would be Best of ASCO. It would be handled by Professor Bello and Dr. Alabi. Could we kindly have you up front? I think our IT guys are ready. So the session All right, so the session will take roughly 30 minutes, 15 minutes for each speaker. Please have your questions written down so at the end of the session you would, ask them.
Thank you
so
very
Bello,
much.
You can start.
Good morning, everyone, and welcome to the last day of Arcon Inugu Amaka. And so today, this morning, on the best of ASCO, we'll be talking about prostate cancer, basically. Most of the time, we've been talking about other things. Today, we'll be talking about prostate cancer, fundamentally. So we picked two abstracts. There are two abstracts that we'll be looking at. I will be discussing the first one, and Dr. Alabi will discuss the second one. Basically, these are related to prostate cancer studies. The first one I will talk on the value of PSA, actually as a surrogate in determining metastatic free survival for patients that have actually received treatment for early prostate cancer. This is not something that we see all the time, but when you treat patients So this abstract is on the prognostic impact of the PSA nadir above 0.1 nanogram per ml within 6 months after completion of radiotherapy for localized prostate cancer and individual patient data analysis of randomized trials from the ICECAP collaborative. So this was their disclosures, and as a background, we know that radiotherapy and androgen deprivation therapy is the standard of care in treatment of intermediate and high-risk prostate cancer. Maybe this may be changing now for high risk especially, but anyway. So development of surrogate measures of metastatic free survival and overall survival could help in trial designs to evaluate new systemic therapies with ADT and radiation therapy. And a PSA of over 0.1 or over 0.5 nanogram per deciliter after neoadjuvant ADT and after 3 to 6 months of radiotherapy completion has shown prognostic value in retrospective studies and randomized trials. So this is the largest analysis, which comprised of over 2,400 patients treated with radiotherapy and short-term androgen deprivation therapy. So this ICECAP stands for Intermediate Clinical Endpoint in Cancer of the Prostate, and collected individual patient data from over 40 randomized trials in localized prostate cancers between 1987 and 2016. So there are a couple of publications that have validated the development of intermediate clinical trial endpoints in prostate cancer. So establishing surrogacy metastatic free survival has been shown to be a strong surrogate of overall survival in local prostate cancer. This is one of the publications by Z et al. On the Journal of Clinical Oncology that was published in 2017. So the objective of the study is to leverage on the ISPAC individual patients' data repository and evaluate the prognostic impact of PSA at 6 months after radiotherapy completion in patients receiving radiotherapy and short-term ADT, and radiotherapy and long-term ADT on metastatic free survival and prostate cancer specific mortality and overall survival. So the other objective is, can PSA at 6 months after radiation therapy be viable to serve as an intermediate endpoint to expedite conduct of clinical trials? So this was the method. Repositories were collected for patients that had only radiotherapy alone, radiotherapy and short-term ADT, that is 3 to 6 months, and radiotherapy and long-term ADT, that is between 24 to 36 months. And the lowest PSA within 6 months after completion of radiotherapy was also assessed. The cut point of 0.1 nanogram per deciliter, choosing to reflect the lower limit of assay detected in that era. The endpoints, as I mentioned, are metastatic free survival and prostate cancer specific mortality, as well as overall survival. So multivariate cause proportional hazard regression to estimate the hazard ratio for the metastatic free survival and overall survival were done, as well as models to adjust for age, performance status, and staging, Gleason score, and PSA. So the flow diagram of patients inclusion: 22 radiotherapy-based trials in the repository, consisting of 13,838 patients were included, which included about 16 trials, and which account for about 10,600 patients. And then, of course, we had some exclusion criteria as well. I will not go into the details. So these are the patient's characteristics. The year of the randomization, like we mentioned, from 1987 to 2011. The median age is about 70 in the overall arm. In the arm of the radiotherapy alone, it was still 70, while those in the short-term ADT and radiotherapy, the median age was 69, while that of radiotherapy and long-term ADT, it's about 70 as well. The NCCN risk stratification group, you can see that the very low, I must say, I think, it's about 1,100, while high risk account for 5,726 overall. So this is basically the stratification. I will not bore you more than this. Okay, so the PSA at 6 months after radiotherapy and long-term outcome, you can see that the 5-year metastatic-free survival for PSA that is less than 0.1 nanogram per deciliter is in the case of radiotherapy alone is about 91%. In the short term of ADT and radiotherapy, it's about 83%, while for the long term it's about 87%. The 10 years overall survival for the radiotherapy alone arm is about 52%, while that of the short-term ADT and radiotherapy is about 62%, and that of the long-term is about 63%. So there is no real significant difference in terms of the 10-year overall survival for the ADT, whether it's short-term or it's long-term, on this study. The 10 years prostate cancer specific mortality for patients that have a nadir of less than 0.1 accounts for about 10% in the radiotherapy arm alone, and about 6% in the radiotherapy with the short-term ADT, and 7% in radiotherapy with the long-term ADT. But for patients that have a PSA nadir of less than 0.1 or equals to 0.1 nanogram per mil, radiotherapy alone is higher, about 12%, and radiotherapy and short-term ADT is about 13%, and even with the long-term ADT and radiotherapy is about 12%. So this is basically the outcome comparing patients that have a higher 0.1 PSA at the cutoff and those that have less than. You can see the difference in terms of metastatic-free survival as well as overall survival as well.
5 more minutes.
So what is the interpretation? So this is the largest assessment of the prognostic impact of PSA at 6 months after radiotherapy in patients receiving radiotherapy and radiotherapy with ADT for localized prostate cancer, and the PSA nadir of less than or equal to 0.1 nanogram per mil at 6 months after radiotherapy completion strongly prognosticate for metastatic-free survival, prostate cancer-specific mortality, as well as patient overall survival. So we have looked at patients treated with radiotherapy alone as well as with ADT. Of course, you know that the trial talked about the PSA at 6 months post-radiotherapy, and there was escalation if the PSA is over 0.1 and de-escalation if it is 0 less than that. So what are the strengths and the limitation of the study? The availability of the individual patients' data from randomized trials, the largest independent patients' data evaluation to date of the prognostic impact of landmark PSA for both radiotherapy arm as well as radiotherapy and ADT, and robust association of PSA with all 3 long-term outcome measures. These are mostly the strengths, and of course the limitations are small number for radiotherapy alone, which has been alluded to. Few patients achieve PSA of less than 0.1 nanogram per deciliter, and they could not evaluate trial level surrogacy, and future work need to be done. And most men treated before 2000 and wide span of treatment errors. So in conclusion, PSA of less than or equal to 0.1 nanogram per mil within 6 months after radiotherapy completion is highly prognostic for metastatic-free survival, prostate cancer-specific mortality, and overall survival in men receiving radiotherapy with or without ADT for localized prostate cancer. Aid in counseling patients treated with radiotherapy and ADT in routine practice, and implication for adjuvant trial design evaluating novel systemic therapies with radiotherapy and ADT and the intensification approach. So thank you very much. I will call on Dr. Alabi, then she will talk on the irradiation. And after we can have a few questions, please.
So thank you very much.
Thank you, Dr.
We have a third presenter online. She'll be joining us online, Dr. Mrs. Ezome.
Okay.
She has special interest in gynae oncology. So after Dr. Alabi, Dr. Mrs. Ezome will join us online. You can go ahead now.
Okay. Good morning, everyone. Best of ASCO. I would like to stand on all existing protocols. From the last, I'm waiting for my slides to come up. From the last discussion, one of the take-home points for me is that when we see patients which have just had radiotherapy, we want to think that when they come with their PSA having dropped to maybe 23, you are happy. The next PSA drops to 15, you are excited. The next one drops to 1, you are excited. So your excitement is only short-lived because the prognosis for the patient is not good. So what you expect is that the PSA should drop to as less than 1. When you have that, that is when you can say that the patient is going to have a good prognosis after like 10 years. So, and what it helps us, or the information it gives us, is whether you want to escalate the treatment for that patient or you want to increase what you are doing. Okay, so my slides are here now. I'll be looking at the PEACE trial. The PEACE 1 trial is more of an European prostate cancer study. And they looked at about 1,173 patients over a period of about 5 years. They randomized them. 7 European countries were involved. They randomized them, and Albert Bossi was the lead for this study. And the background comes from the fact that we've had to evolve over time with treatment of prostate cancer, from doing ADT alone to doing ADT and docetaxel, to doing ADT, abiraterone, acetate with prednisolone, and then we moved on to doing ADT radiotherapy for low burden disease, and then we went to ADT NHT for non-steroidal hormonal therapy using apalutamide and enzalutamide. Then we went to what we call the systemic triplet, having to combine ADT, abiraterone acetate, and radiotherapy. So this is all about use of the NHT as well. So over the years, this has evolved. So this selection of patients were patients who have what we call de novo metastatic castrate-sensitive prostate cancer, meaning that patients who are presenting for the first time with metastatic disease who have not had any treatment. And the key eligibility criteria was distant metastatic disease, de novo metastatic castrate-sensitive prostate cancer, distant metastatic disease with greater than 1 lesion on bone scan or CT scan, with good performance status, ECOG 0 to 2. On study requirements, some patients who had started ADT 3 months prior to study were also included. They were permitted to start the study. And then the patients were also stratified based on what they will have. So the randomization had to do with patients 1 to 1 to 1 to 1, divided into 4 categories. Patients who have had, who were put on ADT either or with bilateral orchidectomy, those with or without docetaxel, those who had or did not have radiotherapy in another arm. So we had 4 different arms. And over a 5-year period, 2013 to 2018, the standard of care for the treatment was to use ADT with continuously use LHRH agonist or antagonist or bilateral orchidectomy with docetaxel, 75 milligram per meter squared, 6 cycles. Radiotherapy here was defined as 74 gray over 37 fractions. And then abiraterone was used as 1,000 milligram per meter squared in combination with prednisolone. The core primary endpoint for this study was to look at radiographic progression-free survival and overall survival. We also had secondary endpoints here. There were quite a lot of things they looked at, which will be seen in the analysis of the results. So, but the most significant things that they wanted to point out were the castration-resistant free survival, the serious genitourinary event-free survival, and toxicity for the patient. So statistical analysis were done. A 2-sided survey was done for them, and expected events were also seen. Okay, so patient characteristics, these were the things that they looked out for the patient's characteristics in evaluating in association with the results of the study. So for the low volume population, they also had these characteristics: median age, ECOG score, Gleason score, median time from diagnosis, metastatic sites, which could be lymph nodes or bone only, and whether they had docetaxel or not. For the radiographic progression-free survival for the low volume population, patients who had a combination of SOC. SOC is the standard of care of that institution based on what they practice, which could be patients are given ADT plus or minus radiotherapy with docetaxel, or the patient had ADT with radiotherapy and abiraterone. So all these were considered for each institution, and they analyzed it based on that. And so for the patients who had radiographic progression-free survival, a higher number of them were those who had SOC with abiraterone and radiotherapy. This just buttresses the fact that sometimes, even with the low volume population of metastatic disease, radiotherapy may still have a role to play for these patients. Then for the overall survival, there was just marginal increase, but the patients who had a combination of standard of care with abiraterone and radiotherapy just had the p-value was 0.86, and the overall survival was 7.5 as compared to 6.9 years for the median years of survival. So for the overall survival for the low volume population, the patients who were in the class of the SOC with abiraterone and radiotherapy also still had a good overall survival compared to the others. The serious genitourinary event, the time to the event was actually captured here so that they could evaluate the patient and see what the outcome would be. Patients without serious genitourinary events were more for those who had SOC plus abiraterone and radiotherapy. And if you look at the global p-value, it was significantly significance was really, really good. So which showed that use of the SOC with abiraterone and radiotherapy was did not give much side effect. This is also the time to serious genitourinary events. Then castration resistance free survival. The patients who also had standard of care, abiraterone and radiotherapy, they had a higher castration resistance-free survival. So this was also significant for this population of patients. So in terms of toxicity, so these were the safety profiles that they found. Hypertension, neutropenia, febrile neutropenia, hepatotoxicity, fatigue, gastrointestinal disorders, rectal hemorrhage. And they looked at patients who had SOC with abiraterone, those who had SOC, abiraterone, and radiotherapy. The patients with SOC plus or minus abiraterone and radiotherapy had a higher population with hypertension, but the one that stood out for them which they were particularly interested in were those with gastrointestinal disorders. And even though the difference wasn't so much, 3% had gastrointestinal disorders from the SOC, abiraterone, and the radiotherapy group. So in conclusion, combining prostate radiotherapy with intensified systemic treatment, abiraterone with or without docetaxel improves radiologic progression-free survival and castrate-resistant progression-free survival in men with low-burden de novo metastatic castrate-sensitive prostate cancer. No detectable impact of prostate radiotherapy on overall survival, with minimal added toxicity. So it just means that we can be a bit more aggressive with our patients' treatment, but we should know that the endpoint we're getting for those patients may not really translate to improved overall survival, but we'll be able to give them a better quality of life, and which I think is also an important goal for our patients' treatment. And so for the first time ever, the PEACE 1 trial has established a role of radiotherapy in the prevention of serious genitourinary events, irrespective of the metastatic burden. This is the main take-home point for this clinical trial. Then a triplet of ADT, abiraterone, prostate radiotherapy should be considered a standard of care in men who have de novo low-burden metastatic castrate-sensitive prostate cancer. Radiotherapy may also be considered in selected men with de novo high-burden metastatic castrate-sensitive prostate cancer. We call that the quadruplet therapy. So we now have what we call the triplet systemic therapy and the quadruplet systemic therapy. We need to stratify the patients to know who benefits from what. These are the people who they acknowledged that contributed to the study. Thank you, everyone.
Thank you. Thank you very much, Dr. Alabi. So I think we can quickly, so please, like I said, please just jot down your questions and we'll take them at the end of the session. So we have the last presenter for this session, and she's online. Dr. Mrs. Ezome, are you online? Have you joined us? Dr. Mrs. Ezome, you are on. Our IT team, could you kindly unmute Dr. Mrs. Ezome, our next speaker? Okay, let's just give a few minutes. So do we have questions as we wait for her to prepare? Okay.
Thank you, the two speakers. Let's come back home. We all know, even for normal individuals, our PSA value can range from 0 to 4. Isn't it? And if you want your patients to get to 0.1, like Mrs. Dr. Alabi said, do we take into consideration the state, whether this patient will be as stressed or not, whether the patient is sexually active at that point in time or not? What I just want to get straight is, if you want to get to that 0.1 for our environment, the black populace, because these studies took place over there, are we not going too far that you want to get to that 0 or below 0.1? This is my, please, the two of you can respond.
Thank you.
Answer? I should answer?
No, I have my question for... Okay, thank you to the presenters for a wonderful presentation. My question is for Dr. Alabi. I don't know, I thought the triplet therapy in prostate cancer was using docetaxel and ARTA and ADT. So, but now you're talking of triplets, saying it's radiotherapy replacing the docetaxel. Sorry, did you? Yeah, so you're talking about triplet therapy, and instead of docetaxel, it's radiotherapy that's been stated here. I don't know if things have changed. Thank you.
Thank you very much, Professor Olasinde. I mean, this was probably a retrospective study, and one of the key reasons why they are looking at that NADR of 0.1 is to develop a surrogacy that will determine metastatic-free survival for patients. So something like a predictive marker at 6 months after those treatments. What exactly could they use to predict if the patient will have a higher metastatic-free survival or not? And mark you, sir, this is for local early prostate cancers. Now, having said this, even in our environment, sir, we do get patients that get to that NADR of 0.00. By the time you are treating prostate cancer, I think sexuality is something you really need to discuss with the patient, whether they really want to treat their disease or they want to maintain their sexuality. So for me, what I usually do is I explain to them that at that age of 70, 60 and above, sexuality is not really a very key thing. However, for patients that are really having a very younger age, maybe as we get our patients at the age of 40, 45, it may be of serious concern, but regardless, we should be able to achieve this kind of NADR of 0.1. So it's an individual thing you need to discuss with the patient. This is one of the conclusions that you really need to discuss with your patients on the need to bring down as much as possible the PSA so that he can have a long overall survival as well as metastatic-free survival. I hope that answers your questions.
Thank you. Thank you, Professor, for that question. I'll just make one more comment about it. So now we have to tell the patients to choose what they want. Do they want to do well, or they want to preserve their libido? And many of the mistakes that we have been making, which I think we should start correcting, is not checking their erectile dysfunction even prior to radiotherapy. There's actually an NCCN application that helps us to actually check it which we can also use for medical legal reasons too, if it comes up after you have radiated the patient and the patient comes and says he has lost his libido. So we should actually assess their libido function, their erectile dysfunction before we start radiotherapy. And getting that nadir, not until we did our study recently at our center that I discovered that we actually get a lot of patients that fall into that category of getting less than 0.1. So, but because we've not been taking data, that's why we don't know. And we have a few who probably ab initio before their radiotherapy, their PSA was low as 23, and you are finishing radiotherapy and you are not achieving that nadir. So what this just simply tells us is like they have created a model for us to be able to use to prognosticate how our patients will respond to treatment in the near or future to come. And so it now tells you, do you want to add ADT? Because they said there's short-term, there's long-term ADT. So do you want to increase ADT for this particular patient who, after 6 months, does not have a nadir of 0.1? So you may want to now increase the ADT for that patient to be longer, so that you may just be able to help the patient to have an improved overall survival. Then I'll go to Dr. Ella's question. So honestly speaking, when I saw this trial, I had to go back also to check that this is not what I know of triplet therapy. So the NCCN guideline, that is what NCCN guideline calls the triplet therapy. So, but for their own study, this is what they call the triplet therapy. But Dr. Bello is making me to understand now, I'm just hearing now, that NCCN guideline has also incorporated this new one into the guideline. So, well, I think it's just from the name, triplet therapy means that you are combining 3 different types of treatment. That is the summary of what I'm getting from here, that you are combining 3 different things. What the 3 different things are may be different. Thank you very much.
Okay, let me just quickly add to this. You know, the NCCN guideline also has templates for treatment options, right? I think the parent guideline has actually incorporated the novel hormonal therapies, that is whether you're using abiraterone or enzalutamide, as part of the treatment standard of care for metastatic castration sensitive prostate cancers, right? So yes, they are part of the templates, but the harmonized guideline for sub-Saharan Africa, which I chair actually, has not actually included the use of the quadruplet treatment. We are looking at what is available in the cost implication of adding abiraterone or enzalutamide to the already financial toxicity that our patients actually have. But yes, after the peace trial, a lot of work has been done, and now it is becoming the standard of care for metastatic castration-sensitive prostate cancers to also include the novel hormonal therapies, that is enzalutamide or abiraterone, plus radiotherapy, ADT, and docetaxel as standard of care.
So I think that's okay. Just one more. Could you please make your question brief? Thank you. So please, the presenters for the next session should please get ready. The presenters are Professor Modi, Dr. Adedayo Joseph, Child Representative Paulette.
Good morning. My name is Dr. Ogechi Sylvia Eze. I'm a GP in the UK, but I'm actually around, so I registered for this conference, and I must say thank you so much. It's really enlightening. My question goes to Professor Alabi, the second speaker. It's about the role of where does palliative care come in? Because where I work, there is so much emphasis on palliative care because they put so much emphasis on the quality of life, especially when the cancer is already metastasized. Does this therapy still apply for those who want just to be cared for? You know, they don't want any active treatment. And also, the topic talks about equity in oncology. one thing we've come to notice, even in the UK now, with this JAPA trend, so many people are coming, and most of them don't even really speak English. So there's so much work being done in translating the medical terminology so that patients can understand. In the area of cancer care, I wonder if we really have got the language to make healthcare accessible and equitable to patients. So how do we go about explaining things like radiation, the side effects, and, you know, so that they can be carried along and understand? Thank you. Thank you.
Okay, so my boss was just telling me now that it's a bit beyond the scope of this discussion. So, but I'll just say one or two things. So we call something individualized patient treatment, which that comes to play. Even above all what we have said, financial toxicity is a great problem. So, but we still need to know what is ideal for our patients. We need to know that sometimes you can even actually go the extra mile of giving them everything and still get a good outcome. So that's how I'll summarize it. Thank you very much.
Thank you so much. Please, a round of applause for our erudite speakers. Thank you so much. So we'll quickly move on to the next presenter. I learned she has joined us now. She's online. So Dr. Mrs. Ezome, if you can hear us, the floor is yours. Go ahead, ma. Please unmute her, IT. Dr. Mrs. Ijoma Ezome, that's the name online. So, ma,
am I being heard?
Okay. Yes, ma, we can hear you. Go ahead, ma. Good morning.
Hello?
Yes, ma, go ahead. Good morning, we can hear you.
You are being heard. Am I being heard?
You are being heard, ma. We can hear you, ma.
Okay, good morning, everyone.
Good morning.
Sorry,
good morning.
I was supposed to present the abstract on the best of ASCO. So I'll just share my slides. I'm very happy to be here to take part in this your conference. Are you seeing my screen, please?
Yes, ma, we can.
Right, thank you very much. So I'll be presenting a study by Marie Plate et al., which is an international randomized phase 3 trial comparing radical hysterectomy and pelvic node dissection versus simple hysterectomy and pelvic node dissection in patients with risk early stage cervical cancer. This presentation was done in 2023 ASCO annual meeting. It was presented then. So, as a form of introduction, cancer of the cervix is the second leading cause of cancer death in women worldwide, and because in developed countries they already have effective screening, they find out that most of their women present at a younger and with low risk disease, usually early stage disease. And even though radical hysterectomy, what we know as veteran hysterectomy when we were training, is highly effective for the treatment of early stage disease. Of course, radical hysterectomy will be associated with what we term survivorship effects due to long-term surgical side effects involving the bladder, the bowel, as well as sexual dysfunction. So when we talk of radical hysterectomy, we're talking about removal of the uterus, the tubes and the ovaries, as well as parts of the parametrium and the upper vagina. whereas in simple hysterectomy, what we just do is to remove the uterus, including the cervix. A number of studies have been done previously through 1995 to 2009, in which they found out that with low-risk disease, that even going ahead, that parametrial involvement in low-risk disease is very low, okay? Even though these were all retrospective data. So because of that, the question is whether less radical surgery, is it not a safer option that is associated with decreased morbidity, so that they were suggesting surgical de-escalation. So the hypothesis in their trial was that less radical surgery, that is simple hysterectomy, will be associated with similar efficacy and less surgical morbidity compared to radical hysterectomy in patients with low-risk disease. So they had two arms, the control as well as the experimental arm. In the control arm, that was the radical hysterectomy arm, and the experimental arm was the simple hysterectomy arm. In both arms, with radical hysterectomy, there was always associated pelvic lymph node dissection, both in the radical hysterectomy and the simple hysterectomy arm. So their primary endpoint was pelvic recurrence rate at 3 years, while their secondary endpoints were pelvic relapse-free survival, extra-pelvic relapse-free survival, relapse-free survival, overall survival, as well as patient-reported outcomes. So they had a total of 700 patients randomized. And they were followed up for a minimum of 3 years. The study had about 85% power. So this is just a schemata of how the randomization took place, as well as eventually they ended up with less than the 350 per arm, 317 per protocol in the control arm, and 312 in the other arm. So these are the key baseline patient characteristics. Most of the patients, if you look at it well, you see that they were quite similar. Both their ages were, median age was 42, 45 here, less than 50 years old, to 77.4%, by 70.3. So basically, the control arm, both the control as well as the experimental arm were quite similar. When we talk about the early stage disease, what they were looking at was those that were in stage 1A2 and 1B1, okay? Even though, of course, in our environment, we rarely have patients presenting at this very low, these very early stages. In terms of the surgical approach, they went through either the simple hysterectomy, it was either abdominal, laparoscopic, robotic, or vaginal. They also did sentinel node mapping, while for both arms. So, but what we have to see is that in terms of whether they did simple hysterectomy or radical hysterectomy, the p-values were basically the same. It was insignificant. When they looked at the key post-surgical findings on final pathology, they found out that residual cervical cancer that was detected in following simple hysterectomy, there was no significant difference. Whether there was lymphovascular space invasion, there was no significant difference in both arms. Positive nodes, positive vaginal margins, even whether there was the margins had in the parametrium, whether the margins were positive, there was little or no difference, except for a positive parametrium. That one was significant, but in the other ones, there was no significant difference, whether it was simple hysterectomy or radical hysterectomy. Even when the patients were now treated post-surgically, adjuvant post-operative treatment, even for those who did in total, when they looked at, there was little or no significant difference, even at that. In terms of survivorship, you find out that in simple hysterectomy, cervical cancer, 4 of them, while 1 died in radical hysterectomy, other primary malignancies, the difference was not really that significant. So the primary endpoint, which is pelvic recurrence rate at 3 years, in simple hysterectomy was 2.52%, radical hysterectomy 2.17%, giving us a difference of 0.35%. Okay. With regards to the secondary efficacy endpoints, we see that the p-value comparing the simple and the radical hysterectomy the p-value was 0.79, showing that it was not significant. In terms of overall survival, we can see 99.1%, 99.4%, comparatively, little or no difference. And in terms of intraoperative injuries, we find out that the nerve injury, bowel, vein, and others, their p-values were, there was no significant difference, even though comparatively there was more injury to the bladder and the ureter in the radical hysterectomy arm. So this is a slide showing us other adverse events that occurred post-surgery. We could see that it was urinary incontinence and urinary retention were higher in the radical hysterectomy arm within 4 weeks of the surgery. Whereas, and in addition, even after 4 weeks of the surgery, that is late complications, they were still much higher. We also checked the quality of life and sexual health using validated questionnaires at different endpoints, both at 3, 6, 12, 24, and 36 months after surgery. So significant differences were seen between the two groups over time, and all were in favor of the simple hysterectomy group. The sexual vaginal functioning there was also a significant difference, and that which was worse in the radical hysterectomy arm. So if we look at this slide, you see that the simple hysterectomy had better level of sexual function, while the radical hysterectomy had a greater level of sexual related distress. So to conclude, they found out that in early stage low-risk cervical cancer, pelvic recurrence rate at 3 years with simple hysterectomy wasn't inferior to radical hysterectomy. Of course, with simple hysterectomy, there were fewer urological surgical complications, and there was better quality of life and sexual health measures following simple hysterectomy. Therefore, they said that following adequate or rigorous preoperative assessment, simple hysterectomy can now be considered the new standard of care for patients with low-risk early-stage cervical cancer, which of course supports the concept of surgical de-escalation in those patients. So if our patients come early enough, we can, rather than go through the veterans hysterectomy as we had been taught earlier, it is now better to do simple hysterectomy because the quality, there is little or no difference between both surgical methods, whereas radical hysterectomy will have more complications. Thank you very much.
Thank you so much, Prof, for keeping to time. So I'll take home simple hysterectomy is not inferior to radical hysterectomy. Do we have any questions for her? Do we have any questions for Dr. Mrs. Ezeome? Okay. All right, there's one question.
Good morning, everyone. So, thank you, Dr. Ezeome, for the lecture. I'm Dr. Oyekon. My question is bringing down this study that was done saying simple hysterectomy is not inferior to radical hysterectomy. Bringing it home to our environment where we have a lot of patients have had surgery by people that are not trained gynecologists, and they don't know the nitty-gritty of a surgical oncology. I mean, should we accept the standard of the surgery that they have done to be adequate for this patient to get the desired outcome? Thank you.
Dr. Ezeome, did you get the question?
Hello, are you hearing me?
Yes, we can, loud and clear.
Yes, ma'am.
Okay. Yes, your question was that should we accept the fact that simple and radical hysterectomy are at par in terms of managing our patients? Remember that what we're talking about here is early stage disease. Rarely do these our patients present with early stage disease. So that what this study in their environment, yes, a lot of their women, because cervical screening has become commonplace in their environment, most of their patients will rarely have cervical cancer, and those who have it will come with very early stage disease. And so the teaching, as we know it, is that we should go ahead and do radical hysterectomy if we happen to meet such a patient here in our environment. But frankly speaking, what do we generally do when we see a patient that comes? We do a pap smear, and the pap smear is maybe positive for for dysplasia, maybe 3 or 4 pluses. What do we generally do in our environment? We go ahead and most people do a simple hysterectomy, and that is the truth of the matter. So I believe that even bringing their study down to our environment, we might not be able to do this study in our environment because most of our patients will come with late stage disease, stage 2B and above. So what they're saying is that should we meet such early stage disease, that we can go ahead and do simple hysterectomy, because doing radical hysterectomy will give the woman much more surgical, post-surgical complications. And I do agree with that, Dr. Oyekon. So it's not a question of whether in town they do hysterectomy or not. Of course, those cases that present to gynecologists in the, gynecologists that are not oncologists, at the stages they come, ideally they should be referred to the gynae oncologist. So I don't know if you understand my point or whether I've answered your question.
Yes, ma'am. It's well understood. So can we take the next question?
Thank you very much. So this is more of a comment than a question. Professor Ome, there is, what I noticed over time for more than 10 years in this practice is that some gynecologists seem actually not to understand this issue of simple hysterectomy and radical hysterectomy. We've seen cases severally where they leave the cervix there, see a cervix, thinking that it's early stage, and they leave the cervix there in the name of doing simple hysterectomy. Like with that, they actually worsen the cases. Secondly, even when they remove the cervix in doing either simple or radical, the problem now is that the patients are not well staged. You might be thinking this is stage 1, and if you don't have access to very good diagnostic facilities, you just end up cutting through the cervix. And that's why I would rather refer to stage 1A or B, whatsoever, to say it's actually at least stage this. Because sometimes these patients are actually stage 2, because one doesn't have those facilities. So it's a good presentation, and we actually know there is a place for surgery in early stage CA cervix. However, quite a number of gynecologists make mistakes, and we see that, especially those in private practice. But unfortunately or interestingly, is that I have seen surgeons, gynecologists in teaching hospitals in Nigeria making this mistake. Of course, the patient ends up with us. They actually don't go back to them. So they may actually not know what actually they have done. So please, we encourage getting a very good workout. But of course, I know that quite a number of them don't actually subject the patients to investigations like CT and MRI before surgery. And in doing so, they actually end up making a lot of mistakes, cutting through patients with stages more than those stage 1A and 1B that they think it is. Thank you very much. And sorry, please, before I finish, I would like these patients to actually be referred to the oncologist. Despite the fact that it is stage 1A, those patients should be referred to the oncologist for adjuvant treatment. Thank you very much.
Thank you, Dr. Ezeome, for your presentation. In line with what Prof. Adamu said, sometimes even when they tell you they did radical hysterectomy, there is no pelvic lymph node dissection. I can't remember when last I saw any histology report that stated anything about lymph nodes dissection in the country, even after they tell you they did radical hysterectomy.
Hello? Yeah. So, Ma, the questions have been, the question and the comment, do you have any response? Hello, Ma?
One for your comments.
Yes.
I do agree with the last speaker, I think Professor Adamu, on the fact that all patients who come, whether in general practice or perhaps to gynecologists, should be sent to the gynae oncologists so that they will do a proper staging. Because even though we're talking of stage 1B and 1B1 and 1A2, not many practitioners, general practitioners or ordinary gynecologists, if we can put it that way, are able to even stage the disease. So it's always better for the oncologists to be the ones that manage these patients. this presentation is for gynae oncologists. Of course, we're not even, the presentation is not necessarily telling general practitioners or ordinary gynecologists to go ahead and do a simple hysterectomy, because they may not be able to, they may not even know what it entails to do, because just like the last speaker said, most of the time they don't do any pelvic lymph node dissection. So whether you do simple or radical, you're supposed to go ahead and do pelvic lymph node dissection, because even in stage 1, already there is pelvic node involvement. Thank you very much.
Thank you so much, Ma, for honoring our invitation. We've learned a lot. Thank you. So we'll move quickly to the next session, which is the pediatric oncology session. So please, the speakers, can we have you up here? Unfortunately, I learned that Prof. Imodi would not join us, but she's ably represented by Dr. Ezenwosu. So Dr. Adedayo Joseph, Paulette Ibekwe from CHAI, could you please join us up front here? Dr. Adedayo Joseph will take the first presenter. So, okay. It's Paulette Ibeka. So it will be 10 minutes per presentation. 10 minutes. 10 minutes each. So we're on.
All right, so good morning, and thank you everyone for being here. I will try to help you stay awake through this. I know pediatrics is not everyone's areas of interest, but I hope at least we will all agree on a couple of points by the time I finish talking. So again, my name is Adedayo Joseph. I'm a clinical radiation oncologist and a pediatric radiation oncologist. And I head the pediatric radiation oncology program in my center, the NSI Luth Cancer Center. Okay, so I will skip a couple of the slides, but just to, as an outline, I'll go through some introduction and background, general landscape of cancer and radiotherapy in Nigeria, the center where I work, and then our pediatric brain tumors program. I always like to start everything I do with a little history, and I'm sure most of us are familiar with this, but Nigeria became a country in 1914 when Lord Lugard amalgamated the North and the South. And as my late father used to say, forced them into an arranged marriage that neither one of them asked for or wanted, in quotes. We became independent in 1960, and we are now the most populated country in Africa and the 8th most populated country in the world. And we are projected to become the 3rd most populated country in the world after India and China. Nigeria is a study in contrast, a lot of wealth, but also a lot of poverty. And it's a country where you can live lavishly or you have to hustle to survive. So GlobalCan estimates that 125,000 new cancers are diagnosed in Nigeria every year. And we all sort of agree under our breath that this is underreported, because this data was derived from 4 out of 13 cancer registries in the country, and we know that the registries don't have all the information as well. But just, talk about why, I'm going to talk about why cancer is important, but then talk about pediatrics as well, because it's the single largest healthcare drain on the economy, cancer. More than HIV, AIDS, heart disease, infectious disease, in terms of lost years of life and productivity. And that is all the more true for pediatric cancer. You see, a 70-year-old man dying is less damaging, so to speak, to the economy than a 3-year-old dying, because you're losing several years of productive life when a 3-year-old child dies versus someone who has worked and retired. Again, a little bit of history. This is the first radiotherapy building in Nigeria, and this picture isn't from 1968, but this is the picture now. Hopefully it didn't look like that in 1968, but at that time they just had a superficial and an ortho voltage machine. And the NSI Youth Cancer Center was started in 2019 as a public-private partnership. It currently is the most equipped and staffed cancer center in Nigeria and possibly in West Africa, with 3 working linear accelerators, 3-dimensional high-dose rate brachytherapy, advanced procedures like IMRT, VMAT, and very soon SBRT. Some of the numbers on these slides have changed because we keep growing. So at the time, we had 9 radons, 12 physicists, 16 RTTs, and more, but those numbers have changed now. We are also an award-winning center and have received recently 2 special recognition awards for excellence in oncology. So just to say that we're all very proud of the work that we're doing. And I like to think about radiation therapy in Nigeria in terms of before and after NLCC. So we had less than 10 working cancer centers in the country, less than 100
please, can we get some
radons.
quiet in the hall, please? Hello, can we get some quiet in the hall, please? Thank you.
Thank you, Dr. Akile. So we had less than 10 cancer centers, less than 100 working radons. This number, the number of radons hasn't changed. It has possibly decreased. Thank you, sorry about that. So it has possibly decreased, but just to show, I'm talking about this just to show the impact that one center can have, which I'm going to do in my next slide. After NLCC, the first year of the center, we treated more than 2,000 patients, and we started over 20 clinical research projects and co. And just to say how much difference can one center really make, you can ask that question and say, Nigeria is so huge, and our problems are so vast, that, what can one center really do? How much impact can one center really have? And I'm going to talk about that in a couple of slides. But this is just to show some pictures of the NSI Youth Cancer Center, what the center looks like. And as I was saying, the impact of one center. So again, these numbers have increased because every day we keep growing. So as of today, we've treated over 11,000 patients. We've delivered radiotherapy to at least 10,000 people, and over 100,000 fractions of radiation have been delivered. We've got a radiotherapy training school, several partnerships and collaborations to train people. We've got interns in the center, research interns, physics interns training in the center. We've received 5 grants in 4 years. We have several projects going on. We've published over 50 papers in 4 years, and we've had 2 clinical trials and on the cusp of another 2. And particularly for me, NLCC is a place where women thrive. We have the first female radiation oncology professor in Nigeria at the center. Our center director, the heads of departments of brachytherapy, research, pediatric radiation oncology, human resources, finance, and pharmacy are all women. So it's a center where women are allowed to thrive, and that's something that I'm very personally proud of. So to talk about my presentation, which is pediatric radiation, it's a rapidly growing and evolving field in sub-Saharan Africa, high potential for morbidity and mortality. We all know this. And I always talk about the holy trifecta for pediatric radiotherapy. And it is the intersection of technology, because you've got to have the machines and the infrastructure. Expertise, because pediatric radiation is not, oh, I can treat adults, therefore I should be able to treat children. Maybe I'll make the dose smaller. It doesn't work that way. You actually have to be specialized. And access. you can have the machines and you can have the experts, but if the children can't access the care, there's no point. And all of this is brought together by cohesion. There has to be multidisciplinary care, a very cohesive team working together. And for me, that is the convergence of what can change pediatric radiation. So I don't want to talk about barriers because we know what they are and we talk about them all the time. So I'm not going to go over this slide. But I want to talk about our brain tumors program, our pediatric brain tumors program. And when we started the program, we decided to break up our goals into the 3 Ps. Patients, and what we wanted with patients was to improve outcomes, reduce side effects, and make sure that we maintain a good quality of life. Professionals, we wanted to train people to become experts. We wanted to make sure that we have the expertise. And of course, we wanted cohesion. We wanted to have a working multidisciplinary team. And protocols, not just to copy and paste protocols, but to make sure that those protocols made sense in our context, to collect our data and to be able to present and replicate our work. Now, I'm not going to talk about what we don't have because again, that list goes, we can start from season 1, episode 1 and get all the way to season 99. We don't have a lot of things. But what we do have is that we have patients, and our patients have to get treated. And not every patient can go abroad. We've got professionals. We have people who are dedicated, who are brilliant, who are committed. We have population. We've got a large pool of potential professionals where we can grab people from. And we have potential. There's nowhere where you can make an impact more than somewhere that is sort of like the Wild West. So epidemiology. In the first couple of years of the program, we treated 97 patients. And I remember yesterday, Dr. Jingra was talking about where to begin with research. And it starts by looking at your practice. Who are the patients that are coming to us? What do they come with? How are we treating them? Are they doing well or are they doing not well? If they're doing well, why are they doing well? What are we doing to make sure that we can replicate and duplicate what we're doing? If they're not doing well, why are they not doing well and how do we fix it? So we started with an audit of our CNS cancers and, we had patients coming to us mostly with gliomas, medulloblastoma, ependymoma, craniopharyngioma. And I do want to say here that with the gliomas, we do have a problem because we can't do a lot of the advanced pathologic testing. So sometimes you have an oligoastrocytoma, but because you can't do 1p19q code deletion tests, you just group it along with others. So again, pathology sort of is not as good as it should be, but to the extent that we're able to classify our tumors, we did. Looking at radiotherapy techniques, in 2019, 96% of our patients were being treated with 3D CRT, and only 3% received IMRT. As of 2022, IMRT is in 75% of what we're doing. So it shows a very good progression in terms of being able to deliver advanced techniques. I'm not going to talk about sedation, but I mean, anyone, and again, these issues are not unique to Nigeria. Sedation, pediatric sedation is a problem anywhere. There's always a challenge, it's always difficult. But specifically for us, we've got less than a dozen anesthesiologists serving a huge hospital. None of them has specific training in pediatric oncology. We don't have a dedicated pediatric anesthesia team, so they've got to share with the adults. So sometimes it means children have to wait several hours, hungry, tired, cranky, for the anesthesiologist to arrive. And sometimes, unfortunately, we've got to cancel fractions because of this. And as a result of that, we had to develop our own behavioral therapy protocol, where we do something called exposure therapy. We bring the kids and do a simulation to try to get them through the process. And we do that up to 3 times just to get the child comfortable. And with that protocol in place, we have children 5 years old and above. We are able to treat them without sedation. Radiotherapy uptake. So 59, the reason we wanted to study this was how many children received a radiotherapy prescription, but they never had radiotherapy. And we found that that was almost 40% of children. And that is significant. 40% of children who came to the center needed radiation, got a prescription, but they never came back for treatment.
Time up, please.
Why?
Thank you very much. Time up.
I'm almost done. Why didn't they get treated? Because the treatment was too expensive, because of problems with sedation, because they lived too far away to be able to come for daily treatment, because of strain on their family, fear of side effects. And, we had to come up with solutions to that. The other thing, I'm almost done. I'm wrapping up in the next 2 minutes. We wanted to look at was treatment breaks, and we found the treatment breaks data particularly surprising. Children who have paid for their full course of radiotherapy didn't finish treatment. And we found that interest, it was surprising, and we wondered why. And you find out that if you don't deal with the other problems, if you don't make sure that they can look after their other children, even if they've paid for treatment, they're not going to get it. So you can't treat children without supporting the family, just to make that point. And we found that treatment breaks were higher in those living closer to the center than those who lived far away. But treatment abandonment was higher in those living far away or out of town. So it means they just simply couldn't cope anymore and they had to go back home. So what is our goal now? To reduce financial strain, to reduce family strain, reduce geographic strain, reduce side effects, and to solve our sedation problems. These are some of our team members. Let me go back.
Thank you very much. Thank you very much.
That's Dr. Chidi there.
Thank you. Thank you. Thank you.
As I step off the stage, Dr. Ololade,
thank you very much.
As I step away, I'd like to invite everyone to our Pediatric Radiation Observership Program and to the Pediatric Radiation Launch that is going on at the NSI Look and Senses at the end of the month.
Thank you. Thank you. We appreciate you. Thank you very much.
So can we have the next presenter, please? Thank you.
Good morning, everybody. And my name is Dr. Osita Ezenwosu. I'm a pediatric hemato-oncologist with University of Nigeria Teaching Hospital, and I'm happy to be here at the Arcon 2023 to present the role of chemotherapy in pediatric brain tumors. Okay, before we look at that, it's good to look at the peculiarities and significance of child brain. Childhood is the most important period for the formation of nervous system and the intellectual abilities. At birth, only about 25% of CNS cells are formed, and this increases to 66% by 6 months, and also to 90% by 1 year. By 3 to 8 years, there is now full differentiation of the cortical cells, as well as full formation of cellular structure of cerebellum as a result of growth and myelination of axons, branching of dendrites, and formation of intraneural spaces. It's also important to point that the oxygen need of the brain in a child is about 20 times that of an adult. And as a result of this, there is increased sensitivity to oxygen starvation in a child, as well as sensitivity to toxic substances and increased intracranial pressure. Given this anatomical peculiarity and as well as functional peculiarity in a child, any growth in a child brain would definitely compromise these peculiarities. How huge is the pediatric brain tumor? It represents about 5 to 10% of childhood tumors, and there is male preponderance. In 2016, was about 2,000 deaths in Nigeria resulting from pediatric brain tumors. So pediatric brain tumor can involve any part of the brain and disrupt both the structure, form, and functions of the brain, and is associated with high morbidity and mortality. So this shows the different types of brain tumors, those that are infratentorial tumor as well as supratentorial tumor. There is astrocytoma ependymoma in the supratentorium. Also, there are also infratentorial ependymoma and astrocytoma. Craniopharyngioma belonging to the supratentorial tumors and medulloblastoma belonging to the infratentorial tumor. The common pediatric brain tumors from outside the shores of Nigeria include astrocytoma, medulloblastoma, ependymoma, in that order. But study done in UNTH shows that craniopharyngioma ranks high in pediatric brain tumors, followed by medulloblastoma and astrocytoma. Another study in another center in Enugu also showed that craniopharyngioma is also high, medulloblastoma and astrocytoma and ependymoma. So you can see that craniopharyngioma is common in an environment unlike outside Nigeria, where astrocytoma and medulloblastoma were higher. In a multi-center study involving 3 states in Nigeria, this shows medulloblastoma, craniopharyngioma, and other cerebral tumors are also high. It's important to note that pediatric brain tumors are not staged because they do not metastasize, except if there is infiltration into the CSF. So because of this, spinal imaging is required in some of the tumors as part of investigations. Despite the degree of histologic differentiation and clinical differentiations in CNS tumors in children, they are not staged because the CNS tumors are capable of causing both fatal raised ICPs and severe neurologic sequelae in children. Because of this, the severity of brain tumors in a child is dependent on its grade and not on its stage. So we have the WHO grading system, which has grades 1 to 4. Grade 1 and 2 are low-grade tumors, which are slow-growing. Grade 3 and 4 are high-grade, which are fast-growing tumors. So in this series in southeast Nigeria, it shows that the low grades are high compared to the high grades. So the treatment modalities in these common brain tumors shows that in medulloblastoma, you can see that the main treatment involves surgery and chemotherapy. Chemotherapy here comes as comes before the surgery as neoadjuvant or as adjuvant chemotherapy. Then in the other ones, astrocytoma, ependymoma, and craniopharyngioma, chemotherapy comes as an adjuvant to radiotherapy. Then in craniopharyngioma is given as intratumoral chemotherapy. So it can be used as neoadjuvant, adjuvant, or as a standalone treatment in children who are less than 3 years because of toxicity of radiotherapy at this stage of life. So the role of chemotherapy is seen in medulloblastoma, where it is effective after as neoadjuvant treatment or as adjuvant to surgery. It also prolongs survival in high-grade tumors, where it increases disease-free survival in these children. In low-grade tumors, it can be used to reduce the tumor burden before radiation or before surgery. In children less than 3 years, chemotherapy is used to delay radiation so that after 3 years, radiation could be given to these children. So in these children that are less than 3 years, it's found that 60 to 70% of their brain tumors are supratentorial, unlike in adults where older children and adults where infratentorial tumors are high. Radiotherapy goal here is to delay radiotherapy due to its neurotoxicity. However, most of these children who receive chemotherapy relapse before radiotherapy, before that 3 years. So current studies, what they do now is to give short course chemotherapy for 16 weeks, followed by focal radiotherapy, and then followed immediately with maintenance chemotherapy.
3 minutes more.
So role of chemotherapy in medulloblastoma was seen in this study done in France, where in the two arms, those who receive the surgery alone and those who receive chemotherapy as neoadjuvant. The results showed that the rate of complete tumor excision was higher in those in Group B, and the intellectual outcome tended to be better in those who received neoadjuvant chemotherapy. So these are the routes which it can be given: IV, intraventricular, intrathecal, or intratumoral. So these are the chemotherapies that can be given, and most of them are alkylating agents in children, and some are antimetabolites and plant alkaloids. So these are the chemotherapies that can be given in different tumors. Currently, the Nigerian Society of Pediatric Oncology are developing protocol for the treatment of all the tumors in children, including brain tumors. Currently, is ongoing, and the goal here is to have the same treatment protocol going on in the country at the same time. So very soon we'll have our own protocol, which we'll be using also in the brain tumors. Okay, so it's good to point that in management of children with brain tumors, multidisciplinary team approach is very important, where the pediatric oncologists take care of the chemotherapy, the radio-oncologists, the surgeons. However, what we find here is that sometimes these children present first to the surgeons who have them had surgery and discharge them, and subsequently they will come up with sequelae of these tumors. So multidisciplinary team approach is very important, as well as education and family support for these children because of the side effects and other neurocognitive dysfunctions they go through. Also, the support from the government to the family is also required in these children, because, like we pointed out yesterday, once a child is sick, the whole family is also sick. So it's also important to support pediatric cancer survivors. This has to start from the hospital, where some light academic programs can be put up to enhance their cognitive function during treatment. Also, neuropsychometric evaluation may be given. Hospital play and recreational centers are disappearing in most of our hospitals. So this has to come back, because these children that stay in the hospital for chronic conditions stay long, and they can have these recreational activities to help in their neurocognitive development. So we have challenges also in giving chemotherapy in these children with brain tumors. The dosing challenge, because most of the pharmaceutical companies focus on adults, and you find out that once these drugs are given to the children, there are a lot of loss.
Please, your time is up.
Okay. Then...
Thank you. Your time is up, please.
Just one slide more.
Yeah.
Thank you. Then blood-brain barrier is also a challenge, where it's a shield to chemotherapy. However, newer studies are showing that these brain tumors may also disrupt blood-brain barrier and allow some of the chemotherapies to gain access.
Thank you.
In summary, chemotherapy has role in improving survival rates and tumor reduction in children, as well as in those that are less than 3 years, to improve their survival while waiting for radiotherapy.
Thank you so much.
Multidisciplinary team approach is required, and supportive care and long-term follow-up is important.
Thank you so much. We really appreciate it.
Thank you.
So we take the next presenter, please. Please, you have 10 minutes.
I think my time should start counting when my presentation is up, because it's still not up.
Okay, no problem. We'll do that for you.
Thank you.
So as we wait for the presentation to come up, the next presenters would be an overview of American Cancer Society's project in Nigeria, the UITH Ilorin experience. Please, the presenter should get ready. IT, are we ready? Yes. You may go ahead, please.
Okay, great. Thank you very much. Good morning, everyone. At this moment, I'm going to pivot away from the clinical perspective. One, I'm not a doctor. Two, because all of this will ultimately not translate to action if we do not have systems in place to support them, especially policy and, especially from the policy perspective. Next slide, please. Thanks. Okay, why is pediatric oncology important? And if I could please get everyone's attention, because we will not move forward and we will not get progress out of this presentation if you do not see how you come in. Because for this presentation, it's not about what I can do or what you're doing at your centers. It's about how we can collaborate together to actually achieve change for pediatric oncology. The reason why pediatric oncology is important is that despite the fact that there's 80 to 90% odds of cure, in Nigeria, like other low middle income countries, we are seeing values as low as 26%. So that needs to change. And the only way that can happen is for us to work together in this process. Oh dear. All right. So for us at CHAI, we're an NGO. We depend on donor funding. When we started this program, I remember presenting at when we started our work in the cancer space, I remember presenting our work to improve access to cancer treatment, and several pediatric oncologists called us out on how there was an absence of formulations or even medicines for addressing pediatric oncology. And we went and we started knocking on doors. Unfortunately, the UBS Optimus Foundation agreed to support us. And since 2019, we've been doing work. We started first in West Africa, specifically Nigeria, Cameroon, and Ghana. And we've transitioned also to Indonesia and China. We have 6 major pillars. And of those pillars, fortunately, 5 of them are being implemented in Nigeria. In other countries, varying components. Policy, financing, and coordination is happening here. Supply chain management, we now have pediatric formulations on the CAP program, which, in partnership with the Ministry of Health, we're working to implement. Hospital level strengthening is ongoing with MDTs and patient navigation going on, which goes to answer one of the questions someone in the audience asked earlier about how do we communicate appropriately to patients and caregivers. Data management is critical, so the digital solutions that provide the Cancer Access Partnership helps with that. And then patient education next, and then patient education. Again, without coordinated procurement that has happened, we won't see an opportunity to pull volumes and encourage manufacturers to bring down their prices, because for the longest time they were saying no one is really using the medicines in Nigeria and other low middle income countries. At the global level, we now know that St. Jude's Children's Hospital and the WHO now have a global initiative on childhood cancers. And one of the things they are working on is a platform similar to the way Global Fund supports several countries to access medicines. And the reality is that Nigeria is not a GICC country. And if we do not become a GICC country, our children will continue to suffer when countries like Ghana, next door, already have access to this system and are able to access medicines at pretty much a free medicines for children. NCCN harmonized guidelines has been adopted in country, and there are a few pediatric oncology guidelines in there. We also have learned that there are a few other organizations that have incorporated pediatric oncology guidelines into their systems. We need to work together to develop an advocacy tool or to advocate for the government. The CHF covers cervical, prostate, and breast cancer. While it is great that we can address the need for the top prevalent cancers in Nigeria, top 3 prevalent cancers in Nigeria, it almost seems criminal that we are not addressing cancers with high outcomes in children who can contribute to the economic improvement of the country. I mean, the other thing is they didn't even do anything to get it. So we're not even talking about preventable cancers. We're talking about cancers that were developed for multiple reasons that we're still trying to learn. Early detection is critical. We need to figure out how to identify mechanisms that other people have already. Fortunately, Dr. Adedayo Joseph wears 2 hats. And the second hat she wears is that she leads the Doctors Cancer Foundation. And they've actually developed a curriculum that is called the Look Again campaign that helps providers of lower cadres in PhDs to best detect and refer quickly so that children are not spending many months in the PhD level. So again, I'm going to just run through quickly. We have a patient navigation program, which I'm happy to talk to several people who want to learn about that. But collaboration can support improved policies and transformative healthcare systems. The reality of it is that we can't do this alone. CHI alone can't do it. Several entities can, in your individual facilities, there's things you can do, but the more we work together, the better. Fortunately, in the beginning of this year, as a product of conversations from last year, the NCCP ICAIA ECHO was put together, and really it was an opportunity to support 17 countries that are linked to their government to make sure that they include the cure-all approaches in their cancer control plan, to make sure that there is provision to address pediatric cancers in our policy. Fortunately, if you go to the St. Jude's Global Health Systems website, there are other things that several people here, anyone, you can take advantage of it. Again, just to deep dive a little bit into the ICAIA system. So it was really, again, integrating the cure-all approach into the framework for national cancer control planning. And there are 4 pillars. Again, happy to share this presentation and to discuss with people because Nigeria was fortunately part of this maiden cohort, and there's going to be another cohort, and there's room for Nigeria to be part of it again, either with the same group or with a mix-up of new people who are interested in learning these approaches. So centers of excellence and care networks are critical, right, with sufficient and competent workforce. Universal health coverage with benefit packages and organizational models for quality services. We do not have NHIA covering children, right? But right now, there's trastuzumab on NHIA, and for me, I think that's a bit of a misnomer. Pillar 3, there are regimens for management with context-appropriate guidance. Again, there's the NCCN harmonized sub-Saharan guidelines, and also St. Jude's on their website, you can access mechanisms to then turn those guidelines into an adaptive model for us. Okay, all right, so I'm going to move through quickly. What have we learned? We've learned that there is an opportunity with several people, including a company called, including a apply help to actually take hold and use these harmonized guidelines 1 more minute. Supply chain. Forecasting for children should be done at the same time it's being done for adults, right? So again, when we are forecasting, we focus a lot on adult cancers, and facilities for doing this need to be supported. MD gynecologists doing this. It should be the gyne oncologists doing that. But what about having everybody in the room planning for that patient's care? And this is really critical with children because you need ENTs. This is my last slide. I just have a couple things here. Hospital level strengthening. MDCs again.
Thank you very much.
TWGs are important, but patient navigation cannot happen if hospital management does not support it, because again, they are not generating internal revenue and they need that public
Thank you very much, Paulette.
Data management is critical. Just 1 more second, please. Data management is critical. Again, early detection. How do we make sure our children are not spending so much time in lower cadres hospitals before they get to us? And patient education. Somebody talked about it earlier. How can we make that?
We're very grateful. We don't have time, please. Thank you very much.
Thank you.
Thank you. We want to appreciate all the speakers for this session. Unfortunately, because of time, we will not be able to take responses. If you would like to interact with them, please, you could approach them as they step down. They can just stand together. They will take a group picture. Please, just wait. Please wait. You are taking... Thank you very much. Thank you very much. We would like to welcome American Cancer Society for the session. Dr. Shagaya, overview of the American Cancer Society's project in Nigeria, UITH Ilorin Experience, the ACS. Thank you very much. We'd like to quickly welcome you. Today is a very busy day for us. We have almost about 8 presentations or 9 to go. We have the annual general meeting. We also have the dinner. So you will please bear with us. And we did not start as scheduled. And we sincerely apologize to all our participants that we started 1 hour behind schedule. So we're very sorry. Thank you very much. That's fine. You are very welcome, sir. No problem. Dr. Wukucha, where are you? Nwachuku. Oh, Dr. Nwachuku. Thank you very much. Oh, okay. So we have to spare issues. Our presentation is after this. No problem. It's okay. Thank you very much. So you can start, sir.
Good morning, all. My name is Akabir Rafiu. He's moving it down. I want to take it. Good morning, all. My name is Akabir Rafiu Folan. I work for American Cancer Society in Nigeria. I'm here with our colleagues from University of Ilorin Teaching Hospital to present the work that we are doing in Nigeria. They will be sharing their experience as an implementer of our projects. They are from University of Ilorin Teaching Hospital. American Cancer Society, as we know, is a leading cancer fighting organization with a vision to end cancer as we know it for everyone. Our mission is actually to improve the lives of people with cancer and their families through advocacy, research, and patient support for the purpose of ensuring that everyone has an opportunity to prevent, detect, treat, and survive cancer. American Cancer Society began its collaboration with the Federal Ministry of Health in 2012 with the aim of improving access to affordable and quality essential pain relief for the management of moderate and severe pain. So we deploy two strategies to actually achieve this aim, which has to do with ensuring sustained availability of essential pain relief, the strong opioid analgesic, at the same time creating rational demand. So the Federal Ministry of Health Nigeria focus on ensuring sustained availability, while we at the ACS, we focus on creating rational demand for the use of these important essential medicines, which has to do with capacity building of health workers. So we deploy an initiative that we named as Pain-Free Hospital Initiative in 2015 as part of strategy to create rational demand. The initiative is actually one that is aimed at integrating effective pain management into our healthcare delivery, and we implemented this initiative in 22 hospitals. On the part of government, they established or developed a guideline for pain management, which actually standardized the way we are expected to manage pain in the country. And between 2015 and 2019, we trained 16,968 healthcare providers cut across the various professional groups that are directly or indirectly involved in the management of pain. We trained doctors, pharmacists, and nurses. And during this period, the patient reporting severe pain decreased by 75% in facilities where we have implemented our projects. And the knowledge of trainees actually increased from 49.6% to 63.5%. And hospitals along the line, they began to routinely assess pain in their various facilities. We have expanded our project beyond pain management in the country. We have actually introduced 4 other projects. These are the projects. The first one is access to pain relief. This is followed by safe handling and administration of chemotherapy. And the third one is uptake and integration of NCCN harmonized guideline. And while the fourth one is cancer access partnership, which our sister organization, CHAI, is implementing on behalf of American Cancer Society. It's actually aimed at making available, affordable, and high-quality anti-cancer medicines. The goal of our projects generally in the country is actually to expand access to high-quality and affordable cancer treatment for improved patient outcomes. And the objective, 1, is to facilitate provision of quality cancer treatment services. 2, strengthen the capacity of cancer centers to receive and effectively utilize outside grant funding, while the last one is to build capacity for research activities. These are things that we are doing and we have done for facilities that we are supporting, implementing our projects. We provide them with grants to implement activities and interventions targeted towards establishment of a solid foundation required for large-scale investment in expanding high-quality and affordable cancer treatment. We also provide implementing facilities with resources such as assessment tools and training materials. During the course of implementation, we have identified milestones that we are using to track implementation of activities that they are implementing in their various facilities. And we adopt performance-based funding model to increase investments in high-performing cancer centers, such that based on your performance that will determine subsequent funding that you'll be getting from our various facilities. So these are expectations from implementing facilities. Implementing facilities are expected to choose the project leads for the 3 projects. Number 2, they are expected to constitute a project implementation team that cut across the various professional groups that have a role to play one way or the other in the implementation of your project. 3, to develop work plan. 4, to implement activities listed under each project in line with the development, the work plan that they develop. And to submit reports and other documents required to show evidence of completion of the activities that they are implementing. We expect them to document expenditures with respect to the grant that we have provided, and also ensure that they have receipts where applicable. And the last one is for the implementing facilities to take ownership and ensure that we have the project institutionalized in their various facilities. For us, from the project that we have implemented in the past, we realized that implementing facilities, after completion of projects, they don't take ownership. And it's something of great concern that facilities utilize the grants, they implement, and they forget about it. To us, it's not sustainable and it's not good enough, because ACS is not going to be supporting Nigeria till eternity. Obviously, to get to a point that ACS will definitely leave the country. So we want a situation whereby as you implement projects, there is a plan between the implementing, the facility leads and the facility to be able to actually have a structure, a plan in place so that they can take ownership, and we can now have the project institutionalized. We will appeal that if it's possible for us to have a conversation around this, our facility can take ownership of projects that we are implementing in Nigeria. So these are the hospitals that we are currently supporting with respect to the 3 projects that we are implementing. We have University of Ilorin Teaching Hospital, UNTH, and University College Hospital, Ibadan, implementing access to essential pain medicines. We have the 3 hospitals as well implementing ChemoSafe, which has to do with safe handling and administration of chemotherapy, while we have 4 hospitals, the UITH Ilorin, the UNTH Enugu, University College Hospital Ibadan, as well as National Hospital Abuja, implementing uptake and integration of NCCN harmonized guideline.
2 minutes more.
So I have project leads from University of Ilorin Teaching Hospital to share their experience with respect to the various projects that they are implementing. I have Dr. Israel Kolawole, a pain management expert, who will be sharing his experience with respect to access to pain relief. We have Professor Samuel Olatoke, who's going to be sharing his experience with respect to uptake and integration of NCCN harmonized guideline. And we have an oncology pharmacist, Mrs. Modupe Olanrewaju, who is going to be sharing his experience with respect to implementation of ChemoSafe. Thank you. Okay.
Good morning, everyone. ACS is supporting 3 projects in UITH Ilorin, and access to pain medicine is one of the 3 projects, and I lead that project. Now, pain management is a powerful adjunct to oncology care, and it has distinct values to physical, mental, and psychosocial well-being of the patient. This is especially true in the case of Nigeria, where more than 75% of our patients present in the advanced stage of the disease, at which time pain is a prominent symptom of their presentation. So there should be a way to adequately manage this pain. And opioid analgesics remain the gold standard for pain management in all situations, especially in cancer patients. But unfortunately, knowledge is inadequate in the use and prescription of this medication. So patients are denied the benefit of adequate pain management that will arise from opioid use. So, and ACS has been with us as far back as 2015 to drive the training of oncological care providers in the good management of pain with the use of opioids. So this is another effort of the ACS to promote pain relief in cancer patients. So the objective of the project, Access to Pain Relief, is to promote access to essential pain relief medicines in order to improve pain relief among cancer patients and promote gain in pain management practices in University of Ilorin Teaching Hospital. There are 5 activities under this project. The first is to conduct a baseline pain assessment scores. Second is to conduct a baseline assessment of knowledge, analysis of cancer care providers, and to identify training gaps that will be focused on in the third activities, which is to conduct a pilot training of cancer care providers and create a facility strategy to scale up pain-free hospital initiative in our facility. The fourth is to develop a promotional campaign strategy to raise awareness, and the fifth is to organize a consultation with relevant stakeholders on access to pain relief. We have gone halfway, I must say. We have completed activity 1 and 2. We are halfway through on activity 3. And as you know, activity 4 cut across all the other activities. And we have also commented that one in a way. Now, the project was implemented in UIT Ilorin by the established multidisciplinary pain and palliative care committee of the hospital. This is an established committee that we use for training on pain management in UIT Ilorin. So the committee met together and discussed on how to implement the project. They developed work plan with timelines to guide implementation. The first thing we did was to carry out advocacy and sensitization. First, to hospital administration to promote the project and seek their collaboration. After all, the project belonged to the hospital. Then we also had to interact with HODs of the target groups that we use for the we attend the training, and then we discussed with administration to help us recruit the participants. On activity 1, first all oncology beds in the relevant wards where cancer patients are seen and admitted in the hospital were physically identified and numbered. We do not have oncology ward per se in my hospital, so we have wards where they admit cancer patients. So we have to identify the beds that they commonly use for cancer patients in the hospital, and we have to number them. And then from there, we calculate the samples of beds we need to assess the pain scores in the hospital. But unfortunately, at that time in June, the oncology care admissions in the hospital was very low because of incessant strike by either the resident doctors or the other workers in the hospital. So we had to use 100% sample to be able to get enough patients for the activities. So we conducted the baseline assessment of pain scores, and then that data have been analyzed, report prepared, and we have submitted the report to ACS. On activity 2, that the baseline assessment of pain score, this is our findings. Total number of patients sample was 32. Males 10, that's 31.2%. Females 22, that's 68.8%. The baseline average pain scores for males was 5.2. For females was 3.9. So overall average oncology ward average pain score in our hospital was 4.6. Number of patients with pain scores above oncology wards was 31.2. So number of patients with pain score above or equal to 4 indicating moderate to severe pain was 56.3%. This shows that more than 50% of cancer patients in UIT Ilorin still experience moderate to severe pain while on admission, indicating that cancer pain management is inadequate in the facility. Now, we also carry out the baseline assessment of knowledge and attitude of cancer care providers in our hospital. The objective of this project was to identify training gaps that need to be addressed during the training of cancer care providers. That's in activity 3. So data was collected anonymously using survey instrument developed by the African Cancer Coalition, adapted from 2014 revised version of knowledge and attitude pain survey regarding pain. That instrument was developed by Betty Farrell and Maguka McFarry. The validated instrument consisted of 43 questions and 2 case scenarios. So we identified the target groups, which are doctors, nurses, and pharmacists who work with cancer patients. So we administered the questionnaires to this target group. For the oncology, for the doctors, we administered the questionnaires at their weekly grand rounds. And for the nurses, we had to administer the cases at the questionnaires on the ward during their shift. And we did that. Our data collectors stayed around for them to complete the questions and attend to any questions they might have on the questionnaire. We repeated the same thing the following week to take care of those who were on off duty the previous week when we administered the questionnaire. And then for the oncology pharmacists, we went to their unit to administer the questionnaire. So, now the findings from that assessment, 76 participants responded to the questionnaire. We had to categorize the questionnaire into categories for ease of analysis. We have those that address knowledge of opioid analgesics in relation to pain management. And there were 12 questions. Of these 12 questions, participants scored above 80% in 2 of the questions. That's 16.7%. Then 70 or 80% in 5 of the questions, and 50 to 69% in 1 question. They scored less than 50% in 4 of the questions. Participants did not score above 91% in any of the questions in the questionnaire. Then knowledge of participants on non-opioid analgesic in relation to pain management, there were 3 of these questions. Participants scored above 80% in 1 of the questions, 50 to 69% in 2 of the questions. No participant scored above
2 minutes
81
left, sir.
in any of the questions. On pain knowledge and attitude to pain management, we had 11 questions. More than 80% of, they scored more than 80% in 5 questions, 50 to 69% in 2 questions, and 50% in 4 questions. Participants did not score above 91% in any of the questions. Now, there were 2 case scenarios. This actually assessed the practical understanding of the participants in relation to cancer pain management. And the first case scenario is Andrew is 25-year-old, and this is 4th day following abdominal surgery. As you enter his room, he smiles at you and continues talking and joking with his visitor. Your assessment revealed that the following information: BP 120/80, heart rate 80 per minute, respiratory rate 18 cycles per minute. On a scale of 0 to 10, patient rated the pain to be 8. So the participants were supposed to mark this level of pain on the numeric rating scale. Okay? So in the pain assessment, they scored only 20 of the participants got the correct answer, which is 34.2%. Then the next question on that case is physician order for analgesia is morphine IV, 1 to 3 milligram, 1 hourly PRN, pain relief. So they were supposed to then pick which the right dose to give to this patient. There were 1 milligram morphine, 2 milligram, 3 milligram. So they scored only 9 participants got the correct answer. The second case scenario, Robert is 25-year-old, and this is 4th day after abdominal surgery. As you enter his room, he's lying quietly in bed and grimaces as he turns in bed. Your assessment reveals the following parameters, and they were supposed to answer the same 2 similar questions as the previous case scenario. But in pain assessment, 46 of the 76 participants got the correct answer. And the action to be taken to relieve the pain, only 28 got the correct answer. Now, the pilot training was done in
Your time is
in
up,
June,
sir.
and this is the participant at the pilot training. Now, what were the hints for success of the program in our hospital? One was the formation of multidisciplinary team to drive implementation of the project. The second was allow experts on the subject to lead each project. So each expert leads the project.
Kindly round up, sir. Your time is up, sir.
So in conclusion, ineffective utilization of opioid analgesic due to inadequate knowledge of healthcare providers in the use of therapeutic use of opioids is a major barrier to effective pain management. More than 50% of cancer patients in UITH Ilorin still experience moderate to severe pain, while the observation indicating that cancer pain management is inadequate. Then the improving access to pain relief is another effort of ACS to help us improve pain management in hospital. Thank you. So the next presentation is from Professor Olatoke.
Good morning to everybody. I'm here to introduce to us the Comprehensive Cancer Network NCCN guideline usage, because it has been found out that it's one of the most commonly used clinical practice guidelines for cancer care. Also, the aim of NCCN guideline was for the care of patients to standardize the care of patients for cancer, and also it helps to standardize research work of everybody managing cancer patients when you use the same guideline. This guideline has been developed for the past 25 years, and it has been endorsed by the Federal Ministry of Health of Nigeria. The study we carried out was see how to promote uptake and integration of NCCS and hormonal guideline among oncology practitioners in my institution. Oh, sorry, you told me the other person. So the first activity that we conducted was to conduct a baseline survey of staff and relevant departments to understand awareness, use, and attitude about the NCCN harmonized guideline. Events in appropriate departments were organized similarly to improve this, and we developed a promotional campaign in appropriate departments to ensure that those providing cancer care are aware of NCCN guidelines. Similarly, a panel or presentation about NCCN guideline was done to the panel, and also a national workshop of stakeholders was organized for the management and other relevant stakeholders that are managing cancer patients. So under the activity 1, we conducted a baseline survey using the pro format generated by the American Cancer Society with little modification to suit our own environment. So we established a team of 4 oncologists, researchers, to see to the implementation of the baseline survey. We created a database and using the produced survey tool. So after identifying the survey population of 100 people, among health workers, we administered the survey tool. We retrieved the survey, the questionnaire field, and the data were analyzed and entered into the databases. And we cleaned and analyzed data. We created a pro forma for evaluation of adherence to the use of NCCN guidelines among cases being managed or currently managed. And we also identified intervention areas for sensitization and campaign. And then, within the period, we identified 15 policymakers and also people responsible for practice of implementation in the respective department. And then we are to write a report and submit to ACS. So under activity 1, where we conducted the survey, 106 respondents, constituting 61 to 27 male to female, 39 consultants, 29 senior registrar, and others. The most common cancer being managed in my center is breast, followed by colon and prostate, leukemia and nephroblastoma, and ovarian cases. The uptake and conformity to NCCN guideline was low among respondents studying the UITH hospital. only 16 reported ever used NCCN guideline. And then 14 reported being familiar with it for sub-Saharan Africa. 13 respondents had no intention of starting the use of NCCN guideline. 42 were considering starting within the next 6 months, while only 27 reported or occasional or frequent use. Only 1 reported regular use of NCCN guideline. So activities 2 was to organize events in appropriate departments to improve awareness and familiarity with NCCN harmonized guidelines. The methodology was that over the launch, stakeholders were called to the meeting, including the management, those departments that are involved in managing cancer patients were brought on the table for a round table meeting. And then, because this became necessary for us to identify respective stakeholders that are important for this kind of policy. The issue addressed during the brainstorming session include 1, to increase awareness and to create acceptance of the NCCN harmonized guideline, and also to demonstrate the use of NCCN guidelines. We organized a global workshop on assessing and using the guideline. The goal is to enable participants to download the guideline and also to provide hands-on section in the utilization across various specialties. And we identified some disease entities such as breast, ovarian tumor, prostatic tumor, and hematologic tumor. We had an open discussion on scenarios in other departments. The participants were taught the endorsement and implementation of this was sought from the management so that it will be obvious to them that we are not just here to give them a fake result. We sought the involvement of the management to give it a very big color, and that also improved the attendance of these participants. During the program, a pretest was conducted, giving them a particular questionnaire to fill. And we also introduced to the participant NCCN harmonized guideline for sub-Saharan Africa. During the global workshop, hands-on session to register and access NCCN guideline was conducted. Simulation was done by 4 specialists, presented their experience with the use of NCCN guideline and also using breast, prostate, ovarian, and acute lymphocytic leukemia. After doing this, the post-test was conducted. Preliminary results from the survey revealed that are Nigerians involved, some of the questions asked, involved in drawing and updating NCCN Sub-Saharan Africa guideline before the training? 81% thought yes, 98% after training, post-test. Then, the meaning of color coding in the NCCN guideline, only 8 of them understood the difference in color coding before the training. After the training, the figure rose to 54. The surgical treatment in the guideline, availability of surgical treatment, only 55% pre-test knew that there's a column, a provision for that. Whereas after the training, 72% knew that there's a surgical part of it. Radiotherapy, only 52 are aware.
2 minutes
after
more,
training, 75.
2 minutes more.
Going by this, even the fertility issue, most of them don't know that it's part of NCCN guideline, and it rose to 74 after the training. And then how to access it, only 55, but after training, 93. And surprisingly, that using NCCN guideline to plan treatment, pre-test, only 76 are aware, but it rose to 84. Then, a lot of them similarly do not know that you can even adapt NCCN harmonized guideline for local guideline for your own particular environment, but after the training, quite a large number of them got that information. So our next activities is to organize the event in appropriate department to improve awareness and familiarity with NCCN and MONAI guidelines. So our aim is to do a global workshop milestone. What do we intend to achieve? We want to improve the number of people that will attend, and then also pre- and post-study results show knowledge gained by the participant. This is the post-meeting. Our next assignment is consolidation phase. What do we intend to do? We want to do interdepartmental and in-clinic promotion, whereby we go to various clinics and see how they are doing it, and then sensitization campaign from various hospitals, whether government or private, and then do a post-intervention evaluation. Thank you.
Just on time, so the next presenter quickly. Thank you for your presentation. You have 10 minutes, ma'am.
Good morning, everyone. I'm pharmacist Lydia Modupe Olarewaju. I'll be presenting on implementation of safe handling and administration of chemotherapy at University of Ilorin Teaching Hospital. By way of introduction, chemotherapy is the most widely and readily available treatment modality for cancer in Nigeria. These drugs are toxic and potentially harmful to patients and workers who are exposed to them. So exposure could be through inhalation, skin contact, mucous membrane contact, injection, or accidental injection. For patients, the benefit of these treatments outweighs the risk. But for health workers exposed to these treatments, there is risk of harm without a balancing benefit. So, risk outweighs the benefit. Therefore, the need to prevent or minimize exposure to this hazardous drug is very, very important. The objective of this project is to promote safe handling and administration of chemotherapy among healthcare providers, patients, and caregivers at University of Ilorin Teaching Hospital. What does it mean to be chemosafe? It means at national level, facility level, we have policies that guide us on how to handle chemotherapy. We also have consistent availability of essential personal protective equipment. We have staffs are trained. We have staff trained, on how to handle hazardous drugs. Then at facility, we have comprehensive standard operating procedures, that can guide us to a specific standard. We also have at least 1 or 2 biosafety cabinets so that people that are mixing chemotherapy, they can be isolated from contact with the chemotherapy. We also have safe method of waste management. Foundation of quality activities. We have 6 activities to be done. Number 1 is to utilize the American Cancer Society ChemoSafe Hub to conduct a facility-wide assessment of safe handling and administration of chemotherapy and other hazardous drugs. Number 2 is to create a list of all hazardous drugs in use in the facility and make it available to all facility staff. Number 3, we are to create a facility health and safety plan to reduce occupational hazards related to hazardous drugs. While number 4 is to develop a standard operating procedures to guide safe handling and administration of chemotherapy in the facility. Number 5, we are to develop a promotional campaign to raise awareness about safe handling of hazardous medicine, a way of having maybe signs, posters. We can also go on social media to do this. Number 6, to cap it up, we are to implement training on safe handling and administration of chemotherapy and other hazardous drugs using the American Cancer Society ChemoSafe curriculum. Out of these 6 assignments, we have only done 2 out of it. So we have done number 1. So number 1 activity, we are to utilize the American Cancer Society ChemoSafe app to conduct a facility-wide assessment of safe handling and administration of chemotherapy and other hazardous drugs. So the way we carried out, first we established a ChemoSafe implementation committee, which consists of 2 oncology pharmacists, 1 resident doctor. We also have an oncology nurse, a clinical pharmacist from the university. We also have a drug information and research expert who is a pharmacist too. So we are all together 6. For this assignment to be done, we had several meetings, both virtual and physical. We downloaded the American Cancer Society ChemoSafe app, which when you look to the right, you can see how it looks like. Then we train members of the ChemoSafe Implementation Committee on how to use the American Cancer Society ChemoSafe app. We also train other health workers, nurses, pharmacists, and doctors. We are 19 together on how to download and how to use the ChemoSafe app. So we use the ChemoSafe app to conduct hospital-wide assessments of chemotherapy handling and administration. We report these activities that are listed above to American Cancer Society. The results we got, we found out that when we did that of facility-wide, that is where there are questions about if there are policy in the facility on how to handle chemotherapy. We got only 7.19 as yes. Then receiving department, which is pharmacy, we got 46.16%. Drug compounding, we have 23.69%. Patient treatment area, that is administration area of chemotherapy, we have 23.03%. Then patient home care, that is, do the relative, do they even know about anything, the hazardous nature of chemotherapy? We got just 20%. Then laundry, we have 6.25. Then waste collection, 4.55. Then waste disposal, we have 23.83%. Altogether, as a facility, we have 19.43 on average %. So it means we have like 80% to a good standard, to an international safety standard. So what do? Identifying this gap, we develop a 5-year work plan to bring facility in line with international safety standards. We share work plan with hospital management and American Cancer Society. Number 2 assignment, we are to create a list of hazardous drugs in use in the facility and make it available to all facility staff. So we did it by requesting all departmental heads where cancer patients are being treated to prepare and submit a list of hazardous drugs that are used in their various departments to the ChemoSafe Implementation Committee. We collected this hazardous drug list from relevant departments. We also segregated the list into pharmacological classes and dosage form and the strength at which they present. So we confirmed the accuracy of the list with the departmental heads. So we also presented the list of hazardous drugs with a draft forward for information and consideration of hospital's chairman medical advisory committee. So we print and bind the endorsed list of hazardous drugs. So this list was submitted, the banded copy was submitted to the CMAC for signature. We shared the banded copies, the approved copies with the departmental heads. We also create awareness among the healthcare providers about the approved list of hazardous drugs at University of Ilorin Teaching Hospital.
2 minutes left, 2 minutes.
These are the pictures that we took during some of the meetings that we had. So success tips is that we established a ChemoSafe implementation team. We also made advocacy to the hospital management and sensitization among the cancer care provider. We adopt in person that did physical and online meeting by the implementation committee. We also work with the American Cancer Society consultant to address emerging issues and review progress. In conclusion, ChemoSafe uses a life cycle approach. The approach starts when chemotherapy agents are received by the facility, the transportation of the drug, the compounding of the drug, administration, home care, housekeeping, and waste collection and disposal. So it considers safety measures to reduce potential harm that may arise from exposure to chemotherapy agent by health workers at each of these potential points. All facilities where chemotherapy are being handled and administered are strongly advised to adopt and implement ChemoSafe. This is how it should be. Thank you for listening.
Thank you for keeping to time. So we must agree that this session was very, very loaded with a lot of information for us. So I'm sure we have questions for our presenters. So we'll take only 2 questions. Okay. So Prof will take the first question. So any questions or comments for our presenters? They've done a great job. Okay, we have 2 questions.
First of all, let me thank all the presenters, because this is an eye-opener. NCCN harmonized guideline. I think we have it in this country now for how many years? And we have some of the chairmen that chaired this NCCN harmonized guideline for sub-Saharan Africa in Nigeria here. But my problem is the implementation or acceptance. I'm happy with your slides, because even in the centers where we practice, even after the training, go back and assess how many of these colleagues of ours are making use of these guidelines. So the question now is, what are you doing? Because I don't know if Dr. Uche is still around. You see? Because I don't know what we can do. It's a huge country of over 200 million people, and everybody is doing his own things the way he likes in his own corner. What are you doing? Dr. Bello is here. A group came out about 3 months ago that they want to develop guidelines for colorectal cancer. And it took me and somebody else to point out to them that we have NCCN guideline in this country. Why do you want to create another one? So the question, I don't know who will answer it among you. Because the acceptance is the key issue. And also in terms of ChemoSafe handling, the training, you have to do a huge work with your colleagues. Because even in our centers, now they allow interns to go and be preparing this. When the trained pharmacists are there, interns are now the one preparing preparing these drugs for use by the patient. And again, because of Forex, now that we have all kinds of drugs all over the place, you say paclitaxel, only God knows how many brands of paclitaxel we have in the country today, and how many brands are endorsed by NAFDAC. And it's the pharmacists that are even in the public health centers that still get these drugs into the hospitals. Thank you.
We'll take Professor Bello.
Thank you so much for the brilliant lectures and enlightenment. My question will go to the representative of the ACS and Federal Ministry of Health. I want to find out what is the real problem, why there is no real uptake in morphine production and consumption. I do not know why a lot of centers, hospitals, federal medical centers, teaching hospitals are shying away from use of morphine. I was in AKTH just last weekend in the night because one of my patients that lives in Kano called me. She was in serious pain, and we decided to go and look for morphine for her. I went to the emergency, and I know that Aminu Kano Teaching Hospital is supposed to be a compounding center. There was no morphine. So we had to go round and round until we got to Dala Orthopedic Hospital. And we had to call the chief medical director before morphine was made available. So I want to understand, is there anything that as an organization, Arcon, can do really to see how people can access morphine as at when do? I do know that a lot of clinicians, maybe outside the palliative care, the anesthesiologists, the oncologists, still shy away from giving morphine for patients that actually need it, for metastatic diseases, not even early disease, metastatic diseases, they don't want to give it because they still believe that there will be addiction. So please, if there is anything you think we can do, some of the problems that you have identified, please let us know so that we can partner with you to make it available for everyone. Thank you.
Third and last question.
Thank you very much, the University of Ilorin Teaching Hospital team, for an eye-opening presentation. Just like Prof. Olasinde said, this is a very good work. But I want to just ask some few questions. The first question is to Dr. Kolawale. I noticed that the presentation on pain focused mainly on use of morphine. And of course, just like your presentation actually showed, there is poor knowledge and poor uptake, just like Prof. Bello here have mentioned, of the use of morphine among physicians in teaching hospital. But apart from that, what I notice is the persistent use of pentazocine for management of cancer pain. Persistent use of pentazocine for management of cancer pain. As far as I'm concerned, pentazocine is a useless medication that shouldn't be used for chronic pain such as cancer pain. So a lot needs to be done. Apart from issue of non-availability, even the knowledge on how to prescribe morphine, at what dose, at what time interval is very low. And most times when hospitals organize training for physicians, doctors refuse going. And then they will now be mismanaging pain, so much such that it is distressing. Then to Prof. Olatoke, so please, I just wanted to know, the assessment of the uptake of the NCCI, was it done among just surgeons or which specialties of medicine does it cut across? And the pharmacists, well, your presentation is actually good. It's an eye-opening presentation. This is the same thing I kept hammering in my center. I talked to senior colleagues on the need to bring cancer patients to the chemotherapy ward. You go to emergency wards, you will see house officers mixing chemotherapy and doing whatsoever they want to do because they are not trained to do that. So thank you very much for the team for good presentation.
So I think the first question by Prof.
In response to the question Professor Olasinde asked, if you listen to the first presenter, pharmacist Akonbi, his last comment was, how do you ensure ownership of whatever work we are doing? For us to sustain the use of NCCN guidelines, we must own the ownership. What do I mean by this? It then means that there must be retraining and retraining from time to time by various hospitals. As human beings, there are chances that people want to dissuade the use. But if training and retraining is being done on a regular basis, this will further enhance the use of NCCN guidelines. And I think that's the way to go. You shouldn't stop at one training and you think you have achieved, oh, no, it won't work. But how do we achieve, I'll take ownership? Each hospital must be involved. Federal Ministry of Health must be involved. Individuals must be involved. And then we must have regular meetings during our MTD meetings. So the question on the caliber of people that attended the update of NCCN guideline, it cut across all departments and specialties. It was not limited to surgical department alone, O&G, hematology, pathology, pharmacists, nurses, everybody. Because we all need to be singing the same tune in order to achieve what we are looking for.
Yeah, thank you very much for the questions. I took note of the questions asked for my presentation. But before I go to that, let me add one or two words to the NCCI guideline because I was part of the group that worked on the NCCI guideline. And many people in this hall were part of that group. So Nigerians were massively represented in the preparation of the harmonization of Sub-Saharan African harmonization of NCCI guideline. So they used their experience in practice, and based on availability of facilities in Nigeria, all those were put into these guidelines. So the guideline is very relevant to us and it's useful to us in Nigeria. The question is, why is the uptake so low? That is a difficult question, which can best be answered by the Federal Ministry of Health. Several countries and organizations have signed into that guidelines, domesticating the guidelines. So Nigeria has signed into it. They have endorsed it as a guideline for Nigeria. You then wonder, why do they, to answer Professor Latin's question, why do we need another guideline? If the country has endorsed those are guidelines and they have domesticated it, why do we want to formulate another guideline? That is a problem. Now, on the issue of pain, Professor Bello asked, why is the uptake of morphine so low? The question asked by the other person, the answer to those questions are related to what Professor Bello asked. there are three aspects to the uptake. One is availability, two is accessibility, three is affordability. We have gone past the era of no morphine in the country. Now we are constantly have oral morphine in Nigeria, but the drugs are expiring because prescribers don't even prescribe the drugs. So to address that is the issue of prescribers, and that is based on inadequate knowledge of our prescribers, doctors, nurses, pharmacists. Is the major problem. If those who are older in the practice will know that between late 80s and early 90s, these strong opioids were not available in Nigeria. So all the healthcare providers that were trained during that period never had opportunity to even gain access to how to prescribe and how to use these drugs. So there is inadequate knowledge. So the myth and misconception about opioids is still with the older prescribers. They are reluctant to prescribe because they are afraid. Many people believe that prescribing morphine to a patient will lead to the early death of the patient. There are nurses who will not even administer when doctors prescribe. This is inadequate knowledge. They know very little about it and they are running away from it. And that is what ACS is doing. They have been championing training of prescribers in Nigeria for the past almost 10 years. That is what we expect Federal Ministry of Health to also take on. Train the prescriber. The older doctors need to be retrained on the use of strong opioids for pain management.
Thank you, sir.
Pentazocine, if I had my way, I agree with you, pentazocine is a useless drug. If I had my way, it will never enter this country again. But it came in because when strong opioids are not available, that was the only thing that was available. And people are still using it today. But it's very ineffective. Now we have strong opioids. Let people get confidence and knowledge to prescribe strong opioid for pain management.
Thank you, sir. So as we get ready for the next presentation,
Hello.
Oh, you have?
Yes.
Okay.
You still have questions?
Okay, briefly, please.
Hello.
Respond quickly.
Yeah,
so
please.
the next session, as we prepare for the next session, please, ma, you can go ahead.
Hello.
And give a quick response.
So for us in American Cancer Society, we are worried that the uptake of NCCN harmonized guidelines is still very low, despite the fact that we have experts from Nigeria that participated in the development of the guideline. Two, that this guideline has been endorsed by Federal Ministry of Health. And part of our efforts to address this, to promote uptake, is what informed this project that we have introduced. And we also felt that there's need for those that were part of the development to help us create awareness. Because we know that it's something that in other countries is already working. So the issue of why the uptake is still very low is actually issues that the practitioners, particularly the oncologists, those that were part of this guideline, they need to take up. We actually plan to scale up the implementation of these projects beyond these 4 facilities that we are currently supporting, such that other facilities too will do the assessment and begin to train their healthcare provider on utilization of this guideline. That's one. Then number 2, on issue of morphine. I'm aware, just like Dr. Kolawole said, that Federal Ministry of Health has been consistent, at least in the last 3 years, in ensuring the availability of morphine. So it is shocking to note that at Aminu Kano Teaching Hospital, they do not have morphine. I'm also aware that some of these facilities, they have issues getting approval from their management. Maybe that was what happened. But I'm aware that they have been procuring morphine powder for the production of oral morphine solution from Federal Ministry of Health. I will follow up to really know what happened, so as to encourage them to have these products in their facilities. Thank you.
Okay. Okay, thank you. A round of applause, please, for our... sorry, just as you go, Prof just has something.
As you take your photograph, I think it's American Cancer Society to emphasize, why is it that only Ilorin was able to present in this conference? There were 4 institutions, centers that were granted grants. And the essence of the grant is to drive home these various points of the use of morphine, use of the guidelines, and the safety of chemotherapy. 3 aspects. And here we are, advocating, always talking about this, and there are grants given to how many centers? 4 centers. And only in Ilorin And we're not sincere. And let's stop going round and round. Let's find out why they're not presenting. The essence is to drive home use of NCCN guidelines for Sub-Saharan Africa. Use of liquid morphine and making chemotherapy safety for both patients and manpower. Thank you very much.
Thank you very much. Dr. Jimo, you are chairing the next session. So the next session, coincidentally, is on NCCN harmonized guidelines to be taken by Dr. Nwachukwu. She has 10 minutes.
Thank you very much.
So while my slides are coming up, Professor Adewi, that's why I told you that my presentation will answer your question. Okay? I knew that this was where you were coming from, and that's the reason why I'm here. It is also part of the plan to improve the uptake of the NCCN harmonized guidelines.
Dr. Alabi.
Okay, so can we remove that now? The meeting being recorded is stopping my... So National Hospital Abuja was one of the centers that received the American Cancer Society grant, and we opted to work on improving the uptake of the NCCN guidelines because we decided that we didn't just want to improve the uptake within our hospital only, and we're doing it as an FCT program. In our phase 2, we actually plan to increase the coverage to the North Central because we believe that the best way to be able to improve uptake is if we are including individuals. So in my center, what we're doing, we've done sessions for breast, we've done another sessions for hematological malignancies, and we call all the specialists in the FCT, including even Kefi, to come to join us, and we take them through the process of what we go through to look at the guidelines so that they understand the benefits of using it. This is not working, so please, next slide. Okay, so the session agenda is, just to let you know the benefits of using a guideline, about the NCCN guideline harmonization process, and the uptake and integration of the harmonized guidelines. Next slide. So NCCN guidelines are standard guidelines. And what are the benefits of using guidelines? It would, 1, improve patient outcome, including disease-specific survival. It would also provide an independent measure of quality of care and assist providers to keep up with the rapidly evolving evidence. Now, this I cannot overemphasize. Every time I open my NCCN app, I get a notification that there's an update available for me to do. Now, if you read from a text, the textbook will take probably 5 to 10 years to include what is new and what is you should be doing in 2023. But if you are using a guideline, because they are easily updated, NCCN guideline, for one, it's called a live guideline because it is being updated as things are going on. This is the reason why it is beneficial for all of us to practice using a guideline. I will talk about the benefits of a guideline shortly. And the last one is that it facilitates shared decision-making in multidisciplinary care. Because when the caliber of people who come together to put these guidelines, we have surgeons, amongst us, we have pathologists, we have gynae oncologists, we have radiation oncologists, medical oncologists. Everybody comes together from sub-Saharan Africa, and we look through these guidelines and we say, okay, how do we make it suit us? So the things that are not there, that are in our practice, we usually add them in blue. I'll come to that shortly. So the objective is that a guideline, a clear and simple guideline that points to the optimal treatment across different resource levels, while preserving as many options as possible for the oncologist. So you look through these guidelines, it will tell you what treatment options to give your patients and the best way to manage them. Next. What is a clinical practice guideline? A classic definition of a CPG is a systematically developed statement to assist practitioners and patients in decisions about appropriate healthcare for a specific clinical circumstance. Another beautiful thing about the NCCN guidelines, parents, is that they have guidelines for patients. So I always tell my patients to also download the NCCN guidelines for patients to give them information, because we don't have the time to be able to counsel them and give them all the information that they require. But if they have this, it is broken down to the level that they cannot easily understand. So it is something that I'm even also looking forward to doing a patient guideline uptake so that patients know about this. We'll gather all the patients together and tell them, how to use it. If a clinician can use a guideline in arriving at, a decision, then it means that guideline is useful. Guidelines should promote conformity and eliminate inappropriate interventions. Patients are becoming wise now. Legal cases are coming up. People are going to MDCN. They are complaining. People are losing their licenses. I read about suspension of 4 doctors last week by the MDCN. People are becoming wiser. So if they go and they see that you gave them treatment that is not within the guideline, I don't think you may be covered. So it is important for us to do this. Another thing is this would help to reduce the cost of care. Because if everybody is doing the same thing, then the government can say, we're procuring drugs because everybody is managing breast cancer in the same way. So they can procure drugs in bulk, knowing that. But if this person is giving this, another person is using that, when they procure your own drugs, the ones in the south are not using it, they will expire in the south. If we are all using one practice guideline, this will help us. Next slide. Okay, so this is just reiterating all the things that patients have better outcomes when they are managed using guidelines than when they are not. That's what studies have shown. Of course, like I said, malpractice and litigation. Next slide. In some other countries, okay, when you look at health insurance, if you prescribe something to a patient under health insurance that is not in the guideline, it won't be covered. So that alone forces you to make sure that you would, stick to the guideline, because if not, your patients will not be able to get what you have prescribed. Sorry, this ought to have been white. The African Cancer Coalition was formed in 2016 by the then Minister of Health for Nigeria, Professor Isaac Adewale, and Jackson Orem, and they told the ministries to nominate people to come from different countries. So that's the next slide showing. Okay. That's the next slide showing the collaborations. And these are all the meetings that we've had since 2017. So it goes from one country to the other, just the way we do for Arcon. And this year it was in Kigali earlier, and they are going to Zimbabwe next week. So the process, we have over 180 cancer experts from 34 countries, and Nigeria, like Professor Israel said, Kolawole, that Nigerians are involved in this harmonization process. But part of the things that I have always mentioned is that we need to do sort of like a re-harmonization process, because that's the only way we can say we carry everybody within this room to be part of it. So this was what birthed this grant to say, okay, let's start from institutions. And there's actually a phase 2 to continue to expand to different institutions within Nigeria so that we will improve the uptake. The Federal Ministry of Health is also driving this process, but it is really, really slow. And we don't have the time, like Professor Olasinde said, this has been on now since 2017, and we still do not have uptake as good as we want it to be. Okay, so this was, I think, when we were in Abuja, and we had surgical oncologists, medical oncologists, radiation, hematologists, gynae, pediatrics, all involved in this process. Why did we pick the NCCN guidelines? So there was a survey that was done first before the start. And
2 minutes more.
Okay. This was the guideline that was actually being used the most. So that was the reason why the American Cancer Society reached out to the the National Comprehensive Cancer Network to work with their guidelines. The process. So you have coalition members in different countries in sub-Saharan Africa. We meet, we sit down, we deliberate, and we look through the parent guidelines. And the things that are generally available, we leave them in black, which is the primary color that the guideline comes in. But if there's something that is not readily available, we change the color for that procedure or for that drug to become gray. It doesn't mean that you shouldn't use it. It just means it's not readily available, but you know that it is still something that you should offer your patients if they are able to afford it. Then we add in blue anything that is not a standard of care, but it's peculiar to us. So at the initial time when we started, we used to include chest x-rays because you couldn't find the x-rays as a staging procedure, but we knew that the CTs were not available. But from last year, because of the availability of CT scans, we took out the x-rays in blue and left the chest CTs in black. So these are a number of guidelines that have been done. It will be good for everybody in this room to download the NCCN guideline app today, if you do not already have it, and update and download all the guidelines, both the parent and the NCCN guidelines, to be able to see the difference between both of them. Like Professor Israel Kolawole mentioned, you can see here that Nigeria has endorsed this guideline. So, but the ministry is still taking their time to improve its uptake. What are the challenges? Of course, accommodating variability. So when we're sitting down, I used to say I don't like sitting down next to the Kenyans because when we're doing guidelines with them, they have everything. So we say, do you have PET-CT? Oh, yes, oh, they've had PET-CT for so long. Do you have one special testing? Oh, we've been doing this for ages. And everything is no for you and everything is yes for them. But we still take a vote, depending on the number of countries there, to say if we will keep it in black or if we will make it gray. So you would see the text looking like this, the color coding I mentioned. And like I said, the black text. So we have radiotherapy in black because it's available in some of the countries that are there. X-rays, ultrasound, pathology. And then in gray, you would have things like PET-CT, immunotherapy, specialized surgical procedures, and specialized radiotherapy like IMRT and VMART in gray. Then we have what we call the gray and strike-through. I'm rounding up now. Gray and strike-through, things like stem cell and CAR T cells therapies. These are gray and strike-through, meaning it's not only just not available, it's not available at all. So the strategies for dissemination is what this meeting is about. We are trying to do webinars for Nigerian clinicians led by oncology local experts. So the Ilorin team has come to give from their point of view. I'm speaking from Abuja point of view because it's part of what we said that we're going to improve the uptake. And then we'll outreach to major cancer centers to get the dissemination of the guidelines. Sorry, I'm going back. So in conclusion, we expect that this resource-integrated harmonized guidelines will provide oncologists with as many treatment options as possible, given the variability in the access to resources. We also hope that these guideline decision makers on which medicines and equipment that they need to procure for the country and create opportunity for regional collaborations around research, training, and program scale-up. Thank you very much.
Yeah, thank you very much, Dr. Ella. A round of applause for him, for her. Thank you. So the next speaker now is Dr. Lasibikon. Ready? Dr. Alabi. Yeah. Is Dr. Alabi in the hall? Dr. Alabi? Ella is already there. Dr. Alabi? Okay, it's all right. You can just start. Slides.
Okay, you are talking on ovarian function suppression, preservation in hormone receptor positive premenopausal breast cancer patients. Dr. Lashe Bikon, Dr. Alabi, and Dr. Wanchuku. So I think we can start.
Okay. Good afternoon, everybody. They're still trying to pull up my slides. So this session, I'm just going to run through a few slides around the evidence that we currently have as regards of the role of ovarian function suppression in the management of breast cancer patients, and also spend a little time on talking about how we can also use that to preserve the ovaries in patients that have early breast cancer. Okay, so this is my disclaimer and my disclosures. So the objective of this session is to drive the practice of ovarian function suppression in premenopausal hormone receptor positive breast cancer patients as recommended by the NCCN guidelines. We have been talking a lot about the NCCN guidelines, and more importantly, really, for us here, it will be the NCCN harmonized guidelines. So the second objective is to drive the need for fertility preservation for premenopausal breast cancer patients. We all know that, as we heard yesterday in yesterday's talk, patients that have early breast cancer should not be disenfranchised, particularly if they really want to have children. So patients should not lose the opportunity to have children because they have breast cancer. And then the third session objective really is to share experiences. And so we have two expert panelists in the house who will be sharing from their wealth of knowledge and their experiences on how they have used ovarian function suppression in the management of their patients. So I'd like to start very quickly with a case summary. So just to try and get a feel of what the practice is around here. And then I think that perhaps maybe at the end of the day, our panelists will be able to speak to it. So Chinenye is a 35-year-old banker who was diagnosed with T2N1 MOERPR positive, HER2 negative, invasive, grade 2 invasive ductal carcinoma of the left breast. She had neoadjuvant chemotherapy with AC ×4, and she then went on to have dose-dense paclitaxel ×4. Following post-mastectomy, Chinenye's histology report revealed that she had residual disease and lymph nodes 4/6. She completed post-mastectomy radiotherapy to this chest wall and nodal region. She's para-2, all females, and her name is Chinenye, and her menses have returned. So the question now is, in the adjuvant setting, what are the options for her? Option number 1 would be tamoxifen alone. Option number 2 would be tamoxifen and ovarian function suppression, while option number 3 could be an AI with ovarian function suppression, or for option number 4, perhaps AI alone. Unfortunately, we're not able to get the IT thing working together. Otherwise, we would have been able to do real live, survey to see what the rest of the audience think. But I'll just leave it to the panelists to perhaps speak to it and talk about the various options and which ones would be applicable and why they would choose what they would choose. So, like I said earlier on, we know that early breast cancer in young women is particularly challenging. Apart from managing the disease, we also have to manage the psychosocial impact more than even in the, more so, especially those that are in the childbearing age and still want to be reproductive. So
I just want to run through a few literature, some evidence that would perhaps guide us in our choice. So I came across this very nice article by Yen Shen Lu et al., which was a very comprehensive overview of ovarian function suppression with LHRH hormone agonists for the treatment of hormone receptor positive breast cancer. Now, they went in depth and did a comprehensive review, what was in the literature. We all know that there's benefit for it, how much of a benefit, you know, it's been here and there, the practice, we've been talking about guidelines and uptake. So the uptake really of ovarian function suppression as part of the breast management in the adjuvant setting of breast cancer has not been really as it should be. And this is not really just for us in Nigeria, but, you know, across also other parts of LMICs as well. So the objective, again, of the paper was to discuss the clinical evidence supporting the addition of the LHRH agonists to adjuvant endocrine therapies, the role of LHRA use in combination with adjuvant chemotherapy to preserve ovarian function and fertility, and then the important practical aspects of the use of LHRH in breast cancer treatment. One of the things that they cited was, of course, the popular SOFT and the TEXT trials that many of us would be aware of, you know. So I would just briefly run through the updated SOFT analysis of the SOFT, suppression of ovarian function, and tamoxifen and exemestane trial, which again has been there for a while. It recently got the analysis recently got updated because we now have more information on some of the endpoints that had been pulled up and stated at the time. So I just want to point out very quickly that the inclusion criteria for patients in this study was documented premenopausal status, right? That had to happen. But then the use of chemotherapy was optional. Remember, we're dealing with early breast cancer. In certain climes where they are sure about their immunohistochemistry status, they can actually also identify the risk stratification. They do omit chemotherapy. So chemotherapy was optional in this study. So a total of 5,738 patients underwent randomization. They were randomized either into the SOFT or the TEXT in the analysis. Under the SOFT trial, the patients, we had 3,066 patients who were randomized 1:1:1, one arm having tamoxifen alone, the second arm having tamoxifen plus ovarian function suppression, while the third arm was randomized to have exemestane plus ovarian function suppression. Now, the primary endpoint really was basically the primary endpoint for the SOFT was tamoxifen, the analysis of ovarian function, ovarian suppression. So the first one was tamoxifen plus tamoxifen alone. There was a comparative analysis. And then subsequently, in the secondary analysis, it was exemestane plus ovarian function suppression versus tamoxifen alone. So if you notice in this trial, the baseline was the base really was tamoxifen alone, and then they, you know, tried the intervention was using either the AI plus ovarian function suppression or tamoxifen, as opposed to TEXT, where the randomization was 1:1 with tamoxifen plus OS, ovarian function suppression, and again, exemestane plus ovarian function suppression. Now, I will just quickly go by. This was the trial design in the interest of time. Then primary and secondary endpoints, which I had mentioned, but I just want to go into detail a little bit because we will see some of the graphs later on. So the primary endpoint in this, in the time to event analysis was disease-free survival, which was survival-free of which was defined as survival-free of the first occurrence and of one of the following, either regional, local, or distant recurrence, and then invasive contralateral breast, while the second one also had to be with whether the patient had invasive cancer or, of course, death. The secondary endpoint, of course, was interval between when they presented with breast cancer recurrence, and so it was a breast cancer recurrence-free interval. Right, so I want to just point us out to the patient characteristics here to see whether they are actually relatable. Mind you, these patients are early breast cancer patients. You will see, I'm not sure whether the pointer is working, but in the first red box, for the lymph nodes that are positive, you will see that under the patients that had chemotherapy, it was quite representative because, you know, here in Nigeria, most of our patients do not present as node negative. So there was quite a representation of node positive disease, but then in terms of the size, it was more of early stage, less than 2 cm presentation, which again is really not the case in our client. So back to the results. The top graph on my left, that will be on your right, that's A, is the pooled analysis of disease-free interval for all the patients. We can see with the curve on the blue, the Kaplan-Meier curve on the blue, which is for exemestane. You see there's some, you know, slight differentiation, but if we look, and then the one below is the one for patients that did not have chemotherapy. So to point out why we are seeing that there's somewhat kind of an overlap here is because we know that patients who are low risk often would not be given chemotherapy, right? It's based on risk stratification. So the point here is that in this group of patients, we're having the estrogen, the hormonal manipulation with ovarian function suppression, would it really make much of a difference? But I'd like to point you to the graph on the right, which shows, which is basically for patients who have had chemotherapy, and we see that there's quite a difference with most patients deriving a lot of benefit from exemestane plus ovarian function suppression as opposed to tamoxifen plus ovarian function suppression. Same thing here we see from the forest plot that we see. All patients had benefit with the ovarian function suppression. However, you would see that particularly in the one with the green arrow, that there was quite a lot of benefit for patients who were HER2 negative in the exemestane and ovarian function suppression arm. So I'll try to speed things up. I think I have 10 minutes, right? I can't see. Okay, so time up. Okay, so I will try to hurry up. But
This is 30 minutes, so and you have spent 10 minutes now.
Okay, so in this other graph that we're looking at, again, just basically highlighting the strong benefit of exemestane ovarian function suppression in patients, in all HER2 negative patients. We can see that very clearly. We can also see very clearly that there's a stronger benefit in patients who had had chemotherapy before. Again, really stressing the fact that there's a benefit in patients who are high risk with using exemestane ovarian function suppression as opposed to tamoxifen ovarian function suppression. So in conclusion, with this study, I think they concluded that adding ovarian function suppression to tamoxifen resulted in significantly higher rates of disease-free survival, but further improvement was seen with the exemestane plus ovarian function suppression. In terms of side effects, because we know that ovarian function suppression is not easy on the young women, dyspareunia, vaginal dryness, loss of libido, and these are psychosocial issues that will be on the front burner for these patients. So I will quickly go through this. Please, I'd like to ask for 5 minutes. The Astra study basically is almost similar to the soft and the text, but I just want to highlight that in this study, right, it was basically highlighting the role of OFS in patients that still maintain their premenopausal status post-chemotherapy. So that was a benchmark for them. So with that, we know that there is this benefit just for the premenopausal patient. Now, another difference between this and the soft and the text trial that we have just looked through extensively is the fact that while the soft and text trial had women on this OFS for 5 years, Astra trial had them on 2 years. And I think this is really significant because we recently had a publication that looked at interruption of 2 years, interruption of their hormonal manipulation after 2 years for patients to conceive, and they found out that their risk of recurrence was not significantly worse. So I think that this really speaks to it, because then we can offer women who are really high risk. Again, patient selection will be critical, particularly for us here in Nigeria, but then we know that we can offer them something for 2 years and then perhaps have an interruption before they go on to have their babies. So again, that study was very, I mean, the slides will be there, but it was also very important because they showed a lot of outcomes for pregnancy outcomes and how the patients, the babies were alive and all of that. So as I round up in 2 minutes, I just wanted to highlight the efficacy of ovarian function suppression combined with adjuvant chemotherapy for fertility preservation in premenopausal women. And that is in the POEM study. This was a phase 3 trial of LHRH analog during chemotherapy to reduce ovarian failure in early stage hormone receptor positive breast, because we know that is a major risk factor, particularly for women that have cyclophosphamide as part of their chemotherapy regimen. So this is the schema for POEMs. I will not go through it, just to note that in the administration for preservation, goserelin was administered 3.6 milligrams subcute, but it was started at least 1 week prior to the first chemotherapy dose, and it was continued for duration of chemotherapy. So if we want to use it for for ovarian preservation, we should note the timing, which is critical to the success of ovarian function preservation. So I will run through it in the interest of time. I'm sure our panelists will be able to speak to it. But this study just basically buttressed the fact that those that had ovarian function preservation, we had increased numbers who attempted pregnancy, those that had chemotherapy plus goserelin as opposed to just standard chemotherapy alone. We see at the bottom total number of babies, 18 in the chemo plus OFS arm as opposed to 12, ongoing pregnancies, miscarriages. So all of them were all of those outcomes were definitely much better with the addition of ovarian function suppression. So with that, I'd like to end and hand over to the
Thank
moderator.
you very much, Arcon President, for this excellent presentation. Thank you. So for our panelists, and they don't have any presentation to present, but we want to call the audience if there are some questions they can ask, and so they can talk on that. Okay.
Answer the questions first. Perhaps they could also start with shedding some light on the question that was...
Yes, about the patient, Chinenye. So for Chinenye, she's a young premenopausal patient with high-risk early breast cancer. She would definitely benefit from the use of tamoxifen with ovarian function suppression to, give her better outcomes. So that would be my option for her, rather than tamoxifen alone. Like you also mentioned, the effects of the AI. I would likely start with TAM and OFS for her. Thank you.
You don't want to try the extreme exemestane?
No, not yet.
Why?
So it's still the side effects. Okay, so the side effects that come with exemestane as an AI for a very young patient, the osteoporosis. You didn't mention that. All the other symptoms, yes, but with the effect on their bones. But I'm sure a lot of us still give zoledronic acid to those patients who were giving AI2 to help their bones. So you need to give it 6 monthly for the protection for their bones. So that's what I would do if I was doing that. But I will most likely give TAM. Thank you.
Okay. Dr. Labi, can you just opine to that?
So I agree with her that I will do the tamoxifen with OFS. And this patient has started her menses again. So the probability that she's actually going to need it is higher. So from the Astra study that you have also talked about, patients who actually get OFS with tamoxifen, they have about 31% improved overall disease-free survival, and overall survival, 69% overall survival. So they actually do better than when we do tamoxifen alone. In the past, we never used to have the habit of putting them on, of doing OFS, but I think it's something we need to imbibe now. We look at cost and so many other things, but we need to imbibe it because it actually gives them better survival. Thank you.
Okay, let's give our audience to ask questions.
One kickback, you put the option of letrozole or an AI only. So I'm just wondering, is that a catch question? Because I don't see how someone would give a premenopausal patient AI only. That would definitely be doing ovulation induction and helping the patients to get pregnant, if possible, with triplets. Thank you.
Well, thank you very much. Nice topic, nice presentations. My questions are two. Number one, when you are doing ovarian suppression, is it at any point indicated to do estradiol to know whether you are actually suppressing the ovaries well or not? That's one. And at what point is it considering cost? Is it all the time that you want to be doing, or when it is already suppressed and you have seen the estradiol level, then you stop, for good? That's one question. The second is the use of the gonadotropin releasing factor, the goserelin that you have talked of. Most studies have talked of using 3.6 milligrams monthly. But we know that the cost implication and all that. Would you allude to using long-acting goserelin, 10.8? And what will be your catch when you are doing that? Thank you.
Yeah, thank you very much for a wonderful presentation. My question is somehow related to what Dr. Bello has asked. But the study you presented, the patient's category, I didn't get the age range, because the question I want to ask is, I saw somewhere it was mentioned that you use ovarian function suppression with tamoxifen for five years. If the patient is at borderline, almost becoming menopausal, will you be using ovarian suppression for that 5 years? That is the question.
Okay, so I will first respond to Dr. Bello's question. So, and that also applies to your question as well. That's where estradiol comes in. Most especially, so what we do now is when you think the patient has become, because sometimes when patient has taken chemotherapy, they become, they no longer see their menses. So they become like perimenopausal. So that's where estradiol may actually become useful for you, because you want to know whether these levels of estradiol have actually been reduced. So, but I'm not aware there are clear-cut guidelines as to when to do estradiol and when not to do it, but we just know that we need to, sometimes we need to look at those markers to be able to decide for the patient, especially when we're looking at cost. To decide whether to do the 3.6 or to use the 10.8, the guideline recommendations for this particular purpose of achieving OFS is 3.6. I've noticed that in some of their literature, 10.8 can actually be used, but not for the purpose of actually achieving OFS in hormone receptor positive perimenopausal patients. Sometimes they even recommend it for even if patient is not hormone receptor positive, for perimenopausal patients. So you can use 10.8 milligram for them, especially when you want to preserve fertility. So that is one of the recommendations. I don't know if I've answered this question. So his question, when the patient becomes perimenopause, so usually after 2 years, we can change to an AI, and the patient doesn't actually have to be on tamoxifen for that long. I don't know if there's any other.
Yes, I agree with Dr. Alabi's comments. So because especially for the very young patients, if you have very young patients who their hormone levels are still very strong, some people have noted that you could have breakthroughs in their hormone status when you use the longer acting ones, which was probably the reason why they're using the 4-weekly. But if you are able to, usually you would have a drop in estradiol in about 8 days of giving the injection, which is the reason why you also start it 1 week before the exposure to chemotherapy, so that by then you would have put the patient in the menopausal state. But like she said, Astra is actually the changing, because when Astra gave results similar at 2 years, so for most of my patients that are high risk, and I do give them, for those who want to try for a child afterwards, I usually give them the break after 2 years. Thank you.
Can I say something?
As with the Astra trial that, I mentioned earlier on, so that was actually one of the strong inclusion criteria for this trial. Before they were enrolled, patients were harvested, in quotes, put into the cohort after post-mastectomy, and all of that. But before they were really recruited into the study, they had to have their serum FSH level tested and estradiol tested as well. And then it is only when they became premenopausal, with those figures, that they were now included into the randomization pool for either tamoxifen with goserelin or tamoxifen alone. So just to reiterate the fact that it's crucial for us to continue to do that, otherwise it might not be cost beneficial.
Can I say something? Time up? Okay, thank you. Just for the purpose of clarity, I think before we put any patient, knowledge is evolving, so I may be wrong, but before we put any patient on A high, there are 3 major things that must be considered. The patient must be receptor positive for ER. The patient should be in menopause. If not in menopause, you have to ensure the follicular stimulating hormone estradiol are in menopausal level, or at the age of 60 years, when we have literatures that nobody could be menstruating at that age. So that we should know that when you are introducing AI, people should not do it arbitrarily, because people can just go and be giving AI without doing EHAP, immunohistochemistry. And the hazard ratio is 1.21. That means to say the use of aromatase inhibitors worsens survival in a patient that is not ER positive. So that must be very clear. So in our own environment, when we come to a premenopausal patient, before we institute AI, the patient must be in menopause. Not by age alone, by confirmation through the FSH and the estradiol. That is very important. I think we should not miss that. Number 2, in young patients that you have put on gonadotropin-releasing hormone, please, there is still a risk of getting pregnant. They should know that. And so they may have to go with additional family planning issues, because you'll be surprised in the course of using it, the patient will come with pregnancy. So we should know that when you are using ovarian suppression, it does not actually eliminate completely the risk of getting pregnant. Thank you very much.
Thank you very much. Account President, do you have any other question for the panelists? We have like 2-3 minutes.
Thank you very much for the presentation. I just wanted to find out whether there's a plan to, going forward, comparing the fertility, particularly we've had a few of our patients that are pretty young, hormone receptor positive, and maybe there's that the fertility status afterwards, as in the long term, because
Sorry, can you repeat the question?
For example, let me maybe I paint a scenario. There's a patient that is already on treatment, completed the chemo and all that, and we're supposed to still wants to have a baby. Now, is there a court to be able to demonstrate that, okay, fine, their best chance is to try after 2 years or after 3 years or after?
Yes, so she mentioned the poems. Okay, so the poem study looked at achieving pregnancy afterwards. So if you had done ovarian function suppression and there were patients who were able to achieve it. But, okay, Dr. Venner is no longer here. I know that we had spoken about doing it even if it's West Africa, okay, so that we can look at the patients who we are giving ovarian function suppression, maybe pre-chemo, and see if, we're actually able to conserve their fertility to like the way it was in other studies. So it's something that is actually worth looking at, and maybe we can speak to AstraZeneca to set up a trial. Yeah, I'm sure a lot of our young patients will be happy to participate in. Thank you.
Yeah, thank you very much. So we have come to the end of the session. Thank you. Thank you. Okay. Okay.
I think last year, Arcon, AstraZeneca presented justifying the efficacy of both 3.6 and 10.8 gonadotropin-releasing hormone antagonists. I mean, are you getting me? Agonist in the treatment of breast cancer patients. So we can use either. Thank you.
Yeah, thank you very much. The next section, Dr. Okwo, is he here? Dr. Okwo, Vitalis. What is it? Where is it? Yeah, yes. What is NCCN?
The next session is actually supposed to be the breakout session. Brachytherapy and gynae oncology. Professor Gigran, please. Can she please come forward? Dr. Adegboyega. Yes, that's your session, please. Okay. Okay, so you're welcome. It's an NLCC sponsored presentation. Okay.
Yeah, so we're going to do a little bit different, but I would like just to suggest that we could do a Zoom Akron brachytherapy session after this meeting, and I can set it up so I can work with the Mecca and get a Zoom session going over contouring and everything else. That would be a separate session for Akron. So we'll do that afterwards, and we can get it set up for maybe later this month. Does that sound good? Okay, let's definitely do that. Okay, so we're gonna.
Thank you very much. So it's an NSIA NLCC sponsored session. So you can please go forward.
Arconites should not forget to please vote. It's less than an hour to the end of voting. Voting has already commenced since 8 a.m. this morning. All Arconites, you would have received a link. Check your email for the code and the password. Voting is ongoing. Thank you.
Okay. I can't go back. Okay, good afternoon, everybody. So, the topic is 3D brachytherapy of gynecological cancer, the NLCC experience. So, the context of gynecological burden in Nigeria. Cervical cancer ranks only behind breast cancer as the foremost cause of cancer burden in Nigeria, accounting for 16.4% of female cancer. A 2021 report from the Human Papilloma Virus Center estimates that every year more than 12,000 Nigerian women are diagnosed with cervical cancer, and almost 8,000 of them will die from the disease. Then endometrial cancer accounts for 12.1.2%, vulvar cancer 0.75%, and vaginal cancer 0.03% in 2020. The NCCN guideline actually emphasized the place of concurrent chemoradiation and brachytherapy in the treatment of cervical cancer, especially from stage 1B3 to stage 2A and even to up to 4A. And then the principle of radiation therapy, there's a place of external beam radiotherapy where we're to give between 45 to 50 gray in 25 fractions. And then we come down with brachytherapy based on whether the patient has had surgery or not. So we give up to 24 gray in 3 fractions. And when patient had had surgery, it can be 5.5 gray in 2 fractions or 6 gray in 3 fractions to the subvaginal surface. So the brachytherapy actually involves delivering radiation treatment inside the tumor or very close to it, so as to give maximum dose to the tumor and you spare the OA house as much as possible using the principle of inverse square law. So gynecological cancer, especially cervical cancer, the goal is that we're giving EBRT with concurrent chemo and brachy, and all these must be completed in less than 26 days, less or equal to 56 days. So it's as if you are giving multiple treatments in correct timing for you to have the best outcome. So there are types of brachytherapy and the applicators. There's intercavitary brachytherapy where we use tandem and ovoid, tandem and ring, tandem and cylinder. Interstitial brachytherapy, then brachytherapy to the vaginal surface using the vaginal cylinder when patient had surgery. And then brachytherapy can even be a monotherapy, especially in early case like in endometrial cancer, either before surgery or after surgery. So these are some of the applicators. There's vaginal cylinder, tandem and ovoids. Then the interstitial needle with the grid, the tandem and ring. So coming to NLCC. NLCC is a marriage of 2 different entities, the Lagos University Teaching Hospital and Nigerian Sovereign Investment Authority. So there's a PPP, and that gave birth to NSI Luth Cancer Center. Before now, as Department of Radiotherapy Luth, the center actually commenced radiation therapy in 1969, when we had superficial X-ray and orthovoltage machine. There was cesium-137 manual loading brachytherapy as of 1973, a cobalt-60 therapy in 1975 and 1990, 2 Curatron in 1992 by IAEA, and the LINIAC machine was commissioned in 2001 by the VAMED projects. So in this new era, the PPP between Luth and NSIA, the former Department of Radiotherapy in Luth, was refurbished and re-equipped. So now we have 3 modern linear accelerator machines with our MRT and VMAT capacity. We have gamma med brachytherapy with 24 channels. All this was commissioned in 2019. And since its inception in 2019, we have treated 11,000 patients. Chemotherapy, we have over 10,000 patients that had radiotherapy, and about 215 patients that has had brachytherapy. So that's the center, the outside, that's our reception and the waiting area. That's our chemo safety cabin and the chemotherapy suits. Then these are the machines we have. We have 2 vital beams and 1 Alcyon machine. So coming to our brachytherapy session, our brachytherapy team consists of clinical oncologists, anesthetist, brachytherapy nurse, the medical physicist, oncology pharmacist, radiation therapists, the porters, and the patient at the center of it all. So that's our gamma med brachytherapy machine, and we have an ultrasound machine for ultrasound guide, at least for guided insertion. So in our center, we have basically tandem and ovoids, we have tandem and cylinder, and we have vaginal cylinder too. So basically for our patients coming in for brachytherapy, we take detailed history, examine, get the pathology, do basic workup. Ideally, it should be PET CT scan, basically because of the lymph node. You want it as small as possible, then to rule out distant metastasis. But because of cost, with the help of my mentor here, that's Professor Anuja, we have been able to arrive at a protocol, and this is the minimum we do. We do chest CT scan, and we do CT abdomen, basically to detect metastases and rule out para-aortic nodes. We do pelvic MRI to be able to characterize these tumor well, and then it also gives a better resolution for the nodes. So after assessing your patient to determine the applicator size, the angle, you prepare before on the day. We do a bit of bowel preparation. Patient comes in, MPO, and then there's bladder protocol. Anesthesia, either could be GA, where we use ketamine, or some of them we do under conscious sedation with a bit of analgesia. Then we actually do our insertion under ultrasound guided by the radiation therapist. So our principle for ovoid, you want it to be large enough for the patient. Cylinder diameter should be just small than what patient can tolerate. Then after insertion, you pack and then move patient gently, because our CT machine, our CT suit is a bit of distance from the brachytherapy suit. So in transporting our patient, you want to make sure that it's well packed and then moving them gently to make sure that the applicators are in place. So we have a CT simulation, usually 3 views, axial, coronal, and sagittal, and our CT machine is 2.5 mm slices. After this, we do contouring. You contour, delineate the high-risk CTV, intermediate-risk CTV, your airway house, which are essentially the rectum, the bladder, the sigmoid, and the bowel. Our doses are 8 gray in 3 fractions, or some 7 grays in 4 fractions. After this, the physicist plan to the tolerance dose, they digitize and normalize and do all that. Then the physician will review and accept, usually using the EQG2 Excel spreadsheet, and with this we're able to project even for subsequent fractions and arrive at a dose that is acceptable both to the target and the OA house, organs at risk. Then we have our QA, patient QA, applicator QA, doses and source. Then treatment delivery, patient is taken back to the brachytherapy suite and then connected, and patient is treated. After that, patient stays in recovery, especially those for GA, to be sure that they are fully conscious. Then we'll place them on some minimal TTH to take home, basically analgesia and antibiotics. So that's our recovery room with the nurse there. And this is one of our session, applicator insertion, and then contouring session. So our organs to be delineated, the OARs are essentially the sigmoid, the rectum, the bladder, and then the high-risk CTV and intermediate risk CTV. So this is still another contouring. After this is planned, for tandem and ovoid, the best is for you to achieve this pear-shaped planning, and then for cylinder, you have that. So this is the DVH. With this DVH, you are able to see the doses to the high-risk CTV, the red one. The pink one is the intermediate risk CTV, and we can see the wide gap between the doses to that and the OARs, which are actually as close to 0 as possible. So in the OARs, there's the small bowel, there's the rectum, there's the sigmoid, and the bladder. So that is the EQD2 Excel spreadsheet. Here you input the doses you are getting both to the target and the OAR for the first fraction, and then you project. If you get the same dose on subsequent fraction, will you be able to achieve your targets, both your dose to the target and the OARs? Then this also helps us to plan for subsequent fractions. Are you increasing your dose? Are you reducing your dose? If the doses to the OARs are too high, you want to decide whether to treat the patient with full bladder or with empty bladder. You want to decide if the bowel prep is not maximal enough. So this helps us to actually be able to project and then improve on subsequent treatments. Okay, then post-treatment, we usually have a happy team with the happy patients. So in the 115 patients we have treated so far, 78% of them is cervical cases and then 22% endometrial, and the occupation varies. Majority are in the private sector. The histology, 66% of our cases are squamous cell carcinoma, followed by adenocarcinoma. And the stages, we have a few, basically 2A, 2B, 3A, and 3B 15%, 3C 1%, 4A 12%, and a bit 14% are unstaged. The time between the first symptom and presentation, the peak is between 6 to 10 months. Only 23% gets to present under 6 months, and then some 3% actually present years later from the presentation. Overall treatment time, where this is analysis is being some weeks back, so I know our analysis is far better than this, but as at this analysis, only 34% of them get completed treatment within 56 days, which is the goal and the acceptable, whereas a majority of them falls between 57 and 100. What gave us this very bad report was at the initial time was when we had issue with our source. So quite a number of them had extended, delayed treatment. But I can tell you that we have improved on this over time. So survivor, at least the few ones we have been able to follow up, we have 92% survivor rates. So, and the mean fraction that we are having, most of them, the highest number is 4. Some had 1 fraction due to maybe uncompleted treatment, but the average was 2.7. Our brachytherapy doses range between 7 and 32 gray, and the mean is 21.15 for cervical cancer and 17.64 gray for endometrial cancer. And our mean total dose, your D90 high-risk CTV, the aim is for you to get between 80 to 90 gray, but our mean is actually 81.04 gray, which is within the acceptable dose. To the OA house, the bladder, you want it to get less than 90 gray, we are getting 73.75. Rectum, you want less than 75. Our mean is 70.75. Sigmoid and bowel in the same range. Our overall treatment time is 75.59 days, which is still higher than less than 56 days. Overall survival is 92%. Mortality cases, the few patients we have lost actually had comorbidities or they had poor KPS, even by the time we started. And also our side effects are comparable with other centers outside the country. And we're currently working on our late side effect profile. So this is our journey. When we had the machine in 2019, these are dry run by variant team. So all these ones, we didn't even have hands-on as at then. So Dr. Yubi came in at a time when we started the hands-on to put us through. And Onyinye, that's Onyinye Balogun in face mask, has always been part of our journey right from day one. She's been there even for the EBRT and external beam. That's Chika. Then she was in Stanford University. She gave us a few free-hand needles, interstitial needles. She took us on one. I think Dr. Joseph did a few sessions before we ran out of the needles. And that's our Professor Duro Simieti, has been our father. Okay, so this was my IAEA fellowship at Cancer Disease Hospital in Zambia with Dr. Ali Gombe. So the two teams from Lagos and Gombe with our physicist. And that's our host there, Dr. Zuzan. Okay, so we were fortunate when we were in Zambia. Professor Anuja came around with one of their projects that they're doing in Zambia, and we met her, and she was quite helpful too. And so that's the Zambia team too. So I was also in UICC fellowship at Slovakian 3 Center, and that's my host. And it was a good time. It was also a fellowship in brachytherapy, both cervical, gynecology, and prostate brachytherapy. So we also had variant training in Netherlands. That's our team, Dr. Andero and Dr. Alabi, with our therapist, Mr. Shaba. There they even had mannequin to practice. So hopefully we also get to have this so that when we don't have patients, people that come in can have something to actually have some experience. So in May, as NLCC, we held our Made in NLCC Brachytherapy Summit, which gathered people with special interest in brachytherapy from all over the country, and we have some virtual presenter, and Professor Anuja was also one of them. So these are some of the speakers there with Dr. Tolu from representing the parents' body, and these are the panelists. We had Dr. Nwako, Professor Adewuyi, and Dr. Ikile, Dr. Bello on the team. And so as an hospital, this is Alima Ata Oncology Ward. This does not belong to this. It was donated by someone to Luth. So it's a dedicated oncology ward. And so with this, we get to admit our patients. It's just at the back of the center. And hopefully by the time we start interstitial, the transporting them to this place that is close enough will be easy. Because when you put interstitial needles, you won't have them to go. They have to be admitted. So our challenge so far has been source change, but we have been able to overcome that. Our present source will expire, and then we're expecting another one on the 18th. So before it gets expired, we have been able to overcome the delay. So an extended overall treatment time, there has been so much improvement. So our major issue is that interstitial brachytherapy experience. Why? Because the kind where the stage we start with, by the time you have done EBRT, our residual disease is usually too big, so it's actually meant to be treated with interstitial needles. Then we need more applicator, tandem, and ring, more hands-on training and retraining, and we're also open to collaboration. So our goal as a center is to be a brachytherapy training hub or radiotherapy training hub in Africa, continuing the brachytherapy summit for more knowledge acquisition and sharing. We want to build brachytherapy special interest group, and then want to generate our local data from our experience and then collaborate. So I want to appreciate Dr. Onyinye Balogun, Dr. Dayoni Tilo and team. Also, they came when we're starting. BVGH have been having series of training and then facilitate trainers like Dr. Yubi. Professor Anuja Jingra has been a mentor from way behind, and she's been very supportive. In MSKCC, my host was Dr. Marisa Kumaya. In CDH, we had Dr. Susan Masadabwe, IAEA, UICC for the fellowship, and our PA, Ms. Taiwo. So that's my references. Thank you, and we take questions. Dr. Professor Anuja.
Yeah. No, I just, this is for questions, but I want to commend what you're doing in your program, and it would be great to have a brachytherapy hub here in Nigeria where people can come and learn and train. I mean, that would be amazing.
Thank you very much. We want to take just very few questions so that we can go ahead. Please, those for the abstract presentation, the list here. Please, can you just forward your abstracts to the IT session so that they can upload them? You'll be coming up immediately after now to be anchored by Dr. Folashire and Dr. Obo. Please, question.
Yeah, thank you very much, Dr. Adegbega, for a good presentation. I just want to find out, with this beautiful experience, the follow-up, you said 92% survival. What did you use to assess them? Because if you are outside radiotherapy center, like I am, I see a lot of recurrence from patients who would have taken external beam and have done intercavitary brachytherapy. So, of course, if you call them after a year or two, they are still there, but they are battling with recurrence. So, are all the patients that you did brachy for, you are able to follow them? Do they come to you for follow-up, or they are in other centers? Thank you.
Dr. Adegbega, I must commend your center in many fronts, because it is obvious now that we, the practitioners, are beginning to speak out what we do, what we say. We are not depending on what is published in the books. So I commend you on trying to bring out your experience, one. I also want to commend you, number two, for stretching out your beautiful arms to other centers, calling them often for a summit, for a review, and all those things. It's very important. I also want to stretch the point, or how do you say, stress the point that brachytherapy is one of the most important components when it comes to survivorship in cervical cancer. And many a times, we are limited by the dose we can give, either at the external beam, which must be compensated for by the brachytherapy. But obviously, when the external beam is already too low, the brachytherapy does not take care of the regional lymph nodes, does not take care of any tumor outside the area of the cervix. We have to understand the limitation of the brachytherapy. It is meant to destroy the primary tumor. Wherever it has gone to the lymph nodes, your chemotherapy, chemoradiation must be adequate enough to undo that. So just to commend you that survivorship in cervical cancer is multifactorial. I've heard from some centers that the tumor keep on staring at them. Then you must do your quality assurance. You must check why. After external beam and chemoradiation, you are still seeing the tumor staring at you. What is going on? Is it that there is geographical miss? Is it that the dose is too low? Is it that you are not actually treating? We need to find out. Because brachytherapy alone cannot do the miracle when the tumor is outside stage 1. Thank you very much.
Okay, do we have more questions so that they can take everything at once? Okay. Professor Dr. Egbinoba.
Thank you very much. Once your service is stage 3, you will need to block the midline and deliver. I'm coming. And deliver doses to the pelvic side wall. I'm talking about pelvic side wall now. Because if you are going to give brachytherapy alone, an external beam, there may be cases that will come up later. I don't know whether you do, how do you assess whether your cases are cured or not, or disease-free? Do you do a PET? I don't think patient you have the ability to do a PET to assess that. And again, secondly, is there any experience with chemotherapy in brachy in your center? Do you have to give chemotherapy at any stage? Thank you very much, because we're silent on that.
Okay, so I'm going to start, and Professor Anuja will complete. Okay, so Dr. No, yeah. Okay, sorry. Maurice, sorry. That's why I put it as overall survivor. So what we have done as at that analysis was to call them, are you still alive or dead? So it was just overall survivor. As for those that have had recurrence, so like I said, we have started our late side effect toxicity and follow-up. So what we intend to do is, we work with the referral, the physician that refer them, and then we also set up virtual follow-up for those that will not be able to come. So, and it's going to be, there's a protocol we're bringing up, how often we get to see them, and we examine and we request for investigation, such that even if they cannot come to the center, if I'm working with you, if a patient is coming from your center, I will call you, we'll do it together. You get to examine, then we get to do imaging at interval. So that's the part we're on now. But what we did so far was just overall survivor, who is alive or who is dead. So we are working on that recurrence and how many of them get to be disease-free. I think that's the only question. So for Prof, and this will also answer Dr. Ibinoba, for those that have 3A disease or nodal involvement, depending on the extent of nodes, we actually give a boost to the nodes and to the pelvic sidewall up to 60 gray. So it's only to the cervix to give 45 and 50. And I know one of your lectures, you actually mentioned that even those that are huge, you want to aim to get even above 90. So that will start from your EBRT, then you go to prostate, to the brachy. So for those that have nodal involvement, we boost the node to at least 60 gray. While to the cervix, we give 45 or 50. So we actually factor that in. And then there won't be need for, because we are doing image guidance, there won't be need for blocking the midline, but we actually factor that into it. So talking about those that are not responding to treatment, there's a study we are working on with her. It's a microbiome study. She's going to talk more about that. And it's just to know what is different or what is peculiar to us they have done the same study in MD Anderson. And they've been able to identify some agents that are responsible for those that will be resistant. So we want to try and replicate the same. So we have identified some centers, but of course we can also open up to do the same study. Let's see if there are some microorganisms that can actually be identified that may be responsible for the resistance. Then the study about the question about neoadjuvant chemotherapy generally is also something we are working on. And we have had, like I said, after EBRT, ideally before EBRT, we do pelvic MRI. After EBRT, we are supposed to do pelvic MRI to know before going for brachytherapy. But most of our patients actually get to start late. The disease is bulky, and some of them, by the time we are examining, after EBRT, we try to examine before we go for brachy. If there's obvious residual disease, we insist on them going back for pelvic MRI. And if the thickness, if the disease is bulky, some of them will cone down. We have not been able to have enough data to substantiate that, but we cone down because we know then that our tandem and ovoid might not be able to treat. So we still do a bit of cone down. Some of them, like if they have extensive disease, and then some of them, there's so much infiltration into the bladder and rectum, we have to do some neoadjuvant. But we're working on a protocol to be able to do a trial based on that. Also, we're working with them to know those we put on neoadjuvant, and the end product is actually to see that by the time we are finishing EBRT before brachy, we are near to no tumor, such that our tandem and ovoid can be able to take care of that. So we have so many. So I'll just allow to shed more light.
Thank you very much. You just have 5 minutes so that we'll round up this
Yeah,
session.
I'm just going to address the midline block. So yes, I agree. If you have 3B disease, you, like we said, you have to boost the pelvic sidewall. So if you do 3D conformal, you can do a midline block. If you do IMRT, then you're boosting it with IMRT. So yes, I agree that pelvic sidewalls will need more dose, exactly like we just said. Chemo with brachytherapy, we do give chemo, we just don't do it the same day as the brachytherapy. So as long as you do it the day before or after, you can give chemotherapy with the brachy, you just can't give it the same day. So I hope that I addressed those two questions. And like I said, we do, as we said, we do boost the nodes to 60 to 66 using the contribution of the brachytherapy. So it is important that you do all of that. And I 100% agree, you do need to take the sidewalls a little bit higher for stage 3B. The only one thing, caveat is for 2B, if you do not have perimetrial disease at the time of brachytherapy, you do not need to boost the perimetrium. So that's the difference. So we are no longer automatically boosting the perimetrium anymore. It just depends on your response rate at the time of brachytherapy. And yes, we do PETs. We do PETs at 3 to 4 months after radiation therapy. And if they're negative, we consider them that's it. And if there's still some residual disease, we will repeat the PET because radiation does continue to work. And in Australia, they actually do the PET at 6 months because radiation does continue to work. So, that's just a thought process. That's it.
Thank you very much. Thank you very much. So, the photograph, very quickly, please. I don't know if Pearl Oncology is ready so that we can quickly have them before we take the abstracts. Pearl Oncology, are you ready? Okay. Are they? Are you ready? So quickly come up. We'll just give you 15 minutes, please. Please make sure your abstract is up there. Immediately after this, we'll be taking the abstract presentation. Just check and make sure yours is part of it. And the presenters, are we all here? Are all the presenters or the representatives here? Okay. So, Pearl Oncology, 15 minutes, please.
Good day, ladies and gentlemen, esteemed oncologists and doctors from around the world, and our very highly distinguished guests. You're welcome to this gathering of brilliant minds dedicated to the battle against cancer. My name is Elizabeth Downsey, and I am the growth manager at Pearl Oncology Hospital. Cancer, as we all know, is a relentless battle. It shows no mercy or prejudice to its victims. Its multifaceted nature demands that we pull together our resources, our knowledge, and our experiences to navigate its complexities. Hence, we host events like this, conferences, and on that note, I would like to give a warm appreciation to Arcon for ensuring that this event is a memorable one. Now, for an introduction to Pearl. Founded in 2021, Pearl is a Lagos-based chain center spread across Lagos. We are located in Lekki, VI, Bagada, and Ojo. We prevent, diagnose, and treat cancer. We have over 45 years of clinical experience delivering humane cancer care with science and compassion. Our vision is to be the first choice of humane cancer care and an ally to conquer cancer in Africa. Our mission is to prevent, diagnose, treat, and palliate cancer. We have 5 core values, starting with empathy. We are patient-centric, and we believe in growth and partnership. Our final core value is innovation. Our comprehensive services cut across the entire cancer continuum. From treatment, we offer surgery, chemotherapy, immunotherapy, and hormone therapy. We also have digital imaging services such as our mammogram and sonography. Our rooms are en suite, and we offer the best palliative care. We also have ward admissions, and we offer programs like our psycho-oncology and oncofertility programs. And to top it off, we offer virtual cancer care through our Oncopadi app. Our locations are spread across Lagos, and our headquarters are in Lekki. We have a 12-bed cancer center. We are also embedded in the Nigerian Navy Hospital, Ojo, which is a 6-chair chemotherapy day center. We are located in Al Jalad, which is also a 4-bed chemotherapy center. And finally, we are located in VI at St. Nicholas Hospital. Our unique value proposition is our team of award-winning oncologists. We are led by the renowned Dr. Omolola Salako, who is a global health leader and a winning cancer researcher. Pearl Oncology is the optimal choice for referring your patients. We have taken the time and effort to immerse ourselves in our patient's journey to deliver the highest quality care. With that in mind, we trust that Pearl will be your first choice when considering patient referrals. Thank you. On that note, I would like to pass the phone to Dr. Adaora, who is our renowned Director of Innovation. She's going to take us through our latest product, the PROS app. Thank you.
All right, good afternoon, my amazing oncologists, cancer specialists, greatest Arconites. Greatest Arconites. I mean, the energy, this is not the African Nigerian energy. Greatest Arconites. Thank you for that. It's a pleasure to be here. We're excited to be here. And today we are going to share with you an amazing innovation that has come all the way from Pearl Oncology, which is our PROS Care app. All right, so we know that currently our cancer mortality is on the rise, and it's estimated that cancer mortality will get to as high as 1 million by 2030. And so there is a call that many institutions, be it our hospitals, be it as specialists, we need to begin to invest in mobile technology, because we know that mobile technology can improve cancer care and improve cancer control. And so according to the Lancet Oncology Commission for Sub-Saharan Africa, it's encouraging stakeholders across globally to invest and adopt telehealth. Now, we did some research. One of the research we did, which was in 2020, where we established that there's an innovative use for mobile health and clinical technology in oncology clinical trials in Africa. And what this research showed us that there were so many roles that technology could play in expanding clinical trials, and more importantly, the lure of mobile health promises disruptive, technology to our clinical trials that can be conducted in several settings. We also did a DigiPulse study, and this helped us to capture the stakeholders' perspective and helped us in shaping how we built some of the tools that we have developed today. We also used this study to sort of make a case for why digital technology was the next big thing or the future of cancer care. And so let's talk about PROS. What is PROS? PROS is our patient-reported outcome side effect monitoring tool that helps us to prove that you can generate evidence for remote symptom side effect for the African cancer patients, whether they are on radiotherapy or they are on any form of systemic treatment. And so we know that all cancer treatments, be it radiotherapy, be it chemotherapy, be it immunotherapy, all cancer treatments come with side effects. And there is a high incidence of side effects. But sadly, these incidents of side effects are being underreported by many of our patients. We know that many of these side effects happen when our patients have left us in the clinics and are at home. And so because of the lack of support many of these patients, receive due to non-clinic hours when they experience these side effects, we find out that there's a poor quality of life, and many times there's a decline in their treatment outcome. And so we developed the PROS Care app. And so what is the PROS Care app? The PROS Care app allows you to monitor your patient's side effects remotely from anywhere in the world. And so on the patient portal, patients are able to report their side effects in real time on a day-to-day basis. They are able to report their side effects in real time on a day-to-day basis. There's an increase, they feel the quality of life survey. They are also in tune to report some of their medical profile and information. They get clinical advice in real time from their medical team. They have access to a lot of educational resources about side effects, and they know what to do when they experience these side effects. And more importantly, many of this data that we've captured will provide our physicians with clinical insights that they use in monitoring their patients. And so the ProsCare app was first piloted at the NSIA Lutz Cancer Center last year. And what we did was that we captured over 137 cancer patients. Many of these patients were adult patients above the age of 18 and had a CANOPSI performance score of more than 70%. And all the consenting participants of this study reported their side effects on the ProsCare app on a daily rate. Now, what we found that out of 137 patients that were enrolled, we were able to capture more than 50,000 treatment side effect entries and more than 193 quality of life surveys across 64 messages from their care team was captured. We had an app utilization rate of 63% and an average of 200 treatment daily side effects were reported, and we followed up these patients for about 7 weeks. In conclusion, we would like to tell you that there is really a need to actually support and monitor patients despite the limited time we spend with them. And the ProsCare tool is that innovative solution that can help us to remotely monitor and manage our patients outside of the clinical setting. So please join us in managing patients, and more importantly, join us in generating real-world data in the development of clinical algorithms that can provide automated clinical advice and predictive models for these patients. Thank you so much.
Thank you very much, Per Oncology. I want to say we really appreciate what you are doing, because I really know that patients have issues with navigation during their treatment journey. Yeah. So it means that now patients can actually get good access. But for patients that cannot have access to mobile phones and internet, how do you want to help those kind of patients?
So luckily, we just recently received a grant courtesy of Pfizer, the Global Bridges Oncology, which is supporting us to expand the development of our app and being able to incorporate USD platforms that will capture patients in remote areas that don't have access to internet facilities.
Thank you very much. Please, do we have questions very briefly? Questions for Pearl Oncology? Okay, so that means, okay, we have one. Okay, please, very quickly. Dr. Kolawole.
Thank you very much. Thanks for your presentation. I know that Uncle Paddy has been with us for quite some time now. And it's heartwarming to know that you are still growing. But in your team, do you have a palliative care provider? Do you have a clinical psychologist in your team? Because these are very relevant and they are useful. Do you have this?
Yes, sir.
Okay.
So as part of this, what we call the STAR pipe, which we are using to actually standardize acute reporting of side effects, we're actually collecting the general physician's perspective, also including the psycho-oncologists, their perspective in actually supporting patients that are experiencing treatment-related side effects. And more importantly, we have advisors who are palliative care specialists outside of the country that we are capturing all of their insights when developing these tools. Thank you.
Thank you very much, Per Oncology. So right away, we'll be going to the abstract session. So I want to invite Dr. Folashire and Dr. Obo to come and chair this particular session. The first one here is the efficacy of whole brain radiotherapy and survival outcome in patients with brain metastasis in NSIA Lutz Cancer Center. Please, I want to also announce that we have just 2 minutes for the election to close. If you have not yet voted, please don't enfranchise yourself. Kindly go to your email, it's there, and vote. Please let us vote. Thank you very much. So, over to... Yes, everybody should please come up. Everybody should please come up. Once in your presentation, you said that's the first one. The second one is knowledge of breast and cervical cancer among female high school students in southeastern Nigeria. So if your presentation is here, please just come up.
Okay, yeah. We'll be starting this session. Afternoon again. For this session of abstracts, we'll be having the following people. Please, you can kindly come out if you are here. Efficacy of whole brain radiation and survival outcome in patients with brain metastasis in NSIA Lutz Cancer Center. Dr. Adegboyega. Dr. Shere Obi will be presenting knowledge of breast and cervical cancer among female high school students in southeast Nigeria. Dr. Pukwola, Quershot technique in palliative radiation therapy of head and neck malignancy, muscle root experience. Please, I want them to come out. Please, if you are here, please kindly come out on time. Then Dr. Adegbeson A will be presenting barriers of cancer patients towards utilization of palliative care services at University College Hospital, Ibadan, Nigeria, a pilot study. IB Wadai will be presenting the Nigeria Association of Medical Physicists and our commitment to save an effective cancer. So we can take the first three. So, Dr. Adegboyega, you have 6 minutes each, then 2 minutes for questions.
Thank you.
Who is our timer, please?
Yeah, good afternoon, SARS and Ma. All protocols duly observed. So I'm taking these abstracts. Efficacy of whole brain radiotherapy and survival outcome in patients with brain metastasis, NSIA Lutz Cancer Center. And these are the authors. So brain metastasis is a common occurrence in patients with advanced cancer. They are extremely challenging to treat, resulting in short survival period. Consequently, whole brain radiation therapy remains the standard palliative intervention for patients with brain metastasis. This study focuses on palliative whole brain radiotherapy or brain metastasis and uses standardized questionnaire for patients to self-report the symptoms and the quality of life. It was a prospective longitudinal hospital-based single-center study, and then we had consecutive sampling method to recruit the 52 patients involved in the survey. Then we had a patient-reported outcome along with their demographic data were collected using a survey question from the European Organization for Research and Treatment of Cancer, Quality of Life C15 Palliative Standardized Questionnaire. The responses were collected before they start treatment, 1 week into the treatment, 4 weeks post-treatment, 3 months, and 6 months post-treatment to inform on the currently unmet needs, the efficacy of intervention radiotherapy. Then these responses were linearly transformed according to the HEOR-RTC scoring manual to a 100-point scale. High scoring functionality is favorable, while low scoring symptoms are not. The results. The study cohort was predominantly female in 82.7%, and accordingly, 65.4% had primary breast primary tumor, being the commonest cancer seen. The median overall survival was 6 months. There was significant improvements in their physical functioning, emotional functioning, the visual disorders, the motor function, and communication deficits between the baseline and at 90 and or 180 days compared to the baseline. A total of 20 patients, that's 38%, survived up to 180 days post-treatment, and they reported alleviated symptoms and better functioning. There was alleviation of pain, fatigue, insomnia, which are the most common benefits reported by the patients, at least for 3 months after the whole brain radiotherapy, and there was steady improvement in the quality of life up to 3 months. With this quality of life score increases from 48 at the baseline, we had up to 63 by 90 days. And these are the figures at the baseline for the quality of life. By day 7, we could see obvious improvements. The lines are going up. By day 30, day 90, and then day 180. And then the other parameters that were also assessed, fatigue, pain, with the color code, dyspnea, insomnia, appetite loss, nausea, and constipation. We could see that the bars were going down from 1 week post-treatment. And this is the quality of life. By 1 week post-treatment, there was improvement, a bit of a plateau for up to 1 month, and then by 3 months, there was improvement. By 3 months, that's 90 days, it started to drop again. So in conclusion, whole brain radiotherapy is an effective approach to improve quality of life and the functions and symptom severity. However, it's shown that after 90 days, many patients experience decline in their benefits, indicating that further investigations in palliative symptom relief is warranted. Thank you.
Yeah, thank you for keeping to time. So, I think after the 3, then we'll take questions. Next person is, okay, Dr. Shiwelbi. You have 6 minutes. The time starts now.
Okay. Good afternoon, professors, consultants, residents, and other distinguished members of the crowd. My name is Dr. Shiwobi Noma, and I'll be presenting an abstract titled The Knowledge of Breast and Cervical Cancer in Secondary School Girls in Enugu. Please, my slides.
Media, please. After her, we'll be taking quad shot technique in palliative. So please, get ready for us. While they are putting up the slides, please let's be informed that dinner is going to happen today. So all our dinner attire should be ready. Okay, you can start now.
Okay. Knowledge of breast and cervical cancer in secondary school girls in Enugu. I'm Dr. Shiwobi Norman. These are the co-authors of this abstract from UNTH. Okay. So this is my background. And generally, we know that globally, breast cancer is the most common cancer affecting females, while cervical cancer is the fourth. But despite the increasing awareness of these cancers, there is still a rising incidence in the low and middle income countries, of which Nigeria is one of them. And this is largely because ongoing awareness campaigns are targeted on the adult population, and these people would have already adopted lifestyles and habits that increase their risks to these diseases. On the other hand, the adolescent period has really shown a significant window. So in line with this year's World Cancer theme of closing the care gap, we decided to do a grassroots advocacy campaign targeting young children. And this pilot study therefore provides evidence of the impact of health education in these age groups, which could provide and guide cancer control efforts and policies. So our objectives were, one, to assess the level of knowledge of breast and cervical cancer of female secondary school students, and to also assess the impact of education on their level of knowledge. It's a descriptive cross-sectional study, and 3 secondary schools were selected randomly from the 3 local governments in Enugu metropolis. Ethical approval was gotten from the post-primary school management board. We had a pre and post test conducted with a 30-minute PowerPoint-aided teaching in between. So this is a picture of one of the schools that we visited. And so far, these are the results from the 3 schools, School A, B, and C. We had a total of 591 and 600 responses for the pre-test and post-test, respectively. The median age of these respondents were 16 years. And the results showed that 56.2% had good knowledge of breast cancer in the pre-test, while it rose to 96% post-test. And 34.9% had good knowledge of cervical cancer in the pre-test, which rose to 95% post-test. This is an overall diagram showing the overall knowledge score, which will be explained in the next slide. So it showed that 43% of the participants had good overall knowledge of both cancers in the pre-test, while it rose to 97% in the post-test. Therefore, there was a statistically significant increase in their level of knowledge in the pre-test compared to the post-test. Also, older participants showed significantly better knowledge after the pre-test. And however, there was no significant difference observed between age and knowledge after the post-test. So in conclusion, there was a significant increase in the level of knowledge of breast and cervical cancer among the students following intervention with no age difference. Thus, there is need for increased cancer awareness among young people, which would impact their lifestyles and then empower them to become advocates. And as we all know, as the HPV vaccination is going on, this could also lead to decrease in resistance to vaccination. So going forward, we want to expand the health awareness campaign to other secondary schools in the state, including the private schools, and also to revisit the schools that we have already gone to with a view of forming school clubs for continuity in health education. Thank you.
Thank you. You can take your seats. Right, the next presenter, Dr. Pokwala, will be coming up. Quad shot technique in palliative radiotherapy technique of head and neck malignancies. Marcel Root experience. You have 6 minutes.
Please, technical, after him, we'll be having experiencing the Nigeria or introducing the Nigeria Association of Medical Physicists and our commitment to safe and effective cancer treatment. Anti-proliferative activity of ephobia agents extract against prostate cancer cells. After this presenter, we'll take questions for the first three groups.
So sorry, I'm trying to sort out my slide. I'm very sorry.
Okay, maybe we can take questions for the two people that have presented. Dr. Pokola, meanwhile. Let's take questions and comments for the two presenters. Yes, sir. Okay. Professor Lassie first, please. Sorry, sir. Okay, sir. To you.
Thank you to the two presenters, Dr. Adegboyega, for the whole brain radiotherapy. You did not tell us, is it just whole brain radiotherapy you did for this patient? You did not combine it with other treatment, whether you give steroids to the patient or not? We need to know. Then secondly, for all the metastases, is it the same dose you give to all of them or what? We need to know from your presentation. To the other lady who presented on the knowledge of breast and cervical cancer among female high school students. Look, from what you presented, the three schools are eyebrow schools. It's not a true reflective of situation. I'm not staying in Nedungu, but these three schools you picked, why don't you move to the rural areas? Or even, but I think in your conclusion, you try to remedy it by picking, maybe you pick one eyebrow school and you pick one private or public school that the public students of the downtrodden are attending, and you can, that will give us a true reflection of the percentages you've given us. Thank you.
Give it to Professor.
Thank you very much. Dr. Adegboyega, I think it would be good to include in your protocol, why do they relapse after 3 months? Is it residual tumor? Is it complications of your treatment? Is it whatever it is? I think we should know why this patient's quality of life deteriorated after 3 months. Thank you.
Dr. Ibinoba, please.
Thank you very much, Dr. Adegboyega. Your presentation. It's metastatic cancers, and you are addressing with whole brain. I think you should let us know whether it was there were oligometastatic lesions, or there were more lesions. Okay, and if there were those lesions, perhaps the size of the lesions, because this will help in coming and deciding on the prognosis or the outcome of your result. Thank you.
I want to thank the two presenters. My question goes to Dr. Shiwobi. I want to commend that work because looking at it from the grassroots, from secondary school, it's very good. Like has been said, we should go more and have a better sample, random sampling from different locations. Then also, not just knowing alone, I want to also go further by helping, talking good health talks, healthy lifestyle, what they can do at that level, even to prevent, and talking about the different levels of prevention of cancers. If you can also go into such studies and look into that. Thank you very much.
Okay, the last question.
Okay, thank you very much for the presentations. My question goes to the second presenter, Dr. Shiwobi. I think I like the concept of the research in which is tending towards prevention. But I would just like to give a pointer to some things that should be corrected in the next time. After you give a presentation and you test the person 30 minutes after, you're actually testing memory, not cognition. So testing memory does not really test the knowledge. Those same people, when you test them 2 hours later, 1 day later, or 3 days later, you will be surprised that the rate of whatever is going to fall. And then if you test memory, you may not really be able to really ascertain that this is actually knowledge impacted. And then the second thing I want to just say is when we are putting programs, there's a difference between awareness, health education, and health promotion. In the end, we want a behavioral change, not just people knowing. So if you don't target the health promotion, even with the awareness or the even with the awareness and the education, they may not really be able to get so we should target it around other activities that can reinforce. For instance, after giving the lecture, give them a pamphlet that they can be able to go and further read, or some educational materials they can refer to. Thank you very much.
Thank you very much. Dr. Adigwega, I have a question for you, just one. For the patient you mentioned with the whole brain metastasis, we've had cases where patients are treated with whole brain EBRT, and for some time it's a stable disease, then you now experience progression, as evidenced by imaging. You now probably have new lesions in the brain after some time. Would you ever consider maybe retreatment? For how long would that be if it's something you are considering? Because at that point, they've had chemotherapy, first, second line, and all that. So would that be an option for you at this time for them to control the disease locally? Because normally give not too high doses, at times 25, at times give 30 grays. So would that be an option for you? And if it would be, after how long would you want to consider for them to have retreatment? Thank you.
Okay, Dr. Adegboyega.
Thank you very much. Okay, so I'm very sorry for not mentioning the dose and the steroids. I think I overcut the slides all in the attempt of saving time. So thank you for bringing that up. So we had 2 doses. Some had like 21 patients had 20 gray in 5 fractions, while 31 patients had 30 gray in 10 fractions. Then all of them had steroids, either before or during the treatment, like that. So what we noticed was that at 90 days, there was all the successes were going down. Unfortunately, so that's our next level, is to try and find out what are the factors. 90% of our patients had multiple. In fact, there was no oligometastasis actually. So I think what we want to do next time is that to try and break it down to those that had 3 or less metastatic sites and to those that has more. So maybe that will help us to know what is the factor at that 90 days that is causing that. Then some of because of in our center, so I think this will address some of your question, that if they are having whole brain, so there's a place of some people are having like partial brain. If you are, because it's image guided, we're able to see, So in such a case, somebody that had not been, if the site has not been treated before is having a fresh tumor, of course, we can re-irradiate. And even those that have had radiation before, like after 1 year, we can re-irradiate. And then just before we came, Professor Showumi had experience with our therapists that are able to re-irradiate even under 6 months. So because of the kind of machine and image guidance and the fact that you're able to monitor the doses getting to where, so there's a place of re-irradiation. Thank you.
Thank you so much. All the comments are well noted, and some of them we have actually addressed in the sense that for the health talk, we really give the children health talk. That's the 30 minutes aided talk or session with them involves a health talk on the risk factors and other predisposing factors to both breast and cervical cancer. And then for future directions, we are really planning on expanding this awareness campaign. So we are going to reach to other schools and then have a wider coverage and better sample. And thank you, Dr. Omar, about the difference between awareness and education. But to take care of that, we are already have a plan of revisiting the schools and also having, taking other assessments after that. Thank you so much.
Okay, sorry, before you go, I would give Dr. Adamu a privilege to ask the last question. Professor Olaside, I hope your question was addressed.
Thank you, everyone. I actually want to make a comment, but also give an advice to Dr. Chirobi. It's good that you want to expand this. My suggestion is this. Have you written your proposal for part 2? Or have you started it? Okay. If not, my suggestion would have been you turn this into a clinical trial. It's good. It's part of my observation during my PhD. Most of our studies are actually weak studies. But you can expand this, we can work on it to do a very good clinical trial on this education. And so once you are able to do that, you can register the clinical trial, have it published, work on the clinical trial, and at the end of the day, you have a very good evidence for your part 2. And I'm very sure you'll be the first person to have a clinical trial in his part 2 in oncology in Nigeria. And so if you've not done that, we can work on that. It's my area, community oncology and epidemiology. Thank you.
Thank you so much, sir.
Thank you. Thank you, everybody. We'll be taking the next presenter, Dr. Popola. You have 5 minutes. I've reduced it to 5 minutes. We need to wind up. Our time is fast spent.
Okay, thank you.
5 minutes, please.
Good afternoon, everybody. All protocol duly observed. My name is Popola from Massachusetts Cancer Center. This afternoon, I'll be presenting abstract on my institutional experience on cut-short technique in palliative radiotherapy treatment of head and neck malignancies. Globally and locally, we have discovered that there's an increase in the incidence of head and neck malignancies. But unfortunately, in terms of local record, we've discovered that our patients are presenting at advanced stages and with associated symptoms. However, we have different radiotherapy regimen that we use to manage these advanced cases, and some of them may, along the line, even worsen the symptoms of the patients. So we are trying to look at a more friendly radiotherapy dose that the patient will be compliant with, and the side effects will be minimal. So this led us to try to investigate surgical approfractionation radiotherapy technique, also known as cut-short technique, in the management of advanced head and neck cases. Actually, the cut-short is a periodical treatment, so that per cycle, when we want to treat the patient will undergo 4 different fractions, and that's why it is quad. And each fraction will be for 2 consecutive days with minimum of 6 hours apart. And the same treatment will be repeated over a specific period of time to a total of 3 cycles. So we're trying to highlight the benefits and in this technique so that it may be relevant in the management of our advanced head and neck cases, particularly in low to medium economic countries like us. So we track the patient with our electrical medical record for a period of 2 years, and we came up with eligible criteria. So any patient that is able to meet up with eligible criteria will be involved in the studies. So when we see an eligible patient, we get the clinical information and send the patient for appropriate radiological investigations. But while we are doing this with our patient, we have 3 things at the back of our mind. What is the significance or the impact of this technique in terms of pain, mucositis, and tumor response? So we appropriately assess pain and mucositis in these patients, and we also simulate the patient and delineate the GTV and give the appropriate margin for PTV. This is repeated every time the patient comes for the cycle. And each cycle is such that we give a 4 fraction per cycle, and over 2 consecutive days with 6 hours apart between each treatment. And every cycle involves 3.7 grain. So for every cycle, they get about 14 grain. So in total, after completing all the 3 cycles, they get an overall total dose of about 44 grain. And in between cycles, we monitor their response. And by the time they have completed the entire cycle, we monitor what is the eventual response. So we saw that between that period of doing the studies, we saw 72 patients at our center. And out of the 72 patients that presented with head and neck cases, only 7 of them presented with advanced cases. And 2 of these 7 consented to the study. One was an elderly woman, and the other is a young man. They are both presented with advanced cases. So what we discovered is that we compared their pain control between the time they started the treatment and when they finished the treatment. And we saw that both of them, though presented with pain, with severe pain, but by the end of the treatment, their pain score was actually mild. And also, their dependence on analgesic reduced. We also discovered that their mucositis actually reduced from grade 4 to grade 2. This helped with their feeding and they gained some weight as well. So, for every time they come for the treatment,
1 minute.
We compare the pre-GTV to the subsequent GTV, and we discover that there's a progressive decrease in their GTV. This is a patient we compare the initial and the dimension of the treatment with the dimension when she completed that treatment, and we saw good reduction. So we think that this technique is patient-friendly, compliance is good, minimal side effects, and we can see from our result that there's positive impact on pain, mucositis, and there is a positive tumor reduction. So we think that in our environment, this might be very helpful and may be worth giving some consideration. These are my references. Thank you.
Thank you very much, Dr. Popola. Thank you very much. Please could you have questions for Dr. Popola? Questions, please. Questions? Okay, Professor Lasinde, please. Another question? Okay, Dr. Okoro. Let's have one more question. Okay, please. So, please, Professor Lasinde, to get the mic. The mic.
Thank you, Dr. Popola. I hope I'm not having hypoglycemia already. Your first slide, I'm a bit confused. When you say head and neck cancer is 5 to 50%, how do you give such a wide range of representation of tumors you are seeing? 5 to 50%. And secondly, out of the 72 patients in this your study, only 7% with advanced stages of disease, head and neck in this country, you must be seeing special patients in your center. Because 7%.
Dr. Koro.
Thank you, Dr. Popola, for the presentation. I think this quad technique was, you actually presented it for management of palliative cases in head and neck cancer. So I'm a bit concerned if we're going to be giving such high doses and it's a palliative case, we expect that most of these patients, their ECOG status would be, mostly 2 and above. So if you compare the toxicity profile of these patients against the conventional doses of radiotherapy to head and neck, I wasn't able to see that you guys established that it is less toxic. So if you are asking that we should move from radiating patients the conventional way to doing it using the core technique, which actually means you're going to be doing hypofractionation, are we not worried about the toxicity profile? Then I think Prof has already asked the question. I noticed that this core technique was actually delivered to 2 patients out of the 70-something that were in this study. So would we consider that inadequate for us to make an assumption? So those are my questions. Thank you.
Okay, thank you very much, Prof and Dr. Koro. I'll start with Prof's question. One, if they represent that first slide, what happened in that first slide is that there's a study by Dr. Adeyemo and Co. and all over Nigeria. So I'm not saying that in particular, it depends on the geopolitical zones. So it varies from one geopolitical zone to another. But overall, that was what the study by Dr. Adeyemo or Professor Adeyemo and his colleagues came up with that locally. That's number one. Then number 2, our center, one of the things we ensure is that from the time the patient is coming in at all, we let them realize the goal of the treatment. What is palliative case is not cured. We tell them, ab initio, those who are okay for the treatment, they go ahead. Those who are not okay for the treatment, they back out. So if most of them, somebody is bringing a palliative case to us, and we have to relate the patient, we probably want to admit that patient, they will look at the cost. Or like if it's a public setting, when whatever it is, they can, say go ahead and they can afford all sort of things. If the fund is okay by them, that they can go ahead with treatment, we admit the patient and we go ahead. But if from the start they are not okay, that's the reason why in our case, in our center, we see more of stage 1 and stage 2 or probably stage 3. But advanced case, we may see it anyway. But if the caregiver are okay by the treatment we want to give, fine, we go ahead. But if they are not okay, we don't go. We don't start that treatment. That is why private hospital might, to an extent, be different from public setting. That's the number. Coming to Dr. Okoro, 1, the number of those who consented were 2. And this is like a case report. Not necessarily, after in particular, is to introduce that quad shot technique to us. Because it has, if you look at, please can you go back to that second slide, please? No, the next one. Historically, that thing actually started from the 1970s by MD Anderson Cancer Center, after which it was investigated further by radiation therapy and oncology group. And it gave positive and significant response in the patient they treated. In fact, they did not even use them for head and neck. They actually used them first in gynecological cases. And because of how wonderful this technique is, subsequently it was tried beyond gynecological cases. So what I'm just trying to say is that we are trying to introduce to us as part of our treatment options, not that we forget totally our conventional other management.
Thank you very much, Dr. Popola. Please, the other presenters should step forward. Please take note, you have just 5 minutes for your presentation and maximum 2 questions. 5 minutes for your presentation, 2 questions maximum.
Sorry, thank you very much. Thank you for this presentation. The idea of a palliative treatment, why is it high dose? Because you want to free the machine for the radical cases. Now, the understanding we have presently for palliative cases is that the highest is 30 in 10. And then you can even go to 20 in 5. Or a single 8 gray, thereabout. But if you look at your own system now, if you look at it, you have to deliver 4 fractions by 3. That's 12. It's even holding the machine down now than when it should be releasing it. I don't know whether you have a benefit from, is it that you don't have, you are not struggling with the machine space? Thank you.
Thank you very much. One, our machine is not too busy, or but relatively busy. Then number 2, from that cold shot technique, there is a period which is 3 to 4 weeks, depending on the clinician assessment of the patient. So it's not as if the patient will be on the treatment for 2 consecutive days and for the 4 fraction like that. No. After each shot or cycle, the patient can wait for the next 3 to 4 weeks before we administer the second cycle. Thank you, sir.
Thank you very much. Please, the other presenters should come forward. Dr. Adigbe-san, barriers of cancer patients towards utilization of palliative care services at University College Hospital Ibadan, Nigeria, a pilot study. Dr. I.B. Owadia, CING, the Nigeria Association of Medical Physicists, and commitment to safe and effective cancer treatment. Then Innocent Okpako Olowasion, anti-proliferative activity of euphorbia agents extract against prostate cancer. And Dao Arboa, complete remission of diffuse B non-Hodgkin lymphoma, the nasopharynx by adjuvant radiotherapy at MOC Massive Radiotherapy Center, Kinshasa. Please. Then Dr. Zubero, mental adjustment to cancer and hereditary quality of life in breast cancer patients in tertiary health facility in Kaduna State, Nigeria. Please, can they all step forward?
So while they are stepping forward, please, I have a special announcement, please. Sorry, we need to vote for one more person. And so we have sent the link to your email. Kindly vote now. Thank you. The previous voting has ended, but this one is for the one candidate that was omitted. So kindly check your email and vote. Thank you. Where are the presenters? Kindly come forward. Time is gone. The presenters should come forward. Thank you for coming. Where are the others? Do we have anyone online? Okay, we have just one person. Is it that we have just one person? Okay. His own presentation is what?
Dr. Zubero, so we have to take you first. So please just step up and take your presentation. 5 minutes. Questions, two questions per presenter. Thank you. Thank you. Please be reminded that you have to vote again. Please. Just check on your mails and go through the process all over again. Thank you. Okay, Dosberry, you have 5 minutes. 5 minutes.
Good afternoon, professors present, senior colleagues. It's my pleasure to stand here to present this abstract to you this afternoon. So I'll be presenting mental adjustment to cancer and health-related quality of life in breast cancer patients in a tertiary health facility in Kaduna State, Nigeria. Okay, so only recently has real attention been paid to the psychosocial aspects of cancer care in Nigeria, and mental adjustment to cancer is one of those aspects in psychological care of cancer patients that needs to be really explored. Mental adjustment to cancer is a concept that has been in existence for more than 3 decades. Following the research by Watson and Greer, they were able to identify about 5 different adjustment styles to cancer. The adjustment to cancer simply implies the cognitive and behavioral responses that the patient has to undergo following a diagnosis of cancer. So throughout the process of diagnosis, through treatment, management, and survivorship, the adjustment to cancer in this patient is critical. So this study focuses on the mental adjustment to cancer in breast cancer patients, as well as the health-related quality of life. So we sought to define the pattern of mental adjustment to cancer in these patients, and to also describe their health-related quality of life, and to determine whether there is an association between the mental adjustment to cancer and health-related quality of life in these patients. So a convenient sampling technique was used to recruit about 220 female breast cancer patients from the outpatient clinics of Ahmadu Bello University Teaching Hospital, the radio therapy and oncology departments, as well as the surgical outpatient department, and their wards. A structured questionnaire was designed by the researchers to collect the socio-demographic information of these patients, as well as their clinical characteristics. We used the mini mental adjustment cancer scale to assess the mental adjustment in these patients, and we used the FACT-B scale to assess their health-related quality of life. Descriptive statistics, Pearson's correlation were used to analyze the data we collected. So the results, the majority of patients were young, 55% of them, married, educated, and presented with clinical stage 2 breast cancer. That was about 33% of them. 59% of them received chemotherapy, 90% experienced treatment side effects, and 55% had comorbidities. So this table shows the specifics of these demographic characteristics that I have presented. So we can see that the mean age of presentation in this group of patients was about 44 years, with a standard deviation of about 12.4 years. So we found that the maladaptive mental adjustment styles, this means that the adjustment styles that are not desirable were more predominantly used in this group of patients. We identified anxious preoccupation, helpless hopelessness as the most adopted mental adjustment style, while cognitive avoidance, fatalism were least used. So this graph shows the distribution of the pattern of the different mental adjustment styles. The health-related quality of life was average, with a FACT-B total score of 91.03 of a total possible score of 148. And there were significant positive correlations between mental adjustment styles and health-related quality of life, and these were statistically significant at a p-value of less than 0.05. While the maladaptive mental adjustment styles were significantly and negatively correlated with health-related quality of life. So this table shows the various components of the FACT-B questionnaire that we used to assess the health quality of life, and there are about 5 different domains, including the physical well-being, functional well-being, social well-being, emotional well-being, and breast cancer-specific symptoms. These table shows the correlation between the different domains of the health-related quality of life versus the mental adjustment to cancer styles. So to the right of the screen, you would see the full meanings of the acronyms that I have used in the table. So in conclusion, maladaptive mental adjustment styles are more frequently used in the female breast cancer patients that were studied. There were significant positive correlations between adaptive mental adjustment styles, fighting spirit and cognitive avoidance, and health-related quality of life, whilst there were significant negative correlations between maladaptive mental adjustment styles, that's helpless hopelessness, anxious preoccupation, and fatalism, and health-related quality of life. We therefore recommend that the mental adjustment should be assessed in all breast cancer patients presenting to this facility, and that they undergo psychological interventions that can assist them to employ more adaptive mental adjustment styles as opposed to maladaptive mental adjustment styles. Thank you.
Thank you very much, Dr. Zubero. So, do we have questions? I have one question. So, any other question? We are taking just two. Okay. Dr. Zubero, my question. Yeah, we're looking at the mental adjustments related to quality of life. You mentioned the surgeons, the radiation oncologists. Did you also as well engage in your study? Stay up. Dr. Zubero, you can stay up. The clinical psychologists, the psychiatrists, were they part of your study?
Okay, no, we did not include the psychologists in this study because we already had the instruments. The instruments are available online. I mean, the mental adjustment cancer scale and the functional assessment of chronic cancer therapy, the breast version.
But what about the mental health? People are not involved as well.
Yeah, well, we plan to do a further study on this when we intend to deploy psychological interventions to the patients who present to our facility. So in designing the intervention studies, definitely we would have to include the psychologists and the psychiatrists to help us define appropriate psychological interventions for these patients.
Because the reason I'm asking is because a patient could have breast cancer and still have a background mental issue.
Absolutely.
And if that's the case, it's going to actually probably give you more mental problems that can manifest with the treatment. The treatment journey can be so traumatic for them. So if you have a background psychiatric evaluation on this patient, you know their mental state before starting your treatment. So you're able to differentiate, maybe is this from the treatment I'm giving, the disease, or the background ailment. So having a background check by a psychiatrist in this case will greatly help you to determine what's causing this mental issue to the patient.
Actually, for this study, part of our exclusion criteria were any patients who have a history of mental illness. So they were excluded from the study because that could be a confounder for the results that we get from the study.
Thank you very much.
Thank you.
All right, okay.
Yeah, another round of applause for you. Can, thank you. We have come to the end of this session. The others are not available. And so we thank you all for participating in this session. Thank you.
Sir, before you go, sir, all the abstract presenters that are around,
please come around for picture.
For the group picture. Don't go. Thank you very much. Oh, yeah. Well, oncology, will come to you later. No, later. There's one more person. She will be. Dr. Shiwobi, where are you? Maybe she has gone to prepare for dinner, for our dinner. You know, she's the secretary of the LOC. Let's take this picture. Yes, please.
Okay, so right away we'll be going to the seed grant review. Please, if you have not voted, please kindly vote now. Go to your emails and vote now. This next session is sponsored by Janssen. So we'll be calling them up now. Dr. Oyeshegun will anchor this session, please. Okay, sir. You have it.
Good afternoon, ladies and gentlemen. We are now in the seed grant session. So I'll be calling up two people who have assessed these articles. That's Professor Wang, please. And Professor Ugumba. Please come up. So there are 5 presenters, 5 residents who have submitted articles and have been reviewed. They are not in any particular order: Dr. Ojo, Dr. Bashira, Dr. Shibo, Dr. Nato Ayuba, and Dr. Dalushuku Obi. So 2 of them will be presenting online, 3 are physical. They're here now. So I don't know whether we should start with the Okay, can we start? Let's start with those that are in person. Dr. Bashira first. Dr. Bashira, are you ready? And those online, they should be getting ready. You can inform them, media. Those who are online, they should be getting ready, not when we get to their turn, they will start preparing. Please, you have 5 minutes only. 5 minutes only, please.
Good afternoon, professors, consultants, residents here present, and distinguished members of the audience, and of course, the very distinguished members of the panel. My name is Dr. Bashir Miriam. I'm a senior registrar at the Lagos University Teaching Hospital, situated in the NSIA Youth Cancer Center. I'll be making a presentation on the clinical pathological determinants of PSA changes and quality of life in patients who have had 3D external beam radiotherapy, which is curative for prostate cancer. So this will be my outline. So cancer has been established as a major cause of morbidity and mortality worldwide. And according to recent data, prostate cancer is the commonest cancer in men in Nigeria. Looking at the pie charts to your right, this is data gotten from our research unit at NLCC, where you can see about 80% of our patients present at stages 3 and 4 of the disease. Now, in the management of these patients, PSA utilization has been emphasized as very important for monitoring and predicting response of treatments for these patients. So this study hopes to look at the clinical pathological features such as the T staging, the lymph node involvement, comorbidities of this patient, and how they influence the PSA trend and the testosterone levels of this patient post-EBRT treatment. We also hope to utilize these features in seeing if they impact the quality of life of this patient. Now, for the methodology, it will be a prospective study, cross-sectional also, utilizing about 45 patients from the earlier figures of 15 patients, newly diagnosed patients per month at the NLCC. The PSA testosterone levels will be done before 6 weeks and 3 months post-EBRT to assess the trend of the PSA. Now, this will be the inclusion-exclusion criteria. We are targeting majorly localized and locally advanced disease. Patients with poor performance status and metastatic disease will be excluded from the study. The period of the study will be about 10 months, including the period of writing the proposal, the full proposal for submission to the ethical committee, for which ethical approval will be gotten at the ethics committee in Louth. Now, for the quality of life assessment, I chose to use the FACT-P questionnaire, which is a functional assessment of cancer therapy specific for prostate cancer, because of the later part of the questionnaire emphasizes symptoms which prostate cancer patients may complain of. There will be a multivariate analysis to reflect further and see whether there's an association between these clinical pathological features and the quality of life and the PSA trend. So this just tells us about the multivariate analysis further. Now, apart from aiming to see if there's an association between the clinical pathologic features and the quality of life, we want to see if we can create a database for Nigerian patients whereby we can utilize these features, put them in, I'll still get to the slide on innovation, and possibly predict how patients would be, how they prognosticate patients after, before they start therapy, and also develop an institutional protocol on management of prostate cancer. Now, the innovation, to emphasize further, these features, the clinical pathological features, and relating them to the PSA trend and quality of life will be vital in influencing modalities of treatment of patients. And also, there's a possibility of, if the study is expanded further, getting a predictive model that can be utilized in prognosticating prostate cancer patients just from the first or initial visit of these patients. Now, this is just a picture showing what the predictive model is, just a general schema, but not particularly specific for this one, but just a general schema, really. As regards utilization of funds, one challenge, really, we really appreciate Janssen for coming up with this concept, but most of our patients, the price of doing a PSA at our center ranges between about 10,000 naira to about 15,000 naira. So putting that cost on the list will have taken up all the funds. So I did the research personnel, taking up about 50%, where blood samples will be taken, stationary, which is majorly the questionnaires, data analysis, publication field, and of course, ethical approval. So this just explains further how I'm going to utilize the funds if awarded the grant. So it's Prostate Cancer Awareness Month, really, and I think basically for every one of us here, the message is to tell a man, to tell another man, to tell another man about running a PSA test, especially because of the fact that in African men with prostate cancer, this disease has been proven to be very aggressive in these patients. These are my references. And I say thank you very much to my consultant. I have to acknowledge her, Dr. Alabi. She's here. She's gone through this slide severally for me. She's done a fantastic job. All my other consultants, the residents, Ibeleme, Isibo, thank you so much for going through the slides for me. Thank you very much to the reviewers.
Thank you very much for the presentation. Can Dr. Shigbo come up now? Dr. Shigbo.
Okay, hello. My slides. Okay, good afternoon, distinguished ladies and gentlemen. I will be standing on existing protocol. I'm Dr. Chinelo Chibo. I'm a junior resident in the Department of Radiation and Clinical Oncology at the University of Nigeria Teaching Hospital. So today, I will be talking about my study, which will be looking at determining the barriers and facilitators of access to care and the treatment outcomes of prostate cancer patients in Nigeria. Okay, so I'll be discussing these based on these outlines. So generally, as a background, prostate cancer has remained a major cancer burden, especially in developing countries. And we see about 1 in 8 men who are diagnosed with prostate cancer within their lifetime. So according to this data on Globacom 2020, looking at the cancer burden among Nigerian men, it shows that prostate cancer ranks the highest and has also has the highest rate of cancer-related mortality in Nigeria. And despite increasing awareness and screening programs that has been geared towards promoting early diagnosis and treatment, most of our patients still present at advanced stages of their disease, as depicted by this study carried out by Ofoha et al., where we see just about 19% of the patients presenting with localized disease. Then this study, referencing this study that was done by Ugumba et al., where he looked at the indices at presentation to a third referral hospital in the southeastern part of Nigeria, where he highlighted various durations of delay in seeking care in men experiencing symptoms that were suggestive of prostate cancer. This study showed that about 28% of men presented within 3 months of their symptoms, and more than 25% presented way above 12 months of symptom onset. So this, shows us that we have a lot of delay from, the point of symptom, the point of onset of symptoms to diagnosis, and that's why if we try to understand the drivers of delay from this point of onset of symptoms to diagnosis, and from diagnosis to onset of treatment, it will help us to develop strategies that will minimize the time to treatment in patients that have prostate cancer. It will also provide a focus for targeted interventions at both the individual, community, and healthcare levels, and ultimately it will aid to optimize care and improve our treatment outcomes. So the aims and objectives of this study is basically, 1, to look at the trends of prostate cancer in 2 selected population-based cancer registries, and we'll be looking at it over a 5-year period, 2018 to 2020, and we would want to also investigate the type of treatments and care that these patients were offered and what they eventually received. We also want to determine the barriers and facilitators to uptake of care and treatment by these patients, and to follow up these prostate cancer cases and estimate their overall survival using the cancer registry data from the 2 selected cancer registries that we'll be using. So this is going to be a longitudinal population-based observational study, which will be carried out between October of 2023 to September of 2024. And the 2 cancer registries we'll be using are the Enugu and the Ekiti State cancer registries. So it will be a simple random sampling of 60 patients with prostate cancer from both cancer registries. So we're going to get 30 from each of the cancer registries. And we'll get ethical clearance from the ethics committee of both institutions. So the pre-tested structured questionnaires will be administered to these randomly selected samples. And in situations where they have missing data, we'll be going to their case notes and conduct some telephone interviews. The data will be analyzed using the latest SPSS version 23. And the trends of survival will be analyzed using the CANREG 5 statistical software. We'll be including all histologically confirmed prostate cancer patients and patients that have their cancer diagnosis between 2018 and 2022. And we'll be excluding cases that were duplicated or wrongly registered as prostate cancers, or patients that had relapse within
with their date of incidence prior to 2018. We expect to see factors and barriers to these prostate cancer patients assessing care and treatment. We also expect to see factors that are associated with advanced cases of disease, advanced stages of disease, even though some of these patients would have had an earlier diagnosis. We also we expect to see more common treatment options that these patients opt for, and what factors contributed to, their choice of the treatment options, and to overall estimate the prostate cancer survival in the study setting. The innovation of this research is that we'll be able to analyze the reasons to a limitation in the access to care and treatment, and we'll follow this up with suggestions on how to improve, this by reducing the barriers and strengthening the facilitators. And we have paucity of cancer survival data in Nigeria, so this would really be one of the first population registry-centered prostate cancer survival data. And from this research, we'll be able to improve our cancer registry data collection model where we notice any gaps. For the fund utilization, the research personnel will be accounting for 28.9% of the total funds, while utilities, data analysis, ethical approval, and the hope is that at the end of this, we'll be able to publish our work in at least 2 impact journals. That's the hope. So, that will take about 25.1% of the total funds. So I want to acknowledge my supervisor, my mentor, and the rest of my research team, and Arcon and Jansen for this great opportunity. We're very grateful, and it's really been a process. Thank you so much. Thank you.
Thank you very much, Dr. Shubu. So can we have Dr. Dalushuku Obi? Then the online people should be getting ready. Media.
Distinguished ladies and gentlemen, senior colleagues, and my reviewers, good afternoon. My name is Daluchukwu Obi from Radiation Oncology Department, University College Hospital, Ibadan. In the next few minutes, I will be discussing the proposed study on effects of androgen deprivation therapy, otherwise called ADT, on fasting blood glucose among Nigerian men with prostate cancer in UCH, Ibadan. Please, next slide. Prostate cancer, as we know, is the leading cause of cancer death among Nigerian men. And hormonal treatment with the use of ADT is among the common modalities in treatment of early and metastatic prostate cancer. It has also improved survival in men with prostate cancer. However, it can result in severe metabolic disorders like myocardial infarction, coronary heart disease, and hyperglycemia. Many studies have been done on this among the Caucasians, and they've reported a 7 to 44% increased risk of diabetes after ADT use for local or advanced prostate cancer compared to those not treated with ADT. A study, this graph shows results on different studies among Caucasians that shows a higher increase among men, a higher increase of hyperglycemia among men on ADT compared to those not treated with ADT. The only reports among indigenous blacks was that of Bassi et al., done 5 years ago in Calabar. This study showed no effects on fasting blood sugar on ADT, that ADT has no effects on fasting blood sugar in black men. However, it was a cross-sectional study, so it was a one-off test that they did with on the men recruited for that study. With this proposed study, the methods will be the one done among the Caucasians. This requires further validation as relationship between ADC use among black men. So the proposed study will be, the fasting blood sugar will be taken at baseline at 3 months, 6 months, 9 months, and 12 months. The research question remains, does ADT use among black men cause hyperglycemia? Does it cause hyperglycemia, whether it's gonadotropin-releasing hormone, orchidectomy, or oral anti-androgens? The aims of this study is to determine whether fasting blood glucose levels of prostate cancer patients treated with ADT causes hyperglycemia compared to non-ADT group, then to determine the relationship between ADT use and hyperglycemia among Nigerian men. So the methodology is going to be a one-year prospective study done in UCH Ibadan. The study population will be histologically diagnosed prostate cancer men attending both the urology clinic and radiation oncology clinic. The inclusion criteria and exclusion criteria among the cases, in the cases and control will be noted and taken. This is next slide. Then since it's a pilot study, an estimated sample size of 60 was chosen, 30 for the cases, then 30 for control. The data collection procedure will be, the glycated hemoglobin will be taken at baseline and at the end of the study. Then the fasting blood sugar will be taken at baseline, then 3 monthly for 12 months. The data will be analyzed using SPSS. The t-test and logistic regression will be used to determine relationships. Then, before the commencement of this study, ethical approval will be taken and informed consent will be also obtained from the patients recruited. Expected outcome from this study, being a proposed pilot study, is going to provide data describing the role ADT has in development of hyperglycemia among black men with prostate cancer. It's also going to provide further data to design a more comprehensive prospective study with adequate sample size. So this will provide strong evidence on the association between ADT use and hyperglycemia. Contributing to science, the results from this research will provide evidence for further recommendations for effective management of prostate cancer patients on ADT. Innovation of research, it will help to measure glycated hemoglobin before commencement of ADT. So the patients to be placed on ADT should have their fasting blood sugar taken and glycated hemoglobin. It's also going to be a rapid point of care with the strips and glucometer we have, and this will be accessible to the patients even at home so they can check this test. If awarded this grant, this will be the breakdown of the budget for this proposed study. In conclusion, hyperglycemia in patients on ADT can lead to poor outcome, and studies among indigenous blacks are scarce. This proposed study will provide data that will be used for optimal management of these patients. I would like to thank Arcon and Johnson for this opportunity, my mentors and trainers, Professor Adeni Beku, Dr. Abdusalam, Dr. Ntekim, Dr. Flashire, Dr. Ladeji, Dr. Jimo, Dr. Sarmi, and Dr. Molala Salako, the Arcon mentor for this. Thank you.
Thank you very much. Thank you very much. Thank you. I don't know which of the online people is ready. Anyone that is ready can go ahead. Go ahead. There are 2 more. Oh, 1 more.
She's here physically.
Dr. Ojo. Oh, please come on. I thought you were online. Sorry, I thought you were online. So it's only 1 person that is online.
Hello, Dr. Ayuba is ready now.
Good day, participants, esteemed members of Arcon, my senior colleagues. My name is Ojo Olabisi, a senior registrar from University College Hospital, Ibadan. My topic today is the effect of drug therapy boost on prostate cancer patients treated with intensity modulated radiotherapy. It's a pilot study. Prostate cancer accounts for 14.5% cancer incidence and 6.8 cancer-related deaths, a statistic from Globocom 2020 worldwide. In Nigeria, it's the most common cause of cancer amongst men, and it's about 15,306 new cases in 2020. It is important for us to know that in the management of prostate cancer, risk stratification is paramount, and 3 parameters are used: the Gleason score, the PSA, and the tumor staging. And this risk has been closely linked with cancer-related mortality among prostate cancer. As a study done by Michael et al. In 2018 showed that 66.2% patients with high risk have a higher risk of having cancer-related deaths, compared to 6.5% in the low-risk group. NCCN guideline says that external beam radiotherapy alone or external beam radiotherapy alongside with brachytherapy is effective in the treatment of unfavorable intermediate and high-risk localized prostate cancer. However, there are side effects that have been seen among these 2 treatment modalities, which is commonly in the gastrointestinal and genitourinary toxicity, which is seen in both treatment modalities. Some studies said that using high-dose rate brachytherapy as a boost alongside with external beam radiotherapy has improved survival and acceptable toxicity profile, while other studies say otherwise. This procedure, prostate brachytherapy, is very new in the country, as at the moment it's only University College Hospital, Ibadan, that does prostate brachytherapy. So there are no datas. And also, external beam radiotherapy, specifically IMRT, intensity modulated radiotherapy, that is done in LUTS, that's Lagos State Teaching Hospital. It's also a recent technique in the country. There are no datas that compares this treatment outcome between these 2 treatment modalities. So there's a bridge in the knowledge gap. So the aim of my study is to compare the treatment outcome for localized prostate cancer patients that had intensity modulated radiotherapy alone, and those ones that had intensity modulated radiotherapy alongside the high-dose rate brachytherapy as a boost. The specific objectives are to compare their side effects at 1 year post-treatment, to compare the quality of life, and also to compare the biochemical control at 3 months, 6 months, and 1 year post-treatment. My methodology is it's going to be a prospective study, and the population will be localized disease prostate cancer patients. The study location will be in University College Hospital alongside with NSIA LUTS. My sample size is going to be 40 patients will be recruited, 20 patients in each arm of treatment. Ethical approval will be gotten from both University College Hospital and Lagos State Teaching Hospital, Idiaraba. The inclusion criteria are patients that have been stratified into intermediate risk and the ones that have high-risk prostate cancer. And those patients would have had both high-dose rate brachytherapy alongside with IMRT, or would have only IMRT alone. Exclusion criteria is metastatic disease. The data would be kept in the confidential, and the proforma would be using 2 validated questionnaires. The European Organization of Research in Treatment for Cancer questionnaire will be used to assess for the quality of life, while Radiation Treatment Organization will be used for questionnaire will be used for late side effects. PSA will be done, we checked post-treatment, and then 1 year post-treatment, 1 year, 3 months, and 6 months post-treatment. Data analysis will be entered into SPSS, variant analysis will be done, and also log rank tests would also be done. The expected outcome will be to compare the side effects of both treatment arms, to compare the quality of life, and to also compare their biochemical control. And this expected outcome is also noted to know that we hope to use the outcome to guide in the choice of treatment, as we know that the cost of IMRT and high-dose braid drug therapy is significant. So we want to know which of this treatment outcome is good, and why not guide the patient appropriately in having an informed consent to know which of those treatment modalities they would benefit from. Innovation is important for us to know that it's going to be a pioneer study, because this study has not been done at the moment in the country. And then most of the studies that have been done didn't assess the quality of life, but this study is going to assess the quality of life of both treatment arms, and then validated questionnaires would also be used to collect the data. If this grant is given, I hope to use the fund appropriately, in the sense that we're going to do a PSA testing, because these patients would be on follow-up, will be gotten, and then ethical approval will be done. These are my research team. My name is Ojola. These are my research teams: Dr. Abdulsalam, Dr. Jimo, Dr. Arimiye, and also Dr. Adeomi Alabi, because this is going to be a multi-center study. Thank you very much for listening.
Thank you very much. Thank you very much. Thank you very much. So the last but not least speaker will be online. Is it ready? Can you put her on? Dr. Anatu Ayuba. You said? Okay, can you please unmute yourself and start right away, Dr. Ayuba? Dr. Ayuba, are you there? Can you hear me, Dr. Ayuba? Can you unmute yourself and start? We have 5 minutes only. Is she online actually? Yes. Can you unmute yourself and start? But the slides are not on either.
Yeah, speak out now, Doctor.
Hello?
Hello, yes, we can hear you. Please go ahead. Yes.
Hello, can I start?
Go on, I can hear you. Go on.
Go ahead. Start.
All right, thank you, sir.
You have 5 minutes.
Good morning, esteemed Arcon members. Good afternoon, esteemed Arcon members, distinguished panel of reviewers, and distinguished co-participants. I'm Dr. Ayuba Hannatu Usman, Senior Resident in the Department of Radiotherapy and Oncology, National Hospital, Abuja. The proposed study is risk factors for urosepsis in prostate cancer patients undergoing care at the National Hospital, Abuja.
Please go to slideshow. Go to slideshow so I can be bolder.
Urosepsis is a big problem in the low middle income countries and a big problem in the high income countries.
Dr. Ayuba, please go to slideshow. It's a big challenge faced by our patients. Go to slideshow. Click slideshow so that you can see better.
Mobility and mortality.
Can you please go to slideshow so that the slides can be bolder? Slideshow, please. Can you hear me? Slideshow, unmute yourself and continue. Put it in slideshow mode. Please put it in slideshow. Put your presentation in slideshow mode so that you can see it better than now. Can you hear me? Okay, she's doing it already. Put it in slideshow.
Dr. Iba has gone offline.
Time is going. We don't. Hello? Are you still on? Are you still with us?
Sir, maybe while they're still sorting out the technical glitch, I noticed that the chairman of the Board of Trustees is online. Maybe we want to say a word. So we use that period to, if they can unmute Professor Drew Simieti. Professor Drew Simieti is online. Just unmute him. I'm sure he would like to, while we are resolving the technical.
Okay, that's all right. Any of the two that is ready, please. So as to maximize time.
Prof, please, you can go ahead, sir. Prof, sir, you can go ahead, sir. You can unmute yourself and speak, Prof.
Pardon, I didn't follow you. What do you want me to say? I didn't get your conversation earlier. I just saw I should unmute.
Yes,
Can
sir.
I just hear what you want me to say?
Yes, sir.
I hope you are referring to my own prof.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
So what do you expect from me? What do you want me to say, please? I didn't get the conversation before then.
Yes, we would like you to just give a greeting to the annual general meeting. We have not been privileged to hear from you, sir.
Is in Enugu.
Hello, please
I
go
hope
ahead.
you can hear me.
Yes.
I hope you can hear me.
Yes, we can hear you clearly. Please go ahead, sir.
Oh dear. I know that Sheikh is trying to say something, but I can't hear you.
Yes, we
But
can
can
hear
you hear
you.
me?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Oh, okay, thank God for that. Okay. So it's been a very interesting meeting, and I'm so proud of all of you, particularly Arcon and the chairman and members of the local organizing committee. What you've seen in Enugu now, believe me, is fantastic. We saw something in Abuja last year. We saw in Lagos the year before. We've seen something wonderful now in Enugu. I just hope wherever we are going to next, we're going to see something more wonderful. I want to thank all of you for your commitment. I want to thank you for the high standard that is being followed here. I want to thank the external faculty that have flown all the way from abroad to come in here. I want to thank all those who have been online as well. And in general, we've had a wonderful meeting. And I'm very, very proud to belong to Arcon. And I wish Arcon complete success in the years ahead. Thank you, and continue to enjoy your meeting. And after that, maybe, I don't know, please go and see the beautiful sites prepare for you in Enugu. God bless you all. Thank you, and bye.
Thank you very much, sir. We appreciate
Over to you.
Thank you very much. Can we have Dr. Ayuba straight away? One more. Media, can we have Dr. Ayuba again? Yes, they are going to bring up the slides. If any member of our team that can stand in for her, we'll be very glad. Yes, I think it's a network issue. Dr. Basira Lawa, she's left. Where is she? Come and step in for her. If I'm sure you are. You are aware of the work and all that. As much as you can, we will understand. She's back now. Can you put it on slideshow, Dr. Ayuba? Put it on slideshow. I'm sure you know how to put it on slideshow. Slideshow, please. Aha, you are correct now. Please go ahead. You have 5 minutes. Please go ahead. Unmute yourself and start.
I've unmuted from here. Good afternoon, esteemed Arcon members. Can you hear me, ma'am?
Yes, clearly. Go ahead.
Hello, good afternoon, esteemed Arcon members, distinguished panel of reviewers, and distinguished co-participants. Dr. Ayuba Hannatu Usman. Hello, ma'am.
Go ahead, please.
Hello. Hello.
I can hear you. Please go ahead. Do your presentation.
We can hear you. Go on, please.
Good afternoon, esteemed Arcon members, distinguished panel of reviewers, distinguished co-participants, and Dr. Ayuba Hannatu Usman, senior resident at the Department of Radiotherapy and Oncology, National Hospital. The proposed study is the risk factors for urosepsis in prostate cancer patients undergoing care. Urosepsis is a big challenge in the low.
She's off. Because of network problem. Our network.
Hello. Good afternoon, everyone. I'm Dr. Lawal Basira Hanafi. I don't know if you can hear me. Okay, I'm a consultant clinical and radiation oncologist, and I will be taking this presentation on behalf of Dr. Ayuba. So this abstract is risk factors for urosepsis in prostate cancer patients undergoing care at National Hospital. So what we want to do is to do an initial pilot study before we carry out the study. Next slide, please. As a form of introduction, urosepsis is sepsis resulting from an infection of the urogenital tract or male genital organs, in this case the prostate. Studies have shown that about 25 to 30% of sepsis is as a result of urosepsis. There's quite a dearth of data on the prevalence, risk factors, and causative microorganisms that are responsible for urosepsis in prostate cancer, and this is particularly deficit in Nigeria. Next slide, please. So what are the objectives? We want to identify all the cases of urosepsis in prostate cancer patients that are undergoing care in National Hospital within our study period. We want to be able to identify and characterize the organisms that are responsible in prostate cancer patients, as well as look for the possible risk factors in these selected patients. Next slide, please. Okay. So what are we trying to do in this instance? So we want to conduct a pilot prospective cross-sectional study in our National Hospital in the chemotherapy suites, radiotherapy, urology clinic, and the whole inpatient wards within the hospital. Our study population is basically all the prostate cancer patients that are undergoing care. Our method of sampling is convenience sampling, and all the participants within this study periods will be included in this study. And we'll be able to get ethical approval from our ethical approval board in the hospital. And the information that we want to get, we want to use a consent form which we have designed, a questionnaire, and also examine these patients physically. We also want to collect some samples, and this includes a full blood count and differential, blood culture. We also want to do a urine MCS as well as serum procalcitonin. If you had looked at the first initial slide where all our names were, we are doing this study together with the microbiology department, and that's why we'll be able to collect these samples. What do we expect when we're doing this study? So initially, in the first instance, we want to assess the prevalence of urosepsis in prostate cancer patients that are undergoing care, whether chemotherapy, radiotherapy, or post-surgery. We want to assess the bacteriological antibiotic sensitivity and the resistant pattern as well. We want to do a T distribution quick sequential organ failure assessment, QSO-SOFA score points. And we also want to do an association of those patients that are developing urosepsis. We want to assess their general status, the comorbidities that they present with, the stage they present, the chemotherapy administered, as well as the radiotherapy administered. And we want to do a multivariable logistic regression analysis of urosepsis in addition to corticosteroid use as well as the use of ADT. So for the innovation of research, we want to do the QSOFA score sepsis screening tool, database from this pilot study, because like I said, we're going to do an initial pilot study, and we want to use this pilot study to develop screening algorithms with AI for all the risk factors for urosepsis, which will guide prevention. We want to provide information on the bacteria that has been involved, the antibiotic sensitivity, and the resistant patterns as well, and possibly NGS as well as other molecular studies if possible. So when we requested for this grant, we we made an analysis. To process the sample, we need at least 690,000, and this accounts for about 83% of the total fund. For the research personnel, obviously we need to get some other people to help us collect some of the data. We need 60,000, and then consumables to carry out these tests. We also need to pay for ethical approval in the hospital, and this will cost 20,000. So in total, I think it came out down to about 800,000 in total. Thank you very much. These are our references.
So, thank you very much. You have comments? Please, go ahead.
I want to congratulate all of our presenters for doing a fantastic job. I really enjoy reading your proposals, the fact that you highlighted your aim, your objective, clearly tying it to the methods. That's really invaluable and a very important starting point in thinking about a research project. With every research project, there are sometimes, no project is perfect. There's always, since we're studying human beings, there are always confounders to think about, but this is a fantastic start, and best wishes to your projects going forward.
May I just ask our audience to please give these 5 ladies a resounding round of applause. I ask that we do that because, first of all, it takes courage to put in for these seed grants, and so that should be commended. It was a privilege to review your submissions, and like Professor Wong has said, you don't find out the problems on a journey until you first set out on the journey. So what struck me was that each of you was trying to address germane issues regarding prostate cancer within our environment. And these are things that we encounter every day. It's much to the point that it's now looking like very normal. You're bringing new issues to it. Some may say that these issues have been addressed, but they need to be addressed within our setting. So on that note, I congratulate you. When we're having technical issues, we took the opportunity to put heads together, and I was pleased to see that we had a lot of agreement in our thoughts. So I'll now yield the floor to Professor Wong to announce what those our thoughts are.
We thought, since the scores are really very close, we thought we will announce the top 2 scores. Is that what you like us to do? Yeah, okay. So the runner-up is Dr. Chigbo on her project Determining Barriers, Facilitators of Access to Care. And the top score project is Dr. Obi on her work on effects of androgen deprivation therapy on fasting bloods. Yeah.
Thank you very much. I think with this we have come to the end of this session. Are there questions? You want to say something? Please come forward. Come forward.
Thank you so much to our reviewers for all the hard work you did in reviewing all the grants. And as a matter of fact, there were 4 reviewers for this category: Professor Wong, Professor Ugumba, Dr. Hannah Ayeti, and Professor Olarotimi. So they reviewed the grants, and first of all, congratulations to the top 2 scorers. And but just to mention that initially we had planned to give out 3 awards, and fortunately we got another mentor who has agreed to support the other 2 grants. So everybody is a winner. So I think, just to borrow a leaf from what was said on the panel, it takes the courage to do so. And for everybody here, for the avoidance of doubt, In the residence category for prostate cancer, we had only 5 applications. So these are the 5, and they are all winners. So congratulations. I would like to invite the 5 Janssen representative who were the ones who initially put down some seed funding to be able to support the initial 3. And our sponsor for the other 2 is actually one of the reviewers himself, which is Professor Rotimi. And he has actually identified 2 grants that he'd like to, I'm looking for the right word he used now, he'd like to adopt. And so after this 1-year project is over, he intends to continue working with you because it aligns with his own research interests and his own grants. So first of all, let me just announce the 2 that Professor Rotimi is interested in. It is Dr. Basira's grant and also Dr. Chibo's grant. So I think at this point, I'd like to invite all our winners to take a picture with our reviewers and, of course, see, I think he will. Sorry, before I actually leave the stage, I'd like to thank all the supervisors who worked with them, but especially I'd like to thank Dr. Salako, who was called up at the last minute to tutor these young residents on how to successfully put a pitch together and deliver it effectively. So just to say, acknowledge Dr. Salako's input in all of this. Thank you.
Thank you very much for waiting this for. We have this session, then we also have lunch. So I was asked to request, should we take this session or should we take lunch and come back? Thank you. So let's take this session, then we'll go for lunch, and from lunch, those that want for the AGM concerned will come back for AGM. Those that are not AGM concerned will go and prepare for dinner. I mean, the dinner is going to be a very wonderful event. The time for the dinner we planned for 6 p.m. However, 7, okay, I've been 7 p.m. The venue for the dinner will be announced shortly. You know, we're keeping a close lip on the venue because we want it to be a wow. Are you set, sir? Thank you very much.
All right. Good evening or good afternoon, everyone. I'd like to specially recognize the local organizing committee of Arcon 2023 here in Enugu for the wonderful work they've done so far. It's been 3 years, or 3 days rather, spent here in what I consider my hometown, actually, because I studied here. I'm a product of the University of Nigeria. So it's really a thing of pride for me to stand here before you, my teachers, to talk about prostate cancer. Now, I realize that at least for the past hour and a half or so, everybody's ears has been replete with information that maybe they didn't ask for on prostate cancer, but trust me, I'll try to be straight to the point because I understand that I am keeping you from having lunch. So today, we'll be talking about an optimal management. Well, I'll start by introducing myself at least. So my name is Chibike Uzo, the Medical Science Liaison for Janssen Pharmaceuticals. And today we'll be talking about the optimal management of metastatic prostate cancer, the end-to-end or an end-to-end approach. So that's my outline. We'll go from the introduction to different stages of prostate cancer to managing metastatic hormone-sensitive prostate cancer and finally metastatic castrate-resistant prostate cancer. Now, if I actually stood here and defined prostate cancer one more time, I'm under the impression that I'll get shot, all right? Because they must have heard it one too many times today. But again, just a few quick facts. Prostate cancer, malignant tumor of the prostate, very, very common in men of African descent who are above the ages of 65, and certainly is an indolent disease with very few symptoms until it gets noticed or until it proceeds to an advanced stage. Now, once the cancer is out of the prostate, usually it's referred to at that point as metastatic prostate cancer. So here is some sort of a chart that describes the progression from local disease down to metastatic disease. And you would find that to the left of your screen, at least to the left of my own screen, I assume that's the case for you, you find LPC, which basically means localized prostate cancer, LAPC, locally advanced prostate cancer. And because this is a disease that progresses over time, and by progression I mean worsens in presentation and symptom, and even when you look at the biochemical markers, you progress from that localized stage of the disease to a spread or a multi-organ stage of the disease referred to as metastatic prostate cancer. Now, one thing I forgot to mention is that it's hormone-driven, and that kind of informs a lot of the nomenclature in prostate cancer. So we have castrate-sensitive prostate cancer and castrate-resistant prostate cancer. So castrate-sensitive prostate cancer is the point at which the hormone or the cancer cells, still respond to hormonal therapy. Then castrate-resistant prostate cancer is, despite the hormonal therapy, the cancer still progresses. So definitely, like I mentioned here, there's no clear definition from guidelines what metastatic hormone sensitive prostate cancer is, but it definitely means that your cancer or the cancer of the patient still responds to hormonal therapy as it were. Castrate-resistant prostate cancer is a bit different. You give hormonal therapy, that's ADT in this case, and then the cancer progresses. And then what you will find in our setting is that informs your decision to add another medication. So let's look a bit at the management, or just the snapshot of the management of metastatic castrate-sensitive prostate cancer. We look at the guidelines. The NCCN guidelines have been referenced here a couple of times, I noticed. But basically, long story short, the NCCN guidelines recommend combination therapy. So basically, for sub-Saharan Africa, as we see patients with prostate cancer, it's imperative that when they come to us and they have been identified as metastatic disease patients, that they are given combination therapy. So it's a combination of ADT, and ADT, in this case, certainly for the physicians here would refer to goserelin, right? And that's a combination of goserelin and either apalutamide, abiraterone, docetaxel, and enzalutamide. So those are the recommendations as per the NCCN guidelines. Now, that's what the guidelines say, but what does the real world data say, or what does at least at this point, what does the clinical trial data say? So basically what this particular systematic review actually, because that's what it is, it took 10 randomized controlled trials, right? All of which evaluated combination therapies against ADT, right? And out of the 10, we had a total of 2,843 patients, right? And for those 10 trials, 3 out of those trials examined the combination therapy that involved ADT and docetaxel. Another 3 involved ADT and enzalutamide. Another 2 involved ADT and abiraterone. Another 2 involved ADT and radiotherapy, and 1 each for ADT, apalutamide, ADT, docetaxel, and darolutamide. Now, important to note that this was to compare to ADT alone. So they're comparing combination therapies to ADT alone. Now, when they looked at overall survival, what did they see? They said, look, for the patients who have been placed on these combination therapies, and when you compare them to patients who have been placed only on ADT, right, they found that at least for the docetaxel ADT arm, that these patients received, as per the treatment, received relevant survival benefit of high certainty. So definitely they were going to survive for long, or they were going to stay alive for much longer, basically. Now, for the patients who were on the ADT and abiraterone arm, they received survival benefit of moderate certainty. The same high certainty, or the same survival benefit of high certainty, the same survival benefit of high certainty also applied to the ADT and apalutamide arms, as well as the ADT, docetaxel, darolutamide arms. Only a combination therapy involving ADT and enzalutamide provided relevant survival benefit of low certainty. Now, that's for the survival, right? So that's how long the patient can stay alive on the medication. Now, when you move to the health-related quality of life, basically for short, quality of life, so the ability to walk around, talk around, live normal lives without any necessary interruptions, what did they find was the combination therapy that provided the most benefit? They found that for a combination therapy that included ADT and abiraterone, the patients had or enjoyed a better quality of life for up to 24 months after the initiation of treatment. So when they were followed up for 24 months, that's 2 years, they still enjoyed a relatively wonderful quality of life. Now, when you compare that to the other combination therapies, didn't do so well. The combination of ADT and docetaxel, maybe, of course, because chemotherapy is what it is, will pertain or will provide, or you'll find that there's a relatively lower level of quote-unquote quality of life. But certainly for the rest of the other combination therapies, so ADT and enzalutamide, ADT and apalutamide, and ADT and radiotherapy, there was no conferred quality of life benefit. And now benefit harm assessment is basically them saying, you know what, the good, the bad, which one is a net positive, which one is a net negative. So because every medication has benefits and has side effects, and when they looked at the combination therapies across board, which one had a net positive and which one had a net negative. Now, ADT and abiraterone had a 60% net positive. That also applied to ADT and enzalutamide as well as apalutamide. ADT, docetaxel, and ADT, docetaxel, and darolutamide appeared unlikely to be beneficial, when regards to benefit harm assessment. So what's the takeaway here? That when you look at all of those parameters, so overall survival, which obviously matters to anybody who is a cancer patient or who is a relative of a cancer or who knows a cancer patient, give or take, overall survival, health-related quality of life, so the ability to do what you and I are standing here doing, talking, and then aspiring to go for lunch after, and also a net positive negative effect that it was the androgen receptor axis targeted therapies in combination with ADT that did the trick. So what are they saying, or what's the take home from here? It's the combination therapy that does the job, right? As opposed to using ADT as a monotherapy. Now, we'll zoom into the evidence for abiraterone. Now, what's abiraterone? Basically, it's a novel hormonal therapy that works by inhibiting the CYP17 enzyme complex, right? And just I'll spare you the details about that and just jump right into the study design or the control trial or the the clinical trial, obviously that speaks to abiraterone benefit, right, in managing patients with hormone-sensitive prostate cancer. Now, Latitude design, so basically they had two cohorts of patients. So one cohort of patients received ADT, right, and dare I say that it is actually very rampant in clinical practice that for patients who are newly diagnosed metastatic hormone-sensitive prostate cancer patients, you'd find some physicians, right, prescribing only ADT. So they took this particular set of patients who are under these physicians on one arm, and then they took the other set of patients, and then they gave them a combination of ADT and abiraterone, then followed them for a while, for about 6 years, give or take. Now, what they found was that for the arm, that's for the cohort that received only ADT, so that received only hormonal, inhibitive therapy, as it were, the average patient survived for about 35 months. So that's give or take under 3 years, right? Under 3 years, the average patient would have died if they were taking only ADT. But for the patients, and I'll show the graph that speaks to that, for the patients who were taking a combination of ADT and abiraterone, they were able to live for a grand total of 51 months. Now, that data obviously was not reached here, but on an average, 51 months is give or take 6 years. And when you do the math, 3 years, right, on ADT alone, and then almost 6 years when you do combination therapy. I mean, if I'm asked the question, I think it speaks volumes, right, of that, it speaks volumes in favor of that approach. Now, when you look at the radiographic progression-free survival, so that's long story for how many new metastatic sites, right, that you would find in these patients. So they found out also that if you were taking only ADT, if all you received was ADT, in a matter of a year, you're going to have, or in just above a year, you are going to have new metastatic sites, right? And if you were receiving a combination of ADT and abiraterone, in about 3 years, it will take about 3 years, so give or take 2 more years, if you do the math, for you to have new metastatic sites. Now, when you have new metastatic sites, basically, and obviously because there's a predilection of prostate cancer for bone, right? If you have, you definitely end up with complications like pathological fractures, right? And then severe or excruciating bone pain, all of which can limit beautiful people from sitting down in the hall like this. And that's really another point that speaks to the improved or the superiority of combination therapy as opposed to monotherapy in managing patients with hormone-sensitive prostate cancer. Now, we jump right into castrate-resistant prostate cancer. So basically, the point where patient isn't responding to ADT alone, right? And then you have to some sort of double up. Here it's when your hand is a bit forced, So basically, what did the guidelines say? I still took out the time to reference the NCCN guidelines. And what did they say? So basically, once the patient has been diagnosed as castrate-resistant, and of course in this setting would have metastasis, it's really a lot of things to consider, ranging from docetaxel to abiraterone to, not apalutamide, sorry, but cyclophosphamide T and radiotherapy as well. Now, here's a very interesting one, I'd say. So, as opposed to the other ones, which were, and I remember the study I quoted like a few moments earlier that spoke to a systematic review. Here, they basically looked at real-world data, right? So they took about, and just let me count, so about 3,000 patients over a time span of 3 years. And then they said, you know what? Let's see. The patients that received abiraterone, right? These are castrate-resistant patients, of course. So the patients that received abiraterone, the patients that received docetaxel, and the patients that received enzalutamide. Which one of these sets of patients did better in terms of overall survival and time to progression? So, give or take, right? When they examined all 3 cohorts, so the cohorts with the abiraterone cohorts, the enzalutamide and docetaxel cohort, they found that on average, look, these people had similar median overall survival. So they lived on average, or the average patient in this cohort lived for about 28 months. So give or take, we're bordering on the year and a half or 2 years and a half, apologies. But there's a particular nuance here that I'd like to bring to our attention. So what they also found out was that in subsets of patients, so they looked at patients